Hi guys, welcome to the pulmonology section, and I'll begin by hitting the nail on the head that we'll first talk about ABG analysis. And I want to say that if technicians are able to analyze, so obviously you and me can do a better job. So in these questions, what they'll do is jumble up the data, but anytime they give you a question on ABG analysis, first always check out the pH. Normal value know is 7.35 to 7.45. Then check out the PCO2. Normal is in a range of 35 to 45 millimeter of mercury, and bicarbonate values are a range of 22 to 26. So they might be given in a jumbled fashion, but what you need to do is follow this algorithm always. Now, rule number one to be followed is, if they give you a question in which pH and PCO2 are going in same direction, like at the moment what I've shown is that both are becoming less and less, but you don't need to focus on the less part. You need to focus that mathematically speaking the arrows are going in same direction. So you will say that I'm dealing with a metabolic problem. I will give you the chemistry rationale for each one of them, but at the moment the logic or the rule to be followed is that if pH and PCO2 go in same direction, you say it's a metabolic problem. Now to say whether it is acidosis or alkalosis, you have to check out the bicarbonate value, and if it is less than 22 millicoulombs, then our interpretation is that this patient is having metabolic acidosis. Let's do this again. Suppose they give me a question in the paper where pH and PCO2 are going in same direction. Again, you can see that both arrows are going more than normal, but I am just focusing on the word same direction, and therefore my first interpretation is that this is a metabolic problem. And if the bicarbonate values of the patient are also elevated, that means that the chap is suffering from metabolic alkalosis. So the rule to be followed is always check out pH and PCO2 directions. Now I will slightly change the rule. So pay more attention than what you're doing at the moment. From the mathematical perspective, one arrow is going down, the other one is going up, because the direction of change of pH and PCO2 is opposite. The word is opposite. So you will say that the patient is suffering from a respiratory problem. Now to say whether it is a respiratory acidosis or alkalosis, you don't need to even check out the bicarbonate. Don't even give a damn to the value of bicarbonate. Just check out the pH. No, the pH is less. So you will say that the patient is suffering from respiratory acidosis. So the bottom line is that when it comes to a respiratory problem, it is ultra easy that you don't need to even check out the bicarbonate values in the question. Though for the sake of completion, I'm putting a arrow and a mathematical value to bicarbonate. Even if you don't check it out, if you just focus on the fact that pH is less, it has to be respiratory acidosis. And our rationale that I can say at the moment is carbon dioxide is an acidic molecule. Carbon dioxide combines with water to form carbonic acid, and that carbonic acid component would contribute to a respiratory acidosis. Let's do it once again. This time what I'm saying is that pH is more and PCO2 is less. So again, you can see that the arrows are going opposite. If the arrows are going in opposite direction, so I will once again say patient is having a respiratory problem. And now you don't need to even look at the bicarbonate in a respiratory problem. Just check out the pH. It is like super simple, guys. If pH is elevated, that means that the patient is having a respiratory alkalosis. So at the moment, what I've tried to mention is the baseline rule, which helps you analyze the data. And what I've also done is given a mathematical value for bicarbonate, but it really does not matter. All you need to check out is the pH values at the moment. And to help you remember this, I can give a basic rule. The basic rule is called as ROME, that is ROME. That's like a mnemonic which helps you remember this data. ROME goes like this: in a respiratory problem, the pH and PCO2 will always go in opposite direction, as you can see, as I had shown at the moment to you. In contrast, when it comes to a metabolic problem in a patient, you can notice that the arrows are going in same direction, that is equivalent direction. So ROME is a mnemonic where like you can help in, this can help you in analyzing the ABG for starters. It will help you determine what is called as the primary change. In respiratory, it is opposite directions. In metabolic, it is the equivalent direction. And now we will try to analyze on the basis of this report couple of technical informations. Miscellaneous data at the moment, extracellular buffer is obviously bicarbonate. I mean, that's what we call as the buffer base. But if he says the word intracellular, a bit of physiology, then you will answer as phosphate. And then also making your life easier will be aldosterone has an inverse relation with potassium. I've described this in the respiratory section, and I have currently described it in respiratory, and I've described in even in the endocrine section that pH and potassium have an inverse relation, and aldosterone and potassium have an inverse relation. I'll just quickly run through this. You see there's a channel with the name of epithelial sodium channel. Though I've discussed in endocrine, some people might have skipped endocrine, come directly here. So just for the benefit of that, I mean, one of the basic functions of aldosterone is gain of salt and water, but you can also see that it is responsible for urinary loss of potassium as well as hydrogen. So if aldosterone will rise in the body, then what it will cause is a urinary loss of potassium, that is kaliuria. That explains the inverse relation. And then another statement is pH as an inverse relation with potassium. That will make your life a little easier as far as attempting these questions is concerned. So anytime they give you an ABG report, first you have to analyze what is the primary change. And when it comes to compensation, for compensation, the rule is very simple. Just invert English. Suppose I ask you what is compensation of metabolic acidosis, use English and say respiratory alkalosis. Suppose I ask you what is compensation of respiratory acidosis, say it is metabolic alkalosis. So instead of R replaced by M, it's acidosis replaced by alkalosis. Just invert the data for compensation. Working with compensation, guys, is never gonna be a challenge for you, because in compensation you just need to invert the information whatever is provided to you. Though there is a chemistry equation or chemistry rationale behind it, which I'll quickly mention. You see, carbon dioxide combines with water to form carbonic acid. That is why I was saying that carbon dioxide is a acidic molecule. So therefore, once carbonic acid is formed, you would have generation of protons, you will have generation of bicarbonate. And now let me say I have a patient in my hospital who's an asthmatic. The attack is so bad that he's deteriorating into status asthmaticus, and the person is having a silent chest. If a person will be having a silent chest, what will happen is that carbon dioxide will accumulate in the body. Or you can take another example, acute exacerbation of chronic bronchitis, hot favorite of your examiner. When carbon dioxide will accumulate in the body, it will combine with water to form carbonic acid, and carbonic acid will then be forming protons. And if protons are going to be forming, then pH of the patient will begin to reduce. If you just check out the information that I provided here, just look at the direction of arrows. CO2 is rising and pH of the patient is becoming lesser. You can see that it's a respiratory case, no silent chest as said. So it's a respiratory case, and carbon dioxide and pH are going in opposite direction. That is why I said in Rome mnemonic, respiratory problem, CO2 and pH, they go in opposite direction. So it has a chemistry basis. And at the same time, I also want to say now that when the pH will begin to fall, the body will begin to fight back. This fight back of the human body, because human body is a big fighter, this fight back of the body is what is called as compensation, and the compensation always works in a direction opposite to the primary change. So let's look at who will help in compensation, and the compensation organ would be kidney. You can remember lungs and kidney are like two buddies. When lung has a problem, the kidneys help. If kidneys have a problem, the lungs are going to help. So now the lungs are, asking the brain that please send some help. And the brain says, okay, man, I'll ask the kidney. And the kidney says, okay, buddy, I'm ready to help you. So how will the kidney help? You see, in our proximal converted tubule, you have is presence of ultrafiltrate. This ultrafiltrate contains a lot of electrolytes like, bicarbonate, phosphate. So what the kidney will do is that from the ultrafiltrate, it will upgrade the bicarbonate reabsorption. You see, in our ultrafiltrate, there is like fluid, there is electrolytes present. So the kidney will say, okay, buddy, I'll help you. And the kidney will upgrade the bicarbonate reabsorption. And because there is an upgrade, support plus to here to say that bicarbonate will begin to rise. Now, when bicarbonate will begin to rise, I'll say the following word, metabolic. I'm writing the word metabolic because kidney is helping. Lungs were having a problem. Now kidney is helping. And the kidney is doing what? It is raising bicarbonate. It's raising bicarbonate. So when you raise bicarbonate, you say it is metabolic alkalosis. So you can see that my patient was having a primary change of respiratory acidosis. You could see that ultimately protons were being generated, and respiratory acidosis, if I just use English and invert the data, it becomes metabolic alkalosis. So compensation workout will never be a challenge, guys. I mean, it's a piece of cake. Compensation is just implying English. All you need to apply is what is the primary change in the patient, and how to work out the primary changes. This table that I basically mentioned before you. So I would just like to mention the fact here that this table is basically used in the ABG analysis to find the primary change, and then you evaluate the compensation, which is just deploying English there. Now let's try some mathematical examples, and that will make it relatively easier for you. Before I do that, I also want to say a procedural aspect, which is modified Allen's test. The question was very straightforward. Modified Allen's test is done for, the answer is it is done to check for the integrity of the palmar arch. You see, you are putting a needle in an artery. So artery is bound to undergo a spasm. Now, because there can be a spasm, there can can be a distal gangrene also. Like if I put a needle in the radial artery, metallic needle, and the artery will undergo protective spasm, so they can be a development of distal gangrene. But that does not happen. Why? Because what you and me have is a palmar arch, that is, this is radial artery, this is ulnar artery, and then we have is a very good collateral circulation between the two. And this collateral circulation will ensure that even if the radial artery will undergo a spasm, mark my words there, even if the radial artery will undergo a spasm, the ulnar artery will still manage the blood flow, and therefore you are not going to get a distal gangrene in a patient. You take the sample from the radial artery of the patient. I said artery will undergo spasm, but ulnar artery se to blood aata rahega na, so the chances of distal gangrene are almost negligible. To check for the integrity of the palmar arch, I can do a handheld Doppler, but because that's usually not available in India, so a test that we can do is called as modified Allen's test. In modified Allen's test, you will occlude both the arteries. If you occlude both the arteries, radial artery as well as the ulnar artery, you will get pallor in the hand, and then you release each of these arteries one by hand, and you get a flush of the palm of the patient. In fact, he has just simply asked, why do you do a modified Allen's test? It is for the integrity of the palmar arch before doing ABG, and the rationale is that you don't want a distal gangrene. So if there is an integrity of the palmar arch, that means there is a good collateral circulation. The meaning of the word integrity of the palmar arch is good collateral circulation. Now let us apply these rules here. So in the question that you can see, scenario 1, I will first look at pH, then look at PCO2, and pH is less than normal, and PCO2 is also less than normal. PCO2 is 35 to 45, pH is 7.35 to 45. So because both the arrows are going in same direction, so I will say my patient is having a metabolic problem. Now in this patient, I'll check the value of bicarbonate. The bicarbonate value is also lesser. So this question would mean that the person is having metabolic acidosis, pretty straightforward, because all the three arrows were going down, down, down. And that is what I had represented. Even in the first entry that I made before you in this video, that is pH, PCO2 and bicarbonate are going in same direction. So this is the primary change. Now I have to answer whether compensation is there or not. For me to find out whether compensation is present or is not present, because sometimes the person can be having mixed disorder also. So I'll give you two examples. The first one that I'm dealing with is compensation. To know whether compensation is working or not, there is a mathematical rule. This mathematical rule is called as Winter's formula. And instead of using the word Winter's formula, you can also use modified Winter's formula. In fact, in my opinion, because in the exam you have limited time at your disposal, I would recommend you to use modified Winter's formula, because this would be having is a one-step addition. Whereas when it comes to the traditional Winter's formula, I'll write the traditional Winter's formula also. It is 1.5 into the value of bicarbonate. Then to this you have to add 8, and then is plus minus 2. So in my personally I was a very bad student in mathematics, so do a multiplication, then addition, then a plus minus subtraction. It's a bit of a challenge or a hassle. So the simple way is use a modified Winter's formula, and this modified Winter formula is bicarbonate plus 15. Whatever is the bicarbonate given in the question, like in this question bicarbonate given is 10, and to this I need to add 15, and the value will come as 25 millimeters. This is gonna be matching with the actual PCO2. So what we are doing in modified Winter's formula is that we are calculating what is called as expected PCO2. If the expected PCO2 and the actual PCO2 are matching, that is meaning that compensation is present. Our body operates by strict mathematical rules. Our body operates by strict mathematical rules. So because the expected PCO2 of this question and the actual PCO2 which is present in this question, both are equal, this means compensation is working. And now I will say that the person is having a compensation of metabolic acidosis, that is respiratory alkalosis. The message here is that before you say the word compensation, what are you supposed to do in next 10 seconds is apply this mathematical formula. What is the formula? You need to add 15 to whatever is the given bicarbonate in the question. Suppose in this question is 10, then you add 10 plus 15, that is 25. And because both values are matching, that means compensation is working in this patient. I mean, because you could be having patients who are having mixed disorders as well. Before I give you that mixed disorder, I know you are gunning for that, sir, wo mixed disorder batao na. That I'll just say that mathematical rules have to be satisfied before you say compensation or before you say a mixed disorder. If this rule is not satisfied, we'll say a mixed disorder. So at the moment, the answer in this question is metabolic acidosis with compensatory respiratory alkalosis. Now another term which could be used in MCQs to describe this entire presentation is called as partially compensated metabolic acidosis. Both of these statements that I mentioned here before you, metabolic acidosis with compensatory respiratory alkalosis, or the word partially compensated metabolic acidosis, they both mean the same. It's just different use of English vocabulary which can result in, like, difference of opinion कि ये अलग अलग बातें होती है, but no, they're not different, guys. They both mean the same. So at the moment, what you've learned is, before you apply or say compensation, you have to apply this mathematical formula. And now I'll come to the second example, for which I'll first go into a bit of like description, and then I want you to focus on the mathematics. Let us assume that in the hospital right now, there was like a code blue happening, and a patient has unfortunately collapsed. There is a cardiorespiratory arrest that has occurred in this old person admitted to the casualty. Now, if a person will go into cardiorespiratory arrest, you can understand, if the heart will not be working, then there would be under perfusion of the tissues. The blood supply to the tissues would become relatively less. If the cells don't get oxygen, they switch to anaerobic mode of respiration. If you don't provide oxygen to the tissues, they switch to anaerobic mode of respiration. So in this person, there would be a lactic acid accumulation happening, which will result in metabolic acidosis. So even if I don't go to approach the question mathematically, anytime there's a question on like under perfusion of tissues or a cardiac arrest, I'll say a person will go into metabolic acidosis. Rationale in front of you, under perfusion of tissues means no oxygen available, and therefore the body will start developing lactic acid, metabolic acidosis. Now, can you tell me the compensation of metabolic acidosis? Yes, it is respiratory alkalosis. But if you check this out, person is having respiratory arrest. If a person will be having cardiorespiratory arrest, then he cannot compensate. Guys, you and me are alive, we are breathing, we can compensate. A guy with respiratory arrest cannot compensate. So what will happen in his body is carbon dioxide will start rising because he's not breathing. And I told you now that carbon dioxide is an acidic molecule, so it will start generating protons, and the protons will cause the pH to fall. So I can say the word respiratory because lungs are the ones that I'm talking about, and because protons are being generated, the patient is having respiratory acidosis. So you can see that a patient is having two types of acidosis at the moment. He's having metabolic acidosis also, and he's having respiratory acidosis also. So one, I just wanted to tell you that sometimes there can be a mixed disorder occurring in a patient where two types of acidosis can be present. Cardiorespiratory arrest, if written in a question, by default it becomes a mixed disorder even if you don't apply the mathematics. Though I'll apply the mathematics part also, what I want to tell you is that if they give you a question which is specifically focusing on cardiorespiratory arrest in a patient, that's the information that you can see at the moment, then by default, because a lot of these questions would have clinical information also provided, no? So cardiorespiratory arrest is a by default a situation where you don't need to say any compensation, don't need to apply mathematics, but let's do it here. And this was what was asked in NEET PG. He did not give a clinical scenario, he just mentioned, and this is one of the common errors also the students did in the paper. So let me explain this. The pH is less and the PCO2 of the patient is also less. So because both the arrows are going in same direction, you can check out that pH is less and PCO2 is also less. So because both the arrows are going in same direction, so I will write the first word metabolic, and then I will check out the bicarbonate value. Bicarbonate is also less. So obviously this is a case of metabolic acidosis as I explained to you. Now we need to check out whether compensation is working or is not working. So what we will do is, even in this question, we'll apply this mathematical rule of expected PCO2. Expected PCO2 is bicarbonate plus 15. In this question, bicarbonate is 10. So I'll add 15 to that, it will become 25. Whereas the actual PCO2 of the patient is 30 millimeter of mercury. So what you can notice is that the two values are not matching. The PCO2 value is higher than the value of what is expected. Why it is higher is because diaphragm is not working properly. So as a result of this, what I can say is that this question is because the mathematical rule is not getting satisfied. So I will not write the word compensation. In the previous situation, mathematical rule of expected and actual values were matching 25 for the previous question, as you can see. So because the match was happening, that is why we were saying, okay man, we are dealing with compensation. But in this question, which is given without a history, then you will say that this is a mixed disorder. In this mixed disorder, the person is having two types of acidosis, metabolic acidosis as well as respiratory acidosis. Had I not mentioned the example of cardiorespiratory arrest, the query of most people is, sir, how is it possible? No two types of acidosis in a patient. But now I think it is very clear that if the person is dying, then diaphragm will not be able to offer a compensation chance, and therefore the CO2 of the patient will be higher than what it should be. be. In fact, in the MCQ, he made it a little more tricky. So when you will do these apps, he will say, what is the reason for this report? The answer is hypoventilation causing a decreased CO2 washout. In fact, this had I not explained, the query of lot of students is, sir, respiratory acidosis में तो PCO2 should be more than 45. You are saying respiratory acidosis at PCO2 30. Yes, guys, because this is mathematical interpretation. What is happening in this patient is that the diaphragm is not being able to do its job. In metabolic acidosis cases, we always have small breathing. We always have a hyperventilation that causes a carbon dioxide washout. But that washout that is happening is not good enough. It is not adequate enough because I said our body follows mathematical rules. So it should have brought down the PCO2 of this patient to 25, but that 25 value did not happen. It is still 30. That means it is not like being able to compensate. And that's where the word is mixed disorder, which is metabolic and respiratory acidosis. So if mathematics is not your cup of tea and you say, sir, I am not very good at mathematics, that is why I became a doctor. I became a doctor because my maths was bad. So then like you have to follow the English interpretation or cardiorespiratory arrest if it is given. Otherwise, like in NEET PG, I think deliberately did not give the scenario. We just gave this report and you have to work out that this is a mixed disorder. And once again, I emphasize, why am I calling it respiratory acidosis? Is one, mathematics is not being followed. Second is the diaphragm is not being able to bring down the PCO2, follow the mathematical rule of 25. That should have been the workout. So the final message before I move on to scenario number 1.2 is that always apply modified Winters formula. Always by default apply modified Winters formula. That is, I'll just do it once again quickly. Add 15 to the value of bicarbonate that is given and check out whether the output matches with that of PCO2 value. If the values are matching, perfect. But if the values are higher, that means follow the English word. If the values turn out to be higher, you will say, no, the compensation has not worked adequate enough and there is a mixed disorder that is occurring because of hypoventilation. Reasons could be multiple. Diaphragm not working, electrolyte imbalances. I mean, I gave one scenario, but it could also be a possibility of like a person having hypokalemia due to which diaphragm did not work effectively. Electrolyte imbalances would be fairly common in critically sick patients. And now we are in a good position to discuss the next question. Now coming to the next question, the pH of the patient is less, the PCO2 is also less, and bicarbonate is also less. So all the three arrows are going in same direction. So I think this is a piece of cake for you till now. This is metabolic acidosis, easy and simple to interpret. Now what you will do is apply the modified Winters formula in which the expected PCO2, how do you calculate is you add 15 to the value of bicarbonate. So the bicarbonate value in this question is 6, and to this if I add 15 mathematically, then the expected PCO to the patient should be 21 millimeter of mercury. Whereas in this particular question, if you check out the actual PCO2, the actual PCO2 is 16. Now you will say that both the values are not matching. Agreed, both values are not matching. But in this particular patient, rather I can say that the patient's diaphragm has warmed exceptionally well. You see, metabolic acidosis causes small breathing. Small breathing should cause a carbon dioxide washout. So in this particular case, what has happened is that the diaphragm has worked very exceptionally good. And because of the exceptional good work of the diaphragm, the expected PCO2 has become lesser than what was expected. So this means the diaphragm is working. So the answer in this particular patient would be metabolic acidosis with compensated, I'm saying the word compensated respiratory alkalosis, or I can also use the word partially compensated metabolic acidosis. Guys, in this condition, the values are not matching. So the query of lot of students is, sir, abhi to aap bole the, if the values are not matching, you answer it as a mixed disorder. Now you are saying that this is compensated. So I want you to look at the mathematical relation here. Now only no MBBS, only maths. See, in the question, what is happening is that if you check out the 1.1 scenario, which is a common error, the PCO2 value of the patient, the 30 value is more than what you had calculated. That was 25. That means diaphragm is not working enough. That is why I wrote the word hypoventilation. But if you focus on the inferior report, I can say diaphragm has worked more than normal. That is good news ना भाई. Diaphragm अगर ज़्यादा काम करता है, suppose आप ज़्यादा मेहनत करते हो, आप ज़्यादा पढ़ाई करते हो, तो it is good ना. If you study less, that is a problem. So superiorly, I'm saying if somebody has studied less, in a relative sense, diaphragm has not worked well, problem, meta. That is why I said mixed problem. But when it comes to the inferior one, I said that the diaphragm has studied more than normal, has worked more than normal. So this would be still a compensation. So don't go by only mathematics ki sir matching ho raha tha ya nahi ho raha tha. If matching is happening, perfect. This is the easiest example that you need to understand. Scenario number 1 is what is asked in FMG exam. when you will attempt NEET PG, if you are a NEET PG aspirant, if you are an innocent aspirant, then it is that this slide is of paramount. This is the slide which is should be interesting you guys. So I'll repeat this again. If you're an FMG student, ये वाला slide आप skip भी कर दो तो चलेगा, no problems with that. But if you're a NEET PG aspirant, then this is inexcusable. Sir, इसको आपको करना ही करना है, which is to understand that if the values are higher than what you have calculated, that means compensation did not happen. Your diaphragm ठीक से मेहनत नहीं किया, did not did a sufficient amount of hard work. But if diaphragm is working or is working more than normal, I'm happy. Now work more is what we want. That's why we improve our scores also. So finally, what I've mentioned before, you are two very hardcore questions related to ABG analysis which are to be focused upon. And like if you had any issues understanding, you can use the Hindi version of the same as well. But in my opinion, it's pretty straightforward. It's a bit of application of mathematics and will help your life. I mean, this should make your life relatively easier. And now let's go to the next scenario, which is acute exacerbation of chronic bronchitis. Again, a hot favorite of our examiner. The pH in this particular case is less and PCO2 is elevated. So because the arrows are going in opposite direction, I will say that the person is having a respiratory problem. In respiratory problem, you don't need to even check out the value of bicarbonate. Though bicarbonate values have been given here, at the moment I can say that the patient is having respiratory acidosis. So the question will be very straightforward. What is the interpretation in this condition? You will say that this is respiratory acidosis occurring in a patient. Now, whether to check out compensation or not, I'll just write that chemistry equation once again in front of you, that if a person is having, like if you, though I mentioned this chemistry equation earlier also, like I mentioned CO2 and I had given respiratory acidosis scenario, let's just do this quickly once again so that this becomes second nature to us. Bicarbonate is going to be generated here. It's going to be protons and HCO3 as explained to you. Carbon dioxide will rise, so there would be more H2CO3, more protons, and when protons will be more, then bicarbonate will rise now, thanks to the kidney. Remember, kidney was saying, okay bro, I will help you, and bicarbonate will rise. For respiratory acidosis, you need to remember 10:1 rule. 10:1 rule is that for every 10-point rise of carbon dioxide, bicarbonate rises by 1 milliequivalent. How do you calculate compensation in a question of respiratory acidosis is what I'm teaching you at the moment. The method of calculating compensation for metabolic acidosis was that you have to add 15 to the value of whatever bicarbonate that is given and compare with the actual and the expected PCO2. Here the rule is for every 10-point rise of carbon dioxide, the bicarbonate should be rising by 1 milliequivalent. Now, again, we do mathematics. Let us take an average of PCO2 of 40. Normal is 35 to 45. We can take an average of 40. The value has increased from 40 to 60. That's an increment of how many points? 20 points. Now, mathematics. If carbon dioxide will rise by 20 points, then bicarbonate will rise by 2 points. Remember, the normal value of bicarbonate is 22 to 26. You can see that here the value has increased by only 2 points, but the mathematical rule is being satisfied. Like I'll say the maths once again. Average PCO2 is 40. From 40 to 60 is a 20-point jump. So for 20-point hike in carbon dioxide, the body is causing bicarbonate to rise by 2 milliequivalents. That has happened in this case. So once again, I can say that compensation has been successful. And because compensation is successful, I will now write down the compensation of respiratory acidosis, that is metabolic alkalosis. So your answer in this question is patient is having respiratory acidosis with metabolic alkalosis. This rule has to be satisfied, guys. Only then we can say compensation is working, or the other English version of the same can be partially compensated. The same thing can be written as partially compensated respiratory acidosis also. The final learning point is all patients of metabolic acidosis will start doing small breathing, and all patients of respiratory acidosis will start having bicarbonate values rising in the body. Let me just write it here. In a question of metabolic acidosis and respiratory acidosis, what are you supposed to see for compensation is what I'm revising at the moment. In a metabolic, इतना तो निकाल लोगे ना, metabolic acidosis है, pH is less, PCO2 is also less, and both are going in same direction. So metabolic acidosis rule is being followed. In metabolic acidosis, all you need to check out is what is happening to the status of carbon dioxide in the body of this patient. Is the carbon dioxide of the body beginning to come down? Because remember, in metabolic acidosis, in fact, I can write one more statement. Metabolic acidosis will always, like, protons will stimulate the respiratory center. If the protons will cause stimulation of respiratory center, it will contribute to washout of carbon dioxide, and due to washout of carbon dioxide, there would be a respiratory alkalosis developing in a question. So patients of metabolic acidosis will develop respiratory alkalosis as compensation. But before you say that compensation happening, apply that rule. If the rule is satisfied, you say matching values, you say compensation. If the value is higher, then you will say that it is a mixed disorder. In contrast, in respiratory acidosis question, what you have to understand is that there is a buildup of carbon dioxide accumulating in the body of this patient, and because the carbon dioxide will rise in the body, because there is a carbon dioxide accumulation occurring in this patient, protons are being generated, so bicarbonate values in the body should be exhibiting a rise. This rise of bicarbonate is what is shown here. That is the 10:1 rule that is to be satisfied for saying that okay, I'm dealing with a compensation of respiratory acidosis, that is metabolic alkalosis. Let's just quickly summarize this in 15 seconds once again. In a metabolic acidosis problem, there is stimulation of respiratory center, carbon dioxide washout, that is small breathing happening in a person. If that mathematical values match, you say, okay, man, this is compensation. If they don't match and the value is higher, that means diaphragm did not do its job properly, and that's why I said it's a mixed disorder. For respiratory acidosis, 10:1 rule satisfied, then you say it is compensation working. If not, then even in this condition, they can be mixed disorder. But thankfully, like he'll usually ask you the scenario of acute exacerbation of chronic bronchitis, hot favorite of our examiner. And now sometimes it can be a two-step question. He may not ask you the interpretation. He might say that what is going to be the treatment of this patient of acute exacerbation of chronic bronchitis. So you will be asking your nurse to help you out with asking the technician to get the BiPAP machine. You will be putting the patient on what is called as NIV, that is non-invasive ventilation. So you will request your nurse that ma'am, please get me a BiPAP machine, and you will be putting a tight fitting face mask, and you'll be ventilating this patient with NIV to remove extra carbon dioxide from the body, because that extra carbon dioxide is the troublemaker and is contributing to generation of protons. When do you use non-invasive ventilation? The following scenarios are A, B, C. A stands for acute pulmonary edema. I've described that in the cardiology section, that we use like BiPAP for management of patients of or NIV, non-invasive ventilation. Both mean the same for management of acute pulmonary edema. Alphabet B would be for the topic of interest, that is acute exacerbation of chronic bronchitis. He may not write the word chronic bronchitis, he may write the word COPD, but then most of the time COPD patients will be having a substantial component of chronic bronchitis. And the exacerbation, the reason for that can be like a viral infection, or like in the winter season, the patient is having a viral infection. So acute exacerbation of chronic bronchitis could be like the reason why you put the patient on NIV to remove extra carbon dioxide from the body. And I'm very sure that you guys, when you started your MBBS, that is when COVID happened. So in COVID-19 pneumonia, we were grading the patients as having mild pneumonia, moderate pneumonia, severe pneumonia. So for those patients who are having severe pneumonia with COVID-19, we were again putting the patients on NIV, that is non-invasive ventilation. So ABC is a mnemonic that helps you remember that what are the reasons why you go ahead with like patients to be ventilated with non-invasive ventilation. A is acute pulmonary edema, B is for the chronic bronchitis exacerbation, and C is for the COVID-19 pneumonia, because ultimately COVID-19 pneumonia will go into ARDS, and ARDS is a topic I'll be discussing separately as well. We'll discuss what Berlin's criteria, but this is like pure hardcore information that is required. I'll repeat once again, if you're an FMG student, you can skip the slide scenario 1.1 and 1.2. You need to remember only 1 and then 2. But if you're a NEET PG aspirant, then obviously like the entire data is of use to you guys, including this aspect of how compensation works. Now, coming to the next question of scenario 3, I'll obviously solve it mathematically, but I'm saying that every time you read COVID-19 or pneumonia, you know that the guy is doing fast breathing. Anybody doing fast breathing, if the respiratory rate of the person is more, there would be carbon dioxide washout. And when carbon dioxide washout will happen, then the proton production will become less. If protons are less, the pH will begin to rise. And you can see that arrows are again going opposite now. Like you can see that the pH of the patient is rising and the CO2 is falling. So arrows are opposite. So it's a respiratory problem and it is causing a respiratory alkalosis. Just to see you got me or not, I'll give a scenario which is not related to COVID-19. If I ask you, doctor, what will happen to person with anxiety neurosis? Like anxiety neurosis, people tend to get like anxious very soon. So in a person with anxiety or panic attacks, there would be hyperventilation. and that hyperventilation will cause a carbon dioxide washout from occurring in the body, and that will cause the same thing, that is respiratory alkalosis. So the message is, whether I say high altitude, person went to high altitude, had a pulmonary edema, then mountain sickness, again the respiratory alkalosis part will come. Any medical disorder where you get a fast breathing in a person is bound to be having a development of respiratory alkalosis. Now let's do it mathematically. pH is more and PCO2 of the patient is less. Arrows are going in opposite direction. So when I say opposite direction, the first word that it reduces that the person is having respiratory problem. I don't need to even look at the value of bicarbonate. The bicarbonate value is changing, that is okay. But at the moment it is just the pH that is elevated. So I will say that the person is having a respiratory alkalosis. And in this patient, I can also say the fact that bicarbonate is not normal. Now bicarbonate has started to change, because when there would be respiratory acidosis, bicarbonate changes, and when respiratory alkalosis also, it changes. I'm not going into mathematical rule here. Here the rule is called as 10:2 rule, that for 10 point decrease in the value of carbon dioxide, like from 40 to 30, there would be a 2-point decrease in the value of bicarbonate. Okay, let's just write it here so that you are able to remember this mathematical rule of 10:2. Earlier I was telling you the rule of 10:1 for respiratory acidosis, but for respiratory alkalosis of the acute variety, it is 10:2 rule, that for 10-point decrease in the value of carbon dioxide, the bicarbonate of the value should fall by 2 milliequivalent. So from 40 to 30, there's a 10-point decrease. You see, normal PCO2 in the body is 35 to 40. From 40 it is decreasing to 30, that's a 10-point decrease. And the bicarbonate normal value is 22 to 26. So it is decreasing to less than normal, that is 20 milliequivalents. So once again, in this case also compensation is working. So I will say this is a case of respiratory alkalosis with compensated. And what is the compensation? Apply English. Respiratory का उल्टा क्या होता है? Metabolic. And alkalosis क्या होता है? It is acidosis. So compensation workout is like a fraction of a second job. All you need to understand is that in metabolic alkalosis, whenever I'll describe metabolic alkalosis to you also. It is related to vomiting, but every time they give you a question of metabolic alkalosis, you have to apply again Winter's formula. In both metabolic acidosis and metabolic alkalosis, you have to remember Winter's formula, and for respiratory acidosis and alkalosis, you have to remember separate. That is 10:1 rule and 10:2 rule. 10:1 rule for acute respiratory acidosis, 10-point rise of carbon dioxide, 1-point rise of bicarbonate. For respiratory alkalosis, it is a 10:2 rule where I've described the compensation occurring. Coming to the next scenario, chronic vomiting in a congenital hypertrophic pyloric stenosis neonate. I think this is the most easy of among all of them, because when you say person is having vomiting on a long-term basis, there's going to be loss of acid from the body, and the loss of acid would imply that there would be a metabolic alkalosis occurring in a patient. Now let's work it out mathematically. The pH of the patient is more and the PCO2 of the patient is normal. So it's okay. I mean, even if the PCO2 is normal, I'll work out the Winter's formula also in front of you. But at the moment is PCO2 is normal, it's okay. But bicarbonate is still elevated now. What you have to understand is pH is more, so there is alkalosis. Alkalosis can be due to two reasons, either respiratory or metabolic. In respiratory, there should always be a PCO2 washout in a person. Like I showed to you, COVID-19 respiratory alkalosis, there should be a CO2 washout. In this case, there is no CO2 washout, so it can't be respiratory. So only one possibility is left, that this person is having metabolic alkalosis. I deliberately gave PCO2 normal in this question so that arrows going in same direction rule is not satisfied, but you should still be able to figure out that metabolic alkalosis is present here because alkali is more in the body. Now what we will do even in this case is apply the modified Winter's formula. Modified Winter's formula is expected PCO2. You have to add 15 to the value of bicarbonate. The bicarbonate value in this question is 30. So to 30, if you add 15, the value will turn out to be 45. And you can again get a match here. What I mean by getting a match here is that the expected PCO2 of the patient is equal to the actual PCO2 which is given in a question. Because the values are matching, you will say that this is a compensation process working. As I said earlier, and I'm repeating once again, compensation, whether it is present or not present in both metabolic acidosis and alkalosis, is calculated by the modified Winter's formula, which is bicarbonate plus value of 15. And because the values are matching in this case, so you will now use English and you will say, okay, the compensation is respiratory, ulta of metabolic, and instead of alkalosis, you will write the word acidosis. So this is metabolic alkalosis with compensatory respiratory acidosis. The question was given deliberately with the normal PCO2 to make you think from the perspective of mathematics and not blindly just follow the table, because any patient of alkalosis can be both respiratory and metabolic. In respiratory, there will always be a CO2 washout. In this case, there would be bicarbonate that is rising. So these are a couple of scenarios that I've currently explained to you for the ABG analysis. And the final summary I would like to give as follows. Whenever you are dealing with a question of metabolic acidosis, what are you supposed to check out in the question is the PCO2 value. If the PCO2 value of the patient is turning out to be falling, that is because the person would have small breathing, that means compensation is working in the patient. Compensation is working in the patient. In a question of metabolic alkalosis, in a patient of metabolic alkalosis, what should happen to PCO2 value is it should be exhibiting a rise. It should be exhibiting a rise opposite, no opposite of small breathing. I'm saying PCO2 value should be exhibiting a rise. In a person of respiratory acidosis, there is CO2 buildup in the body. What you are supposed to check out is the bicarbonate value. The bicarbonate value in this particular patient should be showing a rise, like the kidneys were causing a rise, and I mentioned the 10:1 rule before you. For respiratory alkalosis, that's the last entry. Again, what should happen is this time the bicarbonate value of the patient should be beginning to show a fall. If you had any issues in working this out, you need to listen to the discussion again, because every time they will give you a question from the perspective of NEET PG, you will have to figure out the data that I'm saying. Now for respiratory alkalosis and acidosis, the rules to be followed would be 10:1 rule and 10:2 rule. I'll say the 10:1 rule again. For 10-point rise of carbon dioxide, bicarbonate should rise by 1 point. In respiratory alkalosis, for every 10-point fall in carbon dioxide, the bicarbonate value should be falling by 2 points. Whereas in this particular case, in both of them, you just have to apply the Winter's formula. Winter's formula is that you need to see whether the match is happening or is not happening. If the match is happening, cool. Otherwise, like if these rules are not followed, you say mixed disorder. If these rules that I'm describing before you are not followed, then you will say that it is a mixed disorder. By Winter's formula, you calculate expected PCO2 and the expected value should match with the actual value as I've explained to you. So this is a summary for those changes that you have to remember with respect to how to apply the compensation. The word is Winter's formula for both of them. Then is the 10:1 rule and then is the 10:2 rule to work out the rules of compensation. Let's do another question. This was given in the INISET exam. The pH of the patient was normal. The PCO2 was normal. The bicarbonate was normal. So a lot of students said, sir, normal tha, to like everything is perfect, and that means like there is no ABG disorder, there's no like arterial blood gas anomaly present in a patient, and that normal report was also given in the MCQ. The hint in the question was that you have to calculate the anion gap in this particular case. If everything is normal, wo to theek hai, but you also have to calculate the anion gap. The anion gap in this question is the formula for anion gap is, you know from physiology, ki isme we subtract the negative charges from the positive charges. The positive charges are sodium. We don't take into consideration potassium, even if it is given in the question, and we subtract chloride and bicarbonate. So let's do some mathematics here. Sodium is 130. The chloride value given in the question is 80. Bicarbonate is 24. So the anion gap of this patient is 130 minus 104. This will work out to a high value of about 26 millicoulombs, which is higher than normal. Because the anion gap, normal anion gap kitna hota hai? So normal anion gap in a patient should be in a range of about 6 to 12 millicoulombs. Normal anion gap should be in a range of 6 to 12 millicoulombs. In this question, it is almost like, substantially elevated. So there's a high anion gap. That high anion gap tells me that this disorder or this ABG disorder is a marked disorder. What I mean by marked disorder is that there are some problems which are not coming from the mathematics perspective. At this, the query of a lot of students is, sir, what did you mean by marked disorder? So let me say chronic kidney disease present in a patient. For CKD, one of the baseline things is whenever kidney will not be functioning properly, there would be inability to excrete hydrogen as well as potassium. And if a person cannot excrete hydrogen, then there is bound to be metabolic acidosis. By default, all patients of kidney damage will be having metabolic acidosis. Now, because the person's kidney will fail, the kidney failure will cause uremia. The urea will irritate the stomach. Due to urea causing irritation of the stomach, in this person, there would be multiple episodes of vomiting also happening simultaneously. Because I said stomach is getting irritated, the person is having vomiting again and again. If person will have vomiting, then you can understand there is loss of acid. If you lose acid from the body, I said if a person will have uremia, the stomach will get irritated, there would be loss of acid. You guys help me out. If you lose acid from the body, what will the person develop? Metabolic alkalosis. So what I want to say is that the metabolic acidosis and alkalosis are cancelling each other in this case. Guys, this particular patient is actually having a mixed disorder. He is having two problems in the body, but ABG is after all mathematics. So mathematically the acidosis can cancel out the alkalosis component. I'll go by the rationale. Kidney failure implies metabolic acidosis. When somebody is vomiting, there is a metabolic alkalosis. Both can coexist in a patient. Though both are present, they are hidden. Why they are hidden is because body follows mathematics, and therefore pH of the patient will turn out to be normal. Acidosis will lower the pH, alkalosis will raise. If the rise and the fall are equal, pH will remain falsely normal in this case. So what I wanted to say is that this particular disorder is again a common error, that this is a factitiously normal report. This looks like normal, guys, but in reality the patient is having two disorders. So when you will say what is the interpretation of this ABG report, again an initiate question that has been discussed here, you will say that the person is having metabolic acidosis plus metabolic alkalosis. You can solve this question even without doing mathematics. It is simple that vomiting is a feature that causes alkalosis and CKD causes metabolic acidosis. So no need to get into the mathematics in the paper. Yes, anion gap is a hint towards the fact. I mean, why did I calculate the anion gap is to find out if anion gap in this case was normal, then this would have told me that, okay, the report is normal, right? I mean, suppose there is no history given and this report is given to me and anion gap is normal as a normal report. But anion gap is that clue that is telling you that something is amiss here, that acidosis and alkalosis or metabolic variety are coexisting and they're causing pH to be factitiously normal. They're causing it to be falsely normal. So anion gap is that hint, the elevated anion gap that tells me that this is factitiously normal report. Suppose in this report pH, PCO2, bicarbonate were normal, anion gap was also normal, then I will answer as a normal report. Now, on the basis of this information, we'll next talk about must know facts like what is the fluid of choice for metabolic alkalosis. This I've already said verbally. There is a dehydration component present. So we will be giving 0.9% isotonic saline for management of these patients. Fluid of choice for metabolic alkalosis is normal saline. Then another question that was asked was, if you are giving like excess of normal saline, the side effect, he's saying what is the side effect that would be occurring of excess normal saline in a patient. So when you give normal saline in excess, the chloride, that is the negative charges in the body. Chloride is a negative charge. So negative charges in the body, negative charges levels will begin to rise. Now, the body wants to maintain electron neutrality. I want you to keep patience here. Just follow my interpretation for the next 10 seconds and you get it. That kidney wants to maintain electron neutrality. So when negative charges levels in the body will rise, then body will ask the bicarbonate. Bicarbonate is also a negative charge. The bicarbonate goes inside the cells. What is happening here is that the body wants to maintain electron neutrality. The body wants to maintain some balance because you sent extra normal saline in the body, you sent extra negative charges in the body. So to maintain electron neutrality, the body sending bicarbonate goes inside the cells. Now, if you focus on the English word here, bicarbonate goes inside the cells, then it will cause a development of metabolic acidosis. So excess of normal saline contributes to development of, your answer would be hyperchloremic. That is, negative charges in the body are rising. The negative charges are forcing the body to adjust to this extra negative charge by forcing the bicarbonate कि भाई तू थोड़ी देर अंदर चला जा यार, so that I can maintain the electron neutrality, and therefore your answer would be hyperchloremic metabolic acidosis. I'll say the rationale once again. When you give excess of normal saline to a patient, then there is more negative charges in the body that are rising. The body wants to maintain electron neutrality. It will give a signal to bicarbonate, you bloody go inside so that at least I can handle this excess chloride. And therefore I said hyperchloremic because excess chloride is forcing the bicarbonate to go inside. So metabolic acidosis will be occurring in this patient. So these are two very standard questions that you need to remember. Fluid of choice for metabolic alkalosis and excess of normal saline, side effect. Then is, what is the fluid of choice for metabolic acidosis? Well, no prizes for guessing that. Pretty straightforward. Ringer lactate. Question for you guys. Ringer lactate has lactate. Why there is lactate? why lactate is present. I mean, what is the need for, putting lactate in ringer lactate? Your answer will be lactate will be going to the liver. It will be metabolized by the liver, and the liver will then be causing a bicarbonate generation. And this bicarbonate which is produced, this will neutralize the proteins. रिंगर लैक्टेट में लैक्टेट क्यों होता है? बिकॉज इट हेल्प्स इन जनरेशन ऑफ बाइकार्बोनेट, एंड द बाइकार्बोनेट जनरेशन will then help in neutralization. I mean, after all, in metabolic acidosis there is excess protons in the body, so neutralization of hydrogen ions is what I'm trying to do in this particular patient, and therefore ringer lactate is the fluid of choice for metabolic acidosis, whereas normal saline is the fluid of choice for metabolic alkalosis. In fact, one of my students who solved the question of side effect of excess normal saline is metabolic acidosis is, he said, sir, you had told that fluid of choice for metabolic alkalosis is normal saline, right? So I mean, what would normal saline be causing to neutralize metabolic alkalosis? Metabolic acidosis. I'll say that again. Fluid of choice for metabolic alkalosis, normal saline. So that means what would normal saline be doing? It is causing metabolic acidosis, which will neutralize the metabolic alkalosis. So he said, I did not remember all this electroneutrality thing that you had told. I just remember fluid of choice for metabolic alkalosis is normal saline. So if you give too much of normal saline, it will cause opposite. That is, it will contribute to metabolic acidosis developing in a patient. That's what I've written, hyperchloremic metabolic acidosis. And the concept is related to electroneutrality. Then what is best for management of acute exacerbation of chronic bronchitis? Your answer is NIV, that is non-invasive ventilation. And if he says what is best for management of respiratory alkalosis, then you will say that I will be giving to this patient a paper bag, and the patient would be expected to do a paper bag rebreathing. The rationale is that if a person is doing a paper bag rebreathing, our exhaled air also contains sufficient amount of carbon dioxide, so that exhaled air containing carbon dioxide would then help in like raising the carbon dioxide levels in the body of this patient. So these are a couple of those miscellaneous kind of must-know facts that have to be remembered. With the second highlight, the second question that I've marked here at the moment before you, this is like a must-know, that is side effect of excess or normal saline is hyperchloremic metabolic acidosis occurring in a patient. In case you had any issues in understanding this, do drop me a mail at marvamedicine@gmail.com. Although I made it, try to make it as simple as possible. And this practice you have to do, that for metabolic acidosis case, what should be happening to PCO2 in metabolic alkalosis. Like the rationale is very simple. Metabolic acidosis को small breathing. Opposite of that, metabolic alkalosis, PCO2 should be raising. If you're able to figure this out, because if I have not been able to explain this to you, then the fault is mine and not yours. I need to improvise and find out a way. But like over the period of like, let me say, of almost 20 years of my teaching, what I have tried to do is that this does help students. Not that I'm boasting, but I'm trying to say it does help students work out the interpretations in the questions. But if you had any issues, then yeah, I'll take it on me, a failure on my part, and I'll try to improvise even further. So, but yeah, before you drop that mail, try to listen to this once again, so that at least maybe like, there might be some points that you might have missed. So, but if you listen to this twice and you still have issues, drop me a mail. I'll try to simplify things before you by maybe dropping a voice message or like simplifying things even further. But this is like the simplest version of like ABG analysis that I can do for you at this moment. Okay. Next up is pneumothorax, which is a oft repeated question. So when you check out this X-ray, you will notice that there is no vascular markings in this case. Like normally in the lungs, we always find vascular markings. Like, on this side, you can see the vessels, right? You can see the blood vessels in the lungs, but there is no lung markings in this case. So the first thing is for pneumothorax, no lung markings is one of the easier way to identify it. The radiologist will say the word hypertranslucent lung, but instead of that, if you just focus on the word no lung markings, that is good enough to identify. And what happened in this patient was that there was a penetrating injury to the chest. Like this guy got stabbed in the chest. So there's a penetrating sucking wound that is created, which is causing air to rush between the two layers of the pleura, the visceral and the parietal pleura, and it is squeezing the lung. This whole lung is now deflated, and this deflated lung will now appear white. Like in this area, you notice that this area, this is the collapsed lung, guys. This is the totally collapsed lung. It's totally deflated, that white, because if you have air in the lung, then it's black. If the air is not there, then the lung will appear like white. So here, if I show white, it will not be visible in white background. So I'm showing this is the deflated lung. So sometimes the pleural reflection may be visible, but even if it is not, the main message is that in pneumothorax, you will be exhibiting is presence of air between the two layers of the pleura. And like most of the time, the scenario given to you will be of tension pneumothorax. In tension pneumothorax, when do you say the word tension? If any of the following are present, for saying the word tension, the blood pressure of this question should mention a BP of less than 90/60, or he might mention the word crushing patient, or he may write the word hemodynamic instability. If any of these terminologies are given, it means that you will say tension word. If instead of hypotension, sometimes he might mention mediastinal shift, or the heart will be pushed away now, because you can see in the line diagram that the apex beat will be displaced, because air at positive pressure in this particular case will push the heart away, and there would be compression of the great veins of the chest like SVC, so there would be elevated GVP. So if you read any of these terminologies that I've written, that is 1, 2 and 3, then you will say it is tension word. If in the MCQ, if these data are not given, if the BP is given to be like more than 90/60, then you will say traumatic pneumothorax, because most of the time it is like chest trauma, penetrating injury to the chest. So traumatic pneumothorax will also be given, tension pneumothorax will also be given. If you have to differentiate between the word tension and traumatic pneumothorax, focus on the words that are written in color blue. Hypotension, mediastinal shift and elevated JVP is for tension. For pneumothorax, what should be written is absent air entry, absent breath sounds, and hyperresonant percussion note in a patient. So the data in black is for pneumothorax. That's understandable. Hyperresonant percussion note, because the percussion note in our chest is like resonant. In this case, it will become hyperresonant. Additional thing that will happen in these patients is this air at positive pressure will squeeze the inferior vena cava and will squeeze the superior vena cava, which is sending blood into the right side of the heart. So ultimately what will happen in these patients of pneumothorax will be tension pneumothorax. What will happen is that the superior vena cava and the inferior vena cava will get kinked. Because of the kinking of the SVC and IVC, the venous return to the heart will almost become zero. And because the venous return to the right side of the heart is becoming almost zero, so the blood pressure of this patient will begin to fall. I said because there is kinking of the SVC and the IVC, the venous return of the patient will begin to fall. When venous return of the patient will begin to fall, the blood pressure of this patient will begin to crash. So if you get a question on tension pneumothorax, then what you have to also understand is why is the blood pressure crashing? Because patient is having obstructive shock. Yes guys, tension pneumothorax is an example of obstructive shock. The last time I have described to you obstructive shock is in cardiology with respect to a person having cardiac tamponade, but today in tension pneumothorax also I'm using the word obstructive shock. In this patient, the BP will crash, so the pulse will begin to disappear. When the pulse of the patient will begin to disappear, then I will also use the word pulseless electrical activity. Last time I used the word pulseless electrical activity was for cardiac tamponade, but now I am once again repeating the word obstructive shock, pulseless electrical activity. They basically mean the same only, and they are a feature of tension pneumothorax. There are two domains which I want you to be very, very thorough with. Status number one, or domain number one that you should be very clear is when to say the word tension, when BP is crashing, or there's a mediastinal shift, or there's an elevated JVP, any one of them given. And I've also given the rationale for tension. Why is the BP falling? Because SVC and IVC in this condition are compressed by the air at positive pressure in the chest, because atmospheric pressure is 760. You see, if I look at the mathematics here, I want to say that in the atmosphere, while you are sitting and you are listening to me, the atmosphere, one atmospheric pressure is 760. Physics of class 10th and 12th physics. And in our pleural space, the pressure is negative. It is -2 to -6. Guys, the pressure in our pleural space is negative. It is -2 to -6 centimeter of water. And what I want to say is that this pressure becomes more negative. Like this -2 is in the phase of expiration. EX means expiration. And in the phase of inspiration, the pressure will become more negative. This is again hardcore physiology, that pressure in the chest becomes more negative, because that's how air will go in our lungs. Now, when you and me are breathing normally, when the pressure in the chest will become negative, that's how air will go in the lungs. So pressure becomes more negative on inspiration. There's a huge pressure difference between outside and inside. And in these patients, what will happen is that the air in the chest at positive pressure is squeezing and crushing the lung, resulting in a pulseless electrical activity. I will also mention a couple of more examples of pulseless electrical activity / obstructive shock. In fact, there are 3 of them only. So let's just write them. Causes of pulseless electrical activity / obstructive shock. One of them that you have to remember and will be discussed in the later part of this particular video lecture itself is massive pulmonary embolism. So the surprising thing is 2 lung conditions will be causing pulseless electrical activity. Massive pulmonary embolism, The second one is tension pneumothorax. Again, the word is, I'll not say plain pneumothorax, I'll say tension word, based on the fact that there is a kinking of the SVC and IVC in this particular condition due to air and positive pressure. And the third example of this would be cardiac tamponade. These are three situations where the BP will crash, the heart is still beating. So the pulse of the patient, you see, the point is heart is beating, still the pulse is disappearing. Normally, so we say na cardiac arrest, the pulse is like the heart is not beating, pulse is disappearing. But here heart is beating, still the pulse is disappearing. That's why the word is pulseless electrical activity. And after giving you all this situation of penetrating injury and all this data of absent air entry, absent breath sounds, he will say what is the first line intervention. So that is very clear that you would be answering this as wide bore needle. For tension pneumothorax, the main treatment is we'll be inserting a wide bore needle. The wide bore needle will allow some evacuation of air which is accumulating in the pleural space of this patient. The wide bore needle will be put by default in the fifth intercostal space in the triangle of safety. Triangle of safety boundaries I will also mention, but at this moment I also want to say that this is the answer with respect to adult patients, that is a needle decompression by putting a wide bore needle in the fifth intercostal space. If they give you a situation with respect to a child, then you will just modify the answer and say second intercostal space, and your line would be lateral to the midclavicular line. Then your answer is second intercostal space lateral to the midclavicular line. Here I also want to bring your attention to a FMG exam question where in adult fifth intercostal space was not in the options. Fifth intercostal space was not in the options. What will you answer if in the adult fifth intercostal space is not answered? The answer would be second intercostal space lateral to the midclavicular line. Yes guys, we prefer in child second intercostal space lateral to MCL, that is okay, but can be done in adults also. What can be done in adults also? So like, you know, there was a lot of like hue and cry regarding, sir, you told fifth, and for adult you told child, and then like in the paper there was no like fifth intercostal space. So it's okay, man. Like if you don't have one space available, whatsoever be the reason, you can use an alternative site in a patient. After all, you need to do a needle decompression. Now, as far as the triangle of safety is concerned, triangle of safety would be like we'll be having anteriorly muscles. In fact, I can just mark the triangle here and then write down the boundaries. So you can see the triangle anyway, I mean in the line representation. So let's just do it. The anterior boundary, posterior boundary, and the inferior boundary of the triangle of safety needs to be practiced. So the anterior boundary is going to be pectoralis major. This is going to be a muscle that is present anteriorly, like pectoralis major. Then the posterior boundary would be latissimus dorsi. The posterior boundary is latissimus dorsi, the muscle in the back which helps you climbing trees, or like muscle that helps a person to climb an object. Then inferior boundary would be the fifth intercostal space, 5 ICS. So the needle would be put in the fifth intercostal space, or you will say anterior to the mid-axillary line is where the needle will be put. But this is not a permanent solution. This will just cause evacuation of air. So the second step that would be done in this patient subsequently will be to put in a chest tube, which will be called as intercostal drainage tube. This intercostal drainage tube is also put in the fifth intercostal space, and it would be put in the triangle of safety. Now, since I've already mentioned the boundary, so I'll be saying anterior to the mid-axillary line. Yes, guys, it's not anterior axillary line, it's not mid-axillary line. It is a little anterior to the mid-axillary line where the chest tube will be put by default. And once the chest tube has been put, then this chest tube needs to be connected to underwater seal. You can see here this representation of this bag. So this bag is the one that's the real game changer. It will generate negative force and it will help in evacuation of air as well as blood in the chest of this patient. So the point number 3 for this discussion is that you have to connect it to a underwater seal drainage. This underwater seal drainage generates negative suction force. It helps in evacuation of blood, because if there's a trauma, there would be some amount of blood also present. So the underwater seal drainage, or UWSD, is the real deal maker in this particular situation. Initially was a palliative treatment because you wanted to evacuate some air to make the BP at least recordable from unrecordable state. Then you put in a chest tube and connect it to an underwater seal drainage. The UWSD will generate negative force, and this will help in evacuation of both blood and air in the chest of this patient. Just for the sake of discussion, I mean, this is the blood collection chamber. So you can notice blood would be accumulating in this area. This is the blood collection chamber. And there is a air collection chamber also. So you will notice that there would be intermittent bubbling that would be happening here. This area that I've currently shown is the air collection chamber. In the air collection chamber, there would be intermittent bubbling. In this air collection chamber, there would be intermittent bubbling of air happening. That tells you that there's a gradual evacuation of air happening. But if there's a continuous bubbling, that is always a cause of concern. Continuous bubbling of air indicates one possibility, that is air leak. What I mean by air leak is that the tube is not connected to the bag properly. If you don't connect the tube, then atmospheric air will be sucked in, and that will contribute to continuous bubbling. So he gave this situation in the paper, though it has a surgery overlap. What is the reason for continuous bubbling in the air collection chamber? The answer is air leak, that is poor connection. This poor connection that I'm talking about is between the intercostal drainage tube and the underwater seal drainage. I mean, you need to connect the two, otherwise atmospheric air will get sucked in. But if that air leak is not present and still there is continuous bubbling, then another possibility could be that there could be trauma to the lung tissue also, and due to this the lung air is leaking into the pleural space. This is what is called as a bronchopleural fistula, and this would require like a surgeon to then go ahead with a thoracotomy in this patient in a bronchopleural fistula, because now the lung tissue is also penetrated. Then there would be continuous bubbling because the lung air will be escaping into the pleural space. Earlier in tension pneumothorax, what was happening was air accumulating in the pleural space, but there was no trauma directly to the lung tissue. But now what has happened is that if the knife had penetrating the lung tissue also, then there would be a bronchopleural fistula and continuous bubbling occurring. Then if intermittent bubbling stops, like intermittent bubbling stops after a few hours, then I can say that, I mean, like he gives a situation that the surgeon put the tube and then he went into the major OT for another procedure. He put the tube in the minor OT and asked you to take care of the tube. So relative came after like few hours and he says, Dr. Saab, now this intermittent bubbling has stopped. So intermittent bubbling stops after a few hours. After a few hours, if this has occurred, then one possibility is that there could be kinking of the tube, because lots of time the intercostal drainage tube is long and it can get crushed under the hospital mattress. You see the hospital mattress is thick and the bag is attached below the hospital bed of the patient. So the tubing is long and it can get kinked. So kinking of the tube should be thought of. If kinking of the tube is not there, then the next cause can be dislodgement of the tube also, because when you put the intercostal drainage tube, you put in an anchoring suture, but sometimes that anchoring suture might give away in the process of shifting the patient from the minor OT to the ward. So dislodgement of the intercostal drainage tube could be the reason why the person could be having intermittent bubbling stopping. But suppose he gives to me that intermittent bubbling is stopping after, let me say, after 5 days, 6 days, whatever. Like if he gives me a situation where intermittent bubbling is stopping after a couple of days. So that basically means that now, like why it is stopping is because the lung has re-expanded. Now there is a re-expansion of the lung. So that is good news. No, that is good news that the lung is re-expanded. So we daily do a check X-ray in these patients and we compare the yesterday's X-rays with today's X-ray. And if the lung will re-expand back to normal, then the intermittent bubbling will stop. So all of these are practical aspects that he has asked in the exam. And like I explained, the real deal here is the real deal maker here is the underwater seal drainage, which helps in management of this patient. Additional point that I would like to add in this topic is that if I will be doing auscultation over this heart of this patient, suppose I put my stethoscope here. If I put my stethoscope over the heart of this patient, I will be hearing sound. I'll say it verbally, then I'll write it. The sound will be as if somebody is walking on freshly fallen snow with leather boots on. That is called as Hammond crunch sign. That is an auscultatory finding of pneumomediastinum. That's an auscultatory finding of pneumomediastinum. I'll write it in a couple of seconds. Just follow my words here. Suppose if I keep my stethoscope here, then there would be no breath sounds heard. So I had already sensitized to you that if I read a question which says absent air entry, absent breath sounds, if I read a question that says absent air entry, absent breath sounds, then that is always a feature that you read with respect to pneumothorax in a patient. But if you read that the patient is having Hammond crunch sign present, then it is an auscultatory finding of pneumomediastinum. So let's do a quick recap. Absent air entry, absent breath sound, that's a feature of pneumothorax. And for the pneumomediastinum part, I'll just write in fairly because lots of time pneumothorax can coexist with pneumomediastinum. So there is a possibility that in some questions he might be mentioning this auscultatory finding. Let's just jot it down here. Pneumomediastinum auscultatory finding. The sound will be as if somebody is walking on freshly fallen snow with heavy duty military grade leather boots. So word is Hammond crunch sign. Or like I can give another example, no, if you bite into chips or lays, no, like chips or lays, when you bite, that crunch sound that would be coming. So pneumomediastinum results in Hammond crunch sign. That's like an auscultatory finding that I've explained to you at this moment. Now, the reason why I am like being a little descriptive for this is because you will also find across another terminology. This is written in MCQs as Hammond sign. Hammond sign is a palpatory finding, guys. Hammond sign is a palpatory finding. When you will palpate on the face of the patient, neck of the patient, you will feel air is present below the skin. The reason for that is when the lung will get injured, the air will dissect into the subcutaneous tissues. In fact, if I move up in the slide, you look at this diagrammatic representation, the eyes of the patient are looking so puffy. It's literally like the eyes are shut. This is not a case of heart failure, guys. The eyes of the patient are literally shut. That is because there is air below the skin. This guy had a pneumothorax. The air escaped from the lung into the muscles, from the muscles into the subcutaneous tissue. So if you keep your hand on the neck or face of this patient, the feel that you will get is as if you're putting your finger on a bubble wrap. Like if you order something from Amazon or any other website, they'll wrap it in a bubble wrap to keep it preserved. So the kind of feel that you get under your fingers when you put your finger over a bubble wrap, the kind of feel that you'll be getting when you palpate on the neck of this patient. So Hammond sign is a palpatory finding of subcutaneous emphysema. I had to explain this separately, guys, because crunch word is for auscultation, but Hammond sign is a palpatory finding of subcutaneous emphysema. It may be written sometimes as crepitus under the skin. In fact, if I would have said the word crepitus under the skin, you would have nodded your head earlier that, okay, sir, understandably, there is a air dissection that is happening. So crepitus under the skin is the easier way to understand. And in some MCQs, he might be writing it in the way I have currently explained to you. And I also want to say that you will read about crepitus under the skin in gas gangrene also. But there we don't use the word Hammond sign or subcutaneous emphysema. So these are like a couple of findings of pneumomediastinum, because pneumothorax can coexist with pneumomediastinum. Then because they can be hemothorax also, so though this is a surgery overlap, we need to do this question. Drain amount should be more than how much ml per hour. If the drain amount is more than 200 ml per hour for 2 consecutive hours, you have to inform the surgeon, because then we need to do hemostasis. The surgeon will have to do a thoracostomy. I mean, the objective is when to inform the surgeon, because the patient will be taken up for a emergency thoracotomy. We need to do a hemostasis. The lungs could be bleeding. They could be bleeding from the bronchial artery, bronchial vein, pulmonary artery. Stab injury to the chest, no, any blood vessel can get injured. So it could be bleeding from the bronchial artery, bronchial vein, pulmonary artery, pulmonary vein. So thoracotomy might have to be scheduled for this patient if the drain amount is more than 200 ml per hour for 2 consecutive hours, or immediately after putting the tube. If there is more than 1500 ml as a single reading, then it implies that the person is having bleeding in the chest. And in trauma cases, I mean, it's obviously a combination of pneumothorax that would be occurring. And I also added the technical details of pneumomediastinum here, auscultatory versus the palpation finding. With one word missing, the crunch word tells you that that's an auscultatory finding. Next up is the topic of pleural effusion, that's also called as hydrothorax. Now, how do you identify this in a chest x-rays? That you are able to see this very classical concavity that I'm currently showing. The technical term that would be used by the radiologist to describe this would be either Ellis curve, or instead of saying the word Ellis curve, another term that can be used is meniscus sign. What you have to also understand from the physics perspective is that the fluid is rising higher in the axilla area due to the capillary action, and that is why like this curvature would be coming. But even if you don't remember that physics part chalega, what you need to remember is Ellis curve / meniscus sign is a concavity that helps you identify the upper level of the pleural effusion. And at the same time, I also can highlight in this diagram that there is a blunting of the costophrenic angle. If I represent this line diagram at the moment, I can mark these areas as 1 and 2. 1 would mean costophrenic angle and 2 would mean cardiophrenic angle. And you can understand due to the gravity aspect, area number 1 will be the first one to be obliterated. So another question in the paper said that which of the following areas would be the first one to be obliterated with respect to a pleural effusion? Your answer would be costophrenic angle will be first to be obliterated, then subsequently the cardiophrenic angle, that is 2, would be obliterated. And you can see a concavity, and obviously the fluid is always going to be white in color. So that is unmistakable image with respect to a left-sided hydrothorax in a patient. Now, my students told me that in the paper, a identical kind of image was present, but there was a subtle difference.
Obviously, like this is white, so that means it is fluid. There was blunting of the costophrenic angle. So almost a similar kind of a representation can be seen. But the subtle difference is that there is no Ellis curve or a meniscus sign present here. What you can notice here is instead of a meniscus sign or like that concavity, it is a straight line. So therefore, my answer in this particular case will change. If they give you a X-ray in which the whiteness is present, that means obviously there would be fluid, but the upper level should be concave for like pleural effusion or hydrothorax as an answer. For the image that is shown subsequently, because of that horizontal level, you will say that the patient is having combination of two things. There is obviously a pleural effusion, but along with that there is air also, and due to combination of the fluid and the air, there is a loss of that capillary actions. That is from the physics perspective that I was saying. So therefore, in this particular question, your answer would not be given as plain hydrothorax. You will rather answer it as a combo of hydropneumothorax. The final data to be remembered is very simple and very straightforward. The first X-ray that is shown to you will be answered by you as hydrothorax because of the concavity component. But if they give you an X-ray in which that concavity is missing, everything is white, blunting of the costophrenic angle is present, but the upper border is straight, then you will say it is hydropneumothorax. I mean, this could be a case of trauma. There could be blood also. I mean, blood will also appear white, and there would be air also. So hydropneumothorax, like in a penetrating injury, could be resulting in this kind of a manifestation. Now we will have to do a diagnostic thoracocentesis, and in some cases, if the fluid is very large in amount, we might even be having to do a therapeutic thoracocentesis in the patient. I also want to say that if a person is having a massive unilateral pleural effusion, then there would be a tracheal shift to the contralateral side as well. We'll discuss subsequently when does trachea come to the same side, when does it go to opposite side. But at this moment, for pneumothorax, as well as for a pleural effusion, if it's large in size, the trachea would go to the contralateral side. Now, what is going to be the preferred site of thoracocentesis? Your options in the MCQ would be like the second space, fifth space, seventh space, and the eighth space. So if they ask you to select one, then your answer would be as low as possible. So I will be putting the needle in the eighth intercostal space, and I put you this as a question to you guys. I mean, which line would you be using? Options are like mid-axillary line, anterior axillary line, posterior axillary line, scapular line. So your technical answer would be that we will be utilizing the area between the posterior axillary and the scapular line. Yes, guys, it is neither posterior axillary line and neither it is going to be the scapular line. It is somewhere in between. It is midway between the posterior axillary line and the scapular line. So we have to stand behind the patient while we are doing this procedure. It obviously has to be ultrasound guided. I'll just zoom into this image as well. You can see there is a fluid that is present at the lung basis because of the gravity part. It will displace the lung. If I auscultate over this area, I will be getting reduced air entry. I'll get less intensity of breath sounds, or he can say the word distant breath sounds. If I percuss over this area, I will be getting a stony, dull percussion node. And now once I identify the upper border of the fluid, I will be putting the needle at the lowest possible space. And when I put this needle, I have to put it somewhere between, like if this is the scapula of the patient, this is the scapula. So I have to put it a little, I would say, medial to the scapular line, a little posterior to the posterior axillary line, or little lateral to the posterior axillary line. Simple data is 8th intercostal space, midway between posterior axillary and the scapular line. And also when it comes to the intercostal space, when you are going to be putting the needle has to be put in such a fashion that you don't end up injuring the neurovascular bundle. You can see that in this line diagram, I've shown the neurovascular bundle also, because below every rib, there would be intercostal artery, intercostal vein, as well as the nerve. The anatomical arrangement of these has also been asked. So it is always VAN, it's always vein on the top, then is the artery, and then is the nerve. The only time you don't get this VAN and you get AVN would mean first the artery, then the vein, is with respect to underneath the first rib. Otherwise, for all the ribs by default, it would be the vein and the artery and the nerve primarily. So VAN is what is to be remembered at the moment. And I want to avoid injury to the intercostal vein, intercostal artery, intercostal nerve, and that is why I will be putting the needle superior to the inferior rib. Like in the MCQ, the options were like, where would you put the needle? Options were like lower border of the superior rib, superior border of the inferior rib. So obviously at the moment, because I've drawn a line diagram, it will make it easy for you. But in reality, like after the paper, students were like, that there was no line diagram obviously there. So it was like, sir, I had to really really hustle there to find out whether the correct answer is lower border of the superior rib, or is it going to be like the superior border of the inferior rib. As you can see in the representation, it's the superior border of the inferior rib. So at the moment, we are doing a thoracocentesis. It can be diagnostic as well as therapeutic. And then how much fluid can we remove per sitting? Then the answer is variable according to different authorities. But like the max you can remove is 1500 ml. In real clinical practice, we never go so extreme up to 1500 ml. Max will be removing like 500 ml. Then next day, if the patient tolerates, we can go to maybe 750, then gradually increase to 1 liter. But in a single sitting, usually he says never remove more than 1500 ml per sitting. The reason for this is mainly because of the re-expansion pulmonary edema. Yes, guys, we don't remove all the fluid together. Like if it's a tall person, well built, 6 feet 5 inches tall guy from Haryana had a lung cancer and now is having a pleural effusion. It's like maybe 3 liters of fluid present. So I'm not going to remove it in a single sitting. I'm going to remove it over like multiple installments. And here, like if I try to remove the fluid in a single sitting, then I run the risk of actually causing a new cause of breathing difficulty. Like already the chap is having breathing difficulty. Now new onset breathing difficulty will occur. That's because of risk of re-expansion pulmonary edema that would be present in these patients. So at the moment, the data is like three aspects. One is the site, then where would you insert the needle in the eighth intercostal space, then it is in the lower part of the intercostal space / superior border of the inferior rib, and I want to avoid injury to the neurovascular bundle as I have explained to you. So I'll just write that for the theory perspective. The answer of yours would be, I'll tell you what are the layers that are pierced also. I'll tell you what are the layers pierced also. Just like hold on for a while. It is the superior border. You have to literally, your needle has to graze against. When you give local anesthesia, all procedures invasive, you must give LA. A lot of people think that you have to anyway insert a needle. It's painful, sir. That sensation of needle going in is very, very unpleasant, believe me. So you must always give local anesthesia, how minor the procedure might appear to you, but for patient it's really, really big. So it would be a superior border of the inferior rib that would be used in this case, as highlighted above the upper border of the lower limb, but in the MCQ it was superior border, inferior border. So I thought I just rephrase that. Now, once I've taken out this fluid, I'll send it to the laboratory. And in the laboratory, I'm going to check for pleural fluid protein and pleural fluid LDH. If you notice that the pleural fluid protein values are given to be less than 0.5 times the serum protein, or if he mentions pleural fluid LDH values to be less than 0.6 times the serum LDH, this implies that the type of fluid that you're dealing with is basically transudate. Transudate will be occurring because of difference in the hydrostatic pressure and the oncotic pressure. That's going to be like Stirling forces. The mnemonic for this is CHAP, CHAP. So that would be C for congestive heart failure, H is for hypoalbuminemia, which can be written as like liver cirrhosis, or he can be writing like hypoalbuminemia's nephrotic syndrome also. There are two expressions for hypoalbuminemia. Cirrhosis is a condition where the synthesis of albumin would be lesser, and nephrotic syndrome is a condition in which there would be a urinary loss of albumin. Then ascites, like ascites has multiple reasons, can be associated with pleural effusion. Lots of time like patients are having hepatic hydrothorax. Hepatic means liver cirrhosis causing a development of initially ascites, and then we have connections between our peritoneal cavity and the pleural cavity. There are transdiaphragmatic holes, so the fluid can move from the peritoneal cavity to the pleural cavity. So ascites could be a cause, and then is peritoneal dialysis that is done especially in children who are having chronic kidney disease. So the mnemonic for this is CHAP, and if they ask you a single best cause overall, like what is the most common cause of why a person will end up with transudative variety of pleural effusion, then your answer would be given as congestive heart failure. In all of these conditions that I mentioned here before you, you will notice that the pleural fluid protein values would be less than 0.5 the serum protein, and the pleural fluid LDH values would be less than 0.6 times the serum LDH values. Sometimes in MCQs, just to use mathematics, he may write the word less than 2/3 of the upper reference limit. URL means upper reference limit of the serum LDH. It basically means the same only. And suppose if I change the data, so I'll use a different color to highlight it. Like suppose I get a question in which the pleural fluid protein values as well as pleural fluid LDH values are given to be more than 0.5 and more than 0.6 respectively. 0.5 is the value for protein, 0.6 is the value for LDH. Sometimes you might even have to do calculation also. But if you are going to be getting these values as more than, I would recommend you to remember at the moment what I'm saying at the moment in color blue. If the values are given to be more than, this means that the fluid that is present in the pleural space of the patient is exudative in nature. When I say the word exudative, it basically means that there is going to be an inflammatory process present here. And for the exudative nature, I can say that one, the fluid will always clot on standing because the fluid is going to be fibrin rich. In FMG exam, it was very simple. He simply said that which of the fluids is going to be fibrin rich, because if I say the word exudate, it means inflammation. Inflammation means fibrinogen, fibrin component would be coming. And the importance of knowing this is that even without the Light's criteria, I can know whether it is a transudate and exudate. When I say like this, it's like how, sir, without lab evidence would you know it's a transudate and exudate? If you just keep the fluid in the syringe for some minutes, if the fluid will begin to clot in the syringe itself, it would mean that it is an exudate because it is fibrin rich. Transudate is just gonna be like water. It's never ever gonna clot, but exudate will clot on standing because it has fibrin present. As far as the causes of this are concerned, I'm not going into any mnemonic. I'll just mention it logically. One of the important causes in India is tuberculosis. Understandably, I mean, TB can be affecting one lung, the peripheral part of the lung near the pleura. If you are having a focus, Bonn's focus, then it can irritate the pleura. Then can be a peripheral lung cancer that can be in the form of adenocarcinoma of the lung. This will like cause usually a massive pleural effusion. I mean, lung cancer usually always causes a massive pleural effusion. Then for the fourth cause, what he can write is a condition that is called as Meek syndrome. Meek syndrome is what we get with respect to ovarian cancer by the name of fibroma or a thecoma. Or another cause that could be mentioned is like Dressler syndrome. Dressler is a post-MI pericarditis. That is what I've explained to you in like the cardiology section. But today I'm saying Dressler syndrome can also not only be having a pericarditis component, it will have a pericarditis component agreed, but can have a pleuritis component as well. And when I say local inflammation, it is an exudate. Or he can mention rheumatoid arthritis. Yes, guys, not rheumatic. Rheumatoid arthritis is a condition in which we get that small joint involvement, young lady, morning stiffness, PIP, MCP, wrist joint involvement with rheumatoid nodules. So these rheumatoid nodules can be present in the lung and they are inflammatory nodules, so they can break down and they can cause a exudative pleural effusion. You can see that I've expanded the number of causes, but cause number one is still vacant because this happens to be overall the most common cause. So for India, I mean, tuberculosis looks like a very tempting answer, but on a global basis, I would recommend you to answer not as tuberculosis because it's not common on global basis. It's more common in India. So your answer would be given as parapneumonic effusion. Now, parapneumonic effusion would mean that the person is having a combination of pneumonia and a pleural effusion. And if antibiotics are not started on time, then this parapneumonic effusion will very soon evolve into what is called as a empyema. Empyema would mean that there would be pus accumulating in the pleural space of this patient, and now I will have to put in a chest tube. So one more indication for putting in a chest tube apart from pneumothorax that I was describing earlier is empyema, where there's pus in the pleural space, because see, antibiotics have horrible penetration into pus. So if I'm gonna not put in a chest tube, just give antibiotics, nothing is gonna happen. Patient will go into sepsis, die due to septic shock. You have to evacuate the pus. And like in empyema, you can do an incision and drainage in the chest. That's going to contribute to pneumothorax. So you will have to put in needle, wide bore needle, in fact, and aspirate that pus initially, I mean, for diagnostic purposes, and then do a therapeutic insertion of intercostal drainage tube to evacuate the pus in the pleural space, which is called as empyema. Among the causes that are mentioned at the moment, if they ask you to select one for the most common variety of a transudative variety of pleural effusion, then your answer would be given as congestive heart failure. And if we ask you to select for the most common variety for like the exudative variety, then your answer is a parapneumonic effusion. And like in the MCQ, what they did was they mentioned the Light's criteria. Three options were transudate, one was exudate, that was TB, and he said which of the following is like not an example which will satisfy the diagnostic criteria of a transudate. Like in the MCQ, what had happened was this mathematical value was given. And don't be surprised, this is like an FMG exam question in NEET PG, he made you calculate. And in calculation, the values were like you had to take the pleural fluid protein divided by the serum protein. All values were given, pleural fluid protein also, serum protein also. If the values are less than this much, then it's the CHAP causes which are to be considered here. And like it was a all except based question. So most guys did not even get into mathematical calculation. They said we just went by odd man out. Odd man out is English application. No, like, you know, if you look at it, inflammatory causes versus non-inflammatory causes like that, if you see, you can easily figure out the answer there. And then additional question which has been asked is like in which condition the pleural fluid adenosine deaminase levels are elevated. The last time you would have read about adenosine deaminase levels would be with respect to SCID. SCID is severe combined immunodeficiency syndrome, where adenosine deaminase levels are lesser. But today I'm teaching about pleural fluid adenosine deaminase levels being elevated, and it's not a disorder of immunity, rather, guys. It can be elevated in tuberculosis. This is a screening test for tubercular pleural effusion. If they ask you to select, like, what is the best way by which you can say that the person is having a tubercular pleural effusion, if he says what is the best way by which you can identify a tubercular pleural effusion, then you will say that I'll be doing a PCR. And this PCR ideally should be done on the pleural biopsy sample. So ideally we should be doing it on the pleural biopsy sample if the facility is available. If I don't have a pleural biopsy, then obviously I'll be doing a PCR, that is CB NAT, on the pleural fluid of the patient. But as I've written here, the diagnostic accuracy on a pleural biopsy will be more accurate because tuberculosis foci would be present there. Like in PSM, they'll use the word CBNAT, cartridge-based nucleic acid amplification technology, for the same. Best way for identifying tubercular pleural effusion is, like, CBNAT is the one that the government of India recommends on the pleural biopsy specimen followed by pleural fluid. Then comes the concept of right-sided pleural effusion is seen in Meeks syndrome. And Meeks syndrome is actually a triad. Meeks syndrome is a triad. It can be seen with ovarian tumor. The ovarian tumor I'm talking about is like a fibroma or a thecoma. These are solid tumors, fibroma/thecoma. Along with this, the second one that is present there is ascites. That would be an abdominal distension, that because it will irritate the peritoneal cavity. It will irritate the peritoneal cavity. And then the point is that because there is a communication between the peritoneal cavity and the pleural cavity, and these communications are more on the right as compared to the left, so the patient will also end up with right-sided hydrothorax, that is a pleural effusion developing. So in the paper, he wants to basically know that you are aware that this is association with an ovarian tumor. And now we talk about bloody pleural effusion. Bloody pleural effusion can be seen due to trauma. It can be seen in a patient who's on drugs like warfarin, so bleeding diathesis. But after trauma or warfarin, the next reason why this could be responsible, or it could be bloody TB, and then could be lung cancer. So anytime there's a bloody pleural effusion, high suspicion for tuberculosis, lung cancer should be kept. And for TB, like, one of the initial screening tests that I can do is first go for Light's criteria, where the proteins would be elevated, LDH would be elevated, adenosine deaminase levels would be elevated. Then he'll give you a question of your low sugar with cholesterol crystals are present in. This is rheumatoid pleural effusion. Do look at the spelling here. I'm not writing rheumatic, I'm writing rheumatoid. So rheumatic is what you get in children with group A beta hemolytic streptococcus, but at the moment I'm talking about a condition which is associated with HLA-DR4. That's again a very favorite question of the examiner, where you get morning stiffness in a young female, HLA-DR4 positivity. Rheumatoid arthritis can have a pleural effusion as well. The rheumatoid nodules are inflammatory, so they break down to produce a exudative pleural effusion, which would be having high protein, high LDH, low sugar, and cholesterol crystals. Make a mental note of the fact that in the Light's criteria, there is no mention. In the Light's criteria that we're discussing, there is no mention of sugar. In Light's criteria, you take into consideration that is again a FMG exam question, very easy one. He said, what is not a component of Light's criteria? Sugar. What are the components? Protein, LDH. He made combinations there. Protein, sugar, sugar, LDH, LDH, protein. The correct answer is in front of you. No? If you have three things like sugar, protein, LDH, you can make permutation combinations. तो पूछा कि Light's criteria में क्या क्या components included होते हैं. So it is a pleural fluid protein and a pleural fluid LDH, and we don't take into consideration the sugar. In CSF analysis, we take into consideration sugar, but not at this moment. And then is low sugar in the pleural fluid. Well, as I explained, it can be with rheumatoid arthritis, but yeah, it could be with malignancy as well. It could be with respect to our lung cancer. And then, yeah, obviously low sugar can be present with respect to like tuberculosis, rheumatoid arthritis, to name a few. Obviously, like, sugar is never diagnostic. It is just one of the accessory findings that will be present. And whenever we're doing a thoracocentesis in a patient, that's also called as a pleural tapping, then there are multiple layers that would be pierced here. So from the anatomy perspective, we can say, like, during the process of pleural tapping, what are the layers that would be like poked by your needle? So we'll go from the skin, subcutaneous tissue, superficial fascia, and then are the muscles, serratus anterior, because you're doing it from the back, no? Serratus anterior, then is external intercostal muscle, then is internal intercostal muscle, then is the innermost intercostal muscle. It is external intercostal muscle, ICM stands for intercostal muscle. Then is internal and then is the innermost inner intercostal muscle. So he can jumble the data. No, it's the external. You can see in the line diagram also. It is external intercostal, then it is the internal intercostal, and then you go more inside, that is the innermost intercostal muscle. And after that, you have to remember that what you pierce is first the endothoracic fascia, and then comes the parietal pleura. Here also you can jumble visceral pleura, parietal pleura, but that most guys will be able to figure out because visceral pleura will be adherent to the lung surface. No? Visceral pleura will be adherent to the lung surface. So we are having fluid accumulation between the visceral and the parietal pleura. Visceral is, viscera word means like it is adherent to the lung, and between the two there is fluid accumulating. So it's very unlikely somebody will mess up with parietal pleura versus visceral, but between that there is one more layer after the innermost intercostal muscle that you'll not be able to feel when you poke in the needle because it will not offer very significant resistance. But still, for the theory, you need to remember endothoracic fascia. So I'll just say the sequence fast. It is serratus anterior. I'll just move the slide. External intercostal, innermost, then endothoracic fascia, and then comes the parietal pleura and not the visceral pleura. So these are a couple of aspects that are currently mentioned in front of you with respect to pleural effusion. And I can just wind this topic off by saying that I am having a patient who is a young lady. She is a non-smoker, and unfortunately she has developed a peripheral lung cancer by the name of adenocarcinoma. So this lady, she's asking you, doctor, like, I never smoked in my life, my father does not smoke, my brother does not smoke, and still I'm unfortunately developing a lung cancer. So can you tell me the reason for development of the commonest lung cancer? Adenocarcinoma, it's a peripheral lung cancer, so it will irritate the pleura, and due to irritation of the pleura, what you will get in these patients would be a very substantial pleural effusion. So while I'm just marking that effusion here, which will be having that classical Ellis curve, and it will cause blunting of the Costophonic angle. The fluid will keep on increasing, guys. Like while we're discussing, the fluid will keep on increasing. It can cause a massive unilateral pleural effusion in this patient. The lady is asking you why, like, why am I having this adenocarcinoma? So your answer would be genetic basis. When it comes to adenocarcinoma, you know that there could be defective genes which are responsible. There are many of them that are responsible for adenocarcinoma, in fact. So, like, from the genetic perspective, like one of them that I can write is EGFR. Then another one that could be responsible is like KRAS, then can be ALK mutation. So in case you could not remember this, then do check out your pathology part. But otherwise, like, there are multiple mutations, and the single one that would be answered is EGFR mutation. Adenocarcinoma usually presents with a massive unilateral hydrothorax, and this massive unilateral hydrothorax in a patient, what it will do is that it will squeeze the lung, it will crush on the lung from outside, and as a result of this, the problem in the patient would be breathing difficulty. This person will also say that this breathing difficulty, this young lady is saying that my breathing difficulty gets accentuated when she turns and lies on one particular side, that is a lateral decubitus position. So you can see that I'm not discussing orthopnea at the moment. Orthopnea is defined as like breathing difficulty that accentuates on a supine position, but here जब वो curved लेके लेटती है, that in English basically means when you turn in a lateral decubitus position, the breathing difficulty of the patient happens to be accentuated. So the moment I say the breathing difficulty of the patient is accentuated, in those circumstances, the technical word that we will use here for this dyspnea accentuated in lateral decubitus position, the technical word that I will write for this is called as trypopnea. So most MCQs would either expect you to answer this word, that is trypopnea, which means the breathing difficulty accentuated in lateral decubitus position, unlike orthopnea, which is accentuation in supine position, or they will ask you, what will you do for management of this lady? You see, the main reason why I have gone into this discussion towards the end of pleural effusion topic is to sensitize you to the fact that I have to remove the fluid from the chest of this patient. That would be done over multiple installments, and we'll remove the fluid. So how do I remove the fluid so much? I can put in a chest tube, and I can, by putting in a chest tube, I can today evacuate 500 ml. Maybe by tomorrow she's a little better, so I can remove another 700 ml. So by like next 3-4 sittings, like I'll clamp the tube at the end of the total fluid of 500 ml removed today, and then tomorrow again I'll unclamp the tube, remove the fluid and let the fluid escape. So the good news is, like, at the end of couple of days, we have removed entire fluid present in the pleural space. Our breathing difficulty has resolved. Now the problem is that the fluid will come back because the lung cancer is still there. You see cancer infiltrating the chest wall basically becomes stage 4. So like the prognosis is anyway bad, and there would be recurrent pleural effusion, and again I'll have to put in a chest tube or do a thoracocentesis, and that's a very, very painful process. So what I plan to do in this patient is, now listen to me very carefully, what I plan to do in this patient is, after all the fluid is removed, I will be injecting via this chest tube antibiotic. The patient is asking me also, am I having some infection that you are injecting this antibiotic? I'll say, no, there is no infection, but I'm injecting this antibiotic into the pleural space because I want to cause adhesions. I want to cause adhesions between the two layers of the pleura. Let me just rephrase whatever I said so that you are able to retain this. You see, initially, this patient was having a presence of lung cancer, and that was contributing to development of pleural effusion. So now what I've done is I have removed all the fluid. My chest tube is still in place. So let me just reintroduce my chest tube here. This is the chest tube in place. And you can see that now there is no fluid present. Patient is saying, why don't you discharge me? I said, ma'am, what I want to do is that I want to inject doxycycline into the pleural space. You see, the patient is asking me, is there some infection, doctor? I asked you earlier also, there is some infection. You are saying no, then why are you injecting this antibiotic? I'll tell her, ma'am, I want that this antibiotic spreads into your pleural space, and then this antibiotic will cause adhesions to develop between the two layers of the pleura. And if I have adhesions developing between the two layers of the pleura, I know that I'm giving my patient a extra parenchymal, right, outside the lung. So extra parenchymal restrictive lung disease, but I am deliberately doing it to prevent the reaccumulation of pleural fluid in this patient. I want to prevent the reaccumulation of pleural effusion in this patient. So the procedure that I'm talking about at the moment, guys, is what is called as pleurodesis. For this one single word, I had to do the entire hard work of writing this data. There are two main messages that I wanted to remember. One is, why do you have adenocarcinoma of the lung, which is overall the most common lung cancer when it comes to women? It is EGFR mutation, apart from the other ones which are written here. And the second point to be remembered is that after you have removed the entire fluid, you will inject a sclerosing agent that will give the patient an extra parenchymal restrictive lung disease. I know I'm causing a restrictive lung disease, but I don't have a choice, right? When you go to fight a battle, there is going to be collateral damage, right? So the collateral damage is in front of you. You win some, you lose some. So doctors have to draw a balance. I can't win completely. I mean, obviously, like I would have loved to get this patient operated upon. Lots of time the patient will refuse, and the prognosis of the patient is anyway bad. Like the health of the patient is bad. So, like the last resort option we can do is to improve the quality of life, and we can do pleurodesis in these patients. So these are a couple of technical aspects for pleural effusion, and now we'll talk about pneumonia. Very easy to identify. You can see a white patch in the right upper zone of the patient. So lots of time the question will himself mention the word that the patient on a chest x-ray shows the right upper zone consolidation. And after asking you about this right upper zone consolidation, then he will say that what is the most reliable auscultatory finding of this patient. I mean, I'm going to be putting my stethoscope over this area today. Like I was describing pleural effusion, and I described auscultatory findings. I did not write it for pleural effusion. I'll do it subsequently, but I said verbally, distant breath sounds because water is over the lung. And then I said, I said there is a stony dull percussion note. So like here, what will be the auscultatory finding? For pneumothorax, it is absent air entry, absent breath sound. For pleural effusion, it is a distant breath sound. What is the most reliable auscultatory finding of lobar pneumonia? Then your answer would not be given as crepitations. That is what is given in the MCQ. Fine crepitations will also be given. Coarse crepitations will also be given. You will answer none of them. You will say that I will look for bronchial breathing. Well, what is bronchial breathing? Is a inspiratory-expiratory ratio of 1:1. I mean the breathing part and the I've shown the inhalation and the exhalation part, which has an ratio 1:1, and there's an audible gap also present. This is not a continuous process. You hear inspiration, then there's an audible gap, and then after that there is an expiration that is happening. This is totally different from the normal physiology part. Like if you and me, if we do a lung auscultation, then there's no audible gap present. So I'll just write the auscultatory finding for a normal person also. Normal person auscultation finding over the lungs is called as vesicular breathing. For vesicular breathing, the ratio is also different, and the I would say if you hear, though our exam is not OSCE, right? They'll not like make you auscultate a patient and say, okay, doctor, tell me what's the breathing pattern that is present. Though that's what they plan to do in the next exam or after that. In vesicular breathing, the pattern would be inspiratory, expiratory. That would be a ratio of about 2:1. And this would be a continuous process. Like this is inspiration, this is expiration. So there is no audible gap that is present. This that I mentioned, normal, this you can skip and like you can just forget it after listening to it once, because they're not going to ask you the normal data. What they'll ask you is what is the most reliable auscultatory finding a lobar pneumonia. Your answer would be given as bronchial breathing. The data in dotted is just for representational purposes. Also, to ensure clarity in the slide, because lots of you might be using the notes subsequently with the video lectures or maybe my handwritten notes also. So I just want to say 2 points to be remembered from the line diagram shown. Adenocarcinoma is a peripheral lung cancer. It occurs due to EGFR mutation most commonly. It irritates the pleura, so it causes a massive unilateral hydrothorax and causes atrapapnea. You will put in a chest tube, remove the fluid, but then the fluid can reaccumulate. So what do? You inject a sclerosing agent to prevent the reaccumulation of fluid. That's called as pleurodesis. I touched upon that because that word pleurodesis is important. And now coming back to the agenda of pneumonia, the most reliable auscultatory finding would be bronchial breathing. And which organism can cause both typical and atypical pneumonia? Then your answer would be Legionella pneumophila. I'll explain the manifestations of Legionella pneumophila also. This is usually identified by a urine-based test. Again, very peculiar because pneumonia is usually identified on a sputum examination, like a gram stain of a sputum or a bronchoalveolar lavage. But in these patients, it would be like we will be using a urine test, an antigen-based test, or ELISA. Overall, the number one cause of community-acquired pneumonia happens to be pneumococcus, also written as Streptococcus pneumoniae. And this bacteria is also the leading cause of development of bacterial meningitis in children more than 3 months to up to adults up to 55 years of age that I've described in CNS. But if he changes it to ventilator-associated pneumonia, then your answer would be given as Pseudomonas aeruginosa. And there was one question in INISET where Pseudomonas was not in the options. So in those circumstances, you would be answering it as Acinetobacter. So ventilator-associated pneumonia is always going to be causing fever in a patient who's like admitted in a hospital and has been intubated. And sometimes the question could be with respect to children with cystic fibrosis, that is mucoviscidosis. I mean, cystic fibrosis or mucoviscidosis question will always have the keywords. We will say the patient, that is a child, is having recurrent pneumonia episodes. Now, recurrent pneumonia episodes can be seen in multiple other conditions. No, even congenital heart diseases can cause a recurrent pneumonia episode. Down syndrome baby can also have recurrent pneumonia episode. So, what should be written extra in the question that you know that it is cystic fibrosis question being given to you? Then your answer would be steatorrhea. A combination of recurrent pneumonia and steatorrhea is always going to be mucoviscidosis. In some questions, he may even mention manifestations of fat-soluble vitamins like vitamin A, D, E, and K. In one of the papers in the recent years, they included bleeding in these patients also. Yes, guys, that is a feature. Why? Because purpuric rash can develop. That purpuric rash would be primarily because of the bleeding. And that's because of vitamin K deficiency that the manifestation would be occurring. The most common mutation which is present here is F50 mutation, which is due to deletion of an amino acid by the name of phenylalanine on chromosome number 7. There is a defective protein that is found. The protein name is CFTR, that is cystic fibrosis transmembrane protein, which is defective. Normally this protein has 1480 amino acids. This has total 1480 amino acids, in which at 508 position there is deletion of phenylalanine. Look at the extreme amount of info that they're asking in the paper. He's asking you that which amino acid would be deleted and at what position. So your answer is deletion of phenylalanine at 508 mutation and the 508 position, and there are 1480 amino acid sequences present here, and that deletion of 1 is going to contribute to the manifestations that I've written. Less than 10 years of age, if he says what is the usual cause of pneumonia, then from the hospital environment, the organism that would be coming in, your answer would be given as Staphylococcus aureus. But because these patients will require hospitalization subsequently, so in the later part, you will notice that the organism will change over to Pseudomonas. So the answer will depend upon like the age group of the case given to you for cystic fibrosis. Coming to the treatment part of pneumonia, should we hospitalize the patient or should we do a OPD-based treatment? The answer will depend upon CURB 65 score. In Curve 65 score, alphabet C would be standing for confusion or disorientation that would be occurring. Alphabet U would be standing for elevated blood urea nitrogen in the patient. And because blood urea nitrogen report can sometimes be delayed, so it can cause an administrative delay in admitting the patient as well. So nowadays we use Curve 65 score, CRB 65 score instead of Curve 65 score. That is like he says that due to administrative delays, like if the technician will take a long time for the report to come, you will keep the patient in waiting. So he says no need to wait for urea, and just straight away go ahead and do the scoring without the urea component also. Alphabet R for stand for respiratory rate. This you will have to count in the question, and most of these questions are like 3 or 4 liners, so there is no opportunity for you to read the question twice. It is like once or never. So whenever you read, always check out the vitals very carefully, because if he mentions respiratory rate to be like more than 30 per minute, blood pressure to be less than 90/60, and then age of the patient is more than 65 years of age, that the components of Curve 65 score, each of these parameters is given 1 point each. Unlike like a couple of other scores in cardiology that I've discussed, like ABCD score, some parameters have more points, some have less points. Here each of the parameters are having like one point allocated to each one of them. And now the rule of the game is that if a patient scores between 0 to 1, when I say 0 to 1, that 1 is exclusively for age. Like if he says age of the patient is more than 65 years of age, but everything else is okay. I mean, the patient is well oriented in time, space, and person. One is normal, respiratory rate is 20 per minute, blood pressure is 120/80, age is the only thing that is more. So I will tell the patient that, sir, you don't need a hospitalization. We can be doing a OPD based treatment, and we can give oral antibiotics to the patient. But suppose the score of the patient is between 1 to 2. Now 1 has come again, and I want to say that at this point of time, the 1 is except any parameter except age. While I'm writing it, like a query from a lot of people is, sir, I could not understand what you're trying to say, because 1 is coming 2 times in the classification, and like that's why, like, doctor, what do you mean by 1? So what I want to say is, or before I like whatever I explain, like I'll put it in a simpler way. Suppose there's a 60-year-old man with pneumonia, 60-year-old man with pneumonia, and he's confused. Would you like to treat him on a OPD basis? No, no. Or if I say 60-year-old man, 60, 60, so age is not a parameter, right? But respiratory rate is 36 per minute. That's again 1 point present there, no? So if it is any parameter except the age, guys, then you will have to admit the patient. Like a confused patient needs to be admitted, right? So it would be an inpatient IPD basis treatment. You will have to give IV antibiotics for management of this patient. And sometimes the score can go up higher, like it can be 3, it can be 4 in a patient. If the score is 3, like suppose I say 70-year-old man is admitted with diagnosis of pneumonia. Respiratory rate is 36 per minute and the blood pressure is 80/60. That means 3 points. 70-year-old man, diagnosis of pneumonia, respiratory rate 36 per minute, BP is 80/60. One report is awaited. The patient is a little drowsy but not exactly confused. But still, if the 3 score is satisfied, I will be admitting the patient directly into an intensive care unit. In intensive care unit and inpatient, the difference would be that I have a ventilatory support that is available. So most of these questions will revolve around the score of 1. That is because 1 can be for oral antibiotics also, and 1 can be for IV antibiotics also. So do take care of the fact that you will answer oral antibiotics only if the person's score is 1 because of the age parameter. If age is not the cause, if it's a confusion or any one of the remaining ones, then you will answer as IPD based treatment, and I will be giving intravenous antibiotics to this patient. So it is oral antibiotics. This is going to be intravenous antibiotics that would be administered to the patient. And the most important thing is, now he will ask you which antibiotics would be given to the patient. So let's assume that the Curve 65 score of the patient or CRB, the interpretation of both the scores is the same. Whether he says how do you interpret CURB score, Curve 65 or CRB score, the parameters are still the same, 0 to 1, 1 to 2 or 3. So the interpretation remains the same, and the CRB score of the patient is given to be between 0 to 1. That is the 1 part here is because of the age is more than 65. Then I will give oral antibiotics. Which antibiotics would be given? So your answer would be that I'll be giving amoxicillin to the person to cover for typical organisms, and I'll be giving azithromycin to the patient also to cover for atypical organisms, that is macrolide. So combination of the two would be used. But sometimes in questions, just to make it sound a little more trickier, he might mention comorbidity in the question. Comorbidity would mean like the person is having stents in his heart or is a diabetic. Comorbidity could be like it could be chronic liver disease, chronic renal failure, CKD, and the person is having requirement of hemodialysis. HD means having requirement of hemodialysis. Or he could mention the patient underwent a coronary artery bypass grafting, or the person is underwent previously a percutaneous coronary intervention with stenting. So if he's gonna talk about comorbidity present, or he will talk about a previous hospitalization, in those circumstances, I will just tweak my answer. I mean, my answer would still remain the same. I will still be giving oral antibiotics to this patient, but there would be a slight subtle change, and that subtle change is what I want you to pick up. That we have to give beta lactams, so amoxicillin with clavulanic acid. So the only change here is that you will be giving augmentin to this patient, that is amoxicillin with clavulanic acid. And along with this, you will be obviously using azithromycin to give coverage for the atypical organism. So while attempting questions for curve score of 0 to 1, all you need to do is pay attention to the fact that whether comorbidity is given in the question or not. If it is not given, then answer is amoxi with azithromycin. If the comorbidity part is given, then you will answer, or you will be adding clavulanic acid. If there is a comorbidity present, then obviously clavulanic acid would be added. Now, sometimes in questions, he might be giving you a score which is like higher than the mathematical values that I explained to you. So let's do this again. Like suppose I get a question in which the curve 65 score or CRB, the interpretation always goes the same. The score of the patient is between 1 to 2. And in these circumstances, I have decided to give inpatient IV antibiotics. Needless to say that a person going into intensive care unit will also be given IV antibiotics, but we can do better monitoring now, because in ICU the nurse to bed ratio is 1:1. So more intensive monitoring of the patient can be done. So whether it is 1, whether it is 2, or it is more than 2, like I can write even a 3 here, I will have to give IV antibiotics to this patient. What are the antibiotics that would be given now? We will be giving ampicillin, sulbactam, or ceftriaxone, standard ceftriaxone that we use also in meningitis, along with intravenous azithromycin to the patient. So azithromycin is like obviously for those atypical bacteria that we're talking about, but here you can notice that we are again giving beta lactams and we're giving ampicillin sulbactam, or it's ceftriaxone with azithromycin. Now, when you give so many antibiotics to some patients, they can develop a diarrhea. Like you're aware of pseudomembranous colitis, where Clostridium difficile overgrowth can cause like a post-antibiotic induced diarrhea. And that can be seen with IV antibiotics also, right? It's not only that oral antibiotics cause that, even IV antibiotics can contribute to development of this kind of an issue. So like, what should I be giving now? Like this patient, I started him on these antibiotics. He's saying, sir, please stop such strong antibiotics, doctor. They're causing diarrhea in me. So I can be starting respiratory fluoroquinolones in the patient. A lot of the MCQs that you will be getting with respect to curve score of 1 to 2 or 3, they might be having in the options respiratory fluoroquinolone. So we can be using like levofloxacin, or we can be using moxifloxacin, or we can be using gemifloxacin. You can remember the word LMG, not light machine gun, but L is for levofloxacin. It's literally machine gunning the organism though. And then is G here is not for gatifloxacin. Gatifloxacin is for gram-negative bacteria. That's also an antibiotic, no, gatifloxacin. Here it is gemifloxacin. So he will ask you about IV respiratory fluoroquinolones in a lot of situations of in patients. That is, if there's obviously a or present here, like provided in the MCQ, like the superior ones are not given. Obviously, they can be multiple correct also in any state variety. So you need to remember all the combinations. The ones in blue, ampicillin sulbactam with azithromycin is 1. Ceftriaxone with azithromycin, it is or. It's not and. It is or. And now comes the and. The end part is along with these antibiotics. Like suppose I have started to keep my life easier, I started the patient on moxifloxacin or levofloxacin, and the question is also mentioning like recent hospitalization, prior respiratory isolation. So because person has been hospitalized, exposure to Staph aureus will be there. So now I have to add antibiotics. So previously I was not saying that I am adding, like it is either levoflox or moxiflox or gemifloxacin, or it's gonna be ceftriaxone with azithromycin, or it is ampicillin sulbactam with azithromycin. But now I have to add coverage, because if person is in the hospital environment recently, that means like Staph aureus exposure can be there. So what antibiotic would be given for Staph aureus exposure is linezolid, Obviously, the culture sensitivity report will also help, but we have to give linezolid for the patient. If he talks about Pseudomonas aeruginosa, then this is a more dangerous organism. Like, can you tell me what is the antibiotic of choice for Pseudomonas aeruginosa? Yes, guys, I think you studied pharmacology. What is best? Because nowadays there is going to be multi-drug resistance present. So you will say that the best one is meropenem. If meropenem is not in the options, then you can answer Piptaz, that is piperacillin and tazobactam. That's sometimes the brand name that was given in the paper, Piptaz, that is piperacillin with tazobactam. The main message at the moment is that this entire slide where antibiotic names are given, if I zoom out, has to be verbatim recalled by you if asked in the paper. Most of the time they'll give you a curve score of like 1, 2 or 3. One as a, I'll, and once again I'll like just mark it here to say that the one is except for age. It is except for age. So that's the critical point in most MCQs on NEET PG, that if it's gonna be age group of a patient given alone as a parameter, then we take it as OPD based treatment. But I score a 1 except age, like confusion or all the other things that I said, then it is IV antibiotics that would be given. And if there is like hospitalization or like comorbidities, respiratory isolation described, then I have to expand the spectrum of antibiotics given by giving linezolid. Here, like the query that I get from a lot of students is that we were taught in pharmacology that for Staph aureus, which is vancomycin, most of the hospital strains are now this vancomycin resistant Staph aureus. We were taught daptomycin. So let me tell you, when will you answer daptomycin? Daptomycin will be answered for CLABSI. CLABSI stands for central line associated bloodstream infection. I'll write this once again. You have put a central line, it could be jugular vein, or instead of jugular, it can be subclavian vein. So central line associated bloodstream infection in the hospital, like you could be having blood cancer patient, febrile neutropenia patients, immunity is low. So for these patients, bloodstream infection is present, and I need to aggressively manage because Staph aureus is coming in. So for CLABSI, the antibiotic of choice, if the culture shows Staph aureus, would be given as not linezolid now. Linezolid has a very good penetration in the lungs. So for VRSA in the lungs, it is linezolid because the antibiotic can penetrate to the lungs. But in the bloodstream of the patient, I can be using daptomycin for my patient. So for CLABSI, if it is caused by Staph aureus, then it is going to be IV daptomycin. I have one more question for you. Suppose it is a fungal sepsis. Suppose it is a Candida albicans, Candida sepsis occurring in a patient, because febrile neutropenia patients can have like central line associated infection can be Candida sepsis also. So can you tell me for Candida sepsis, what antibiotic would be used? You want me to give options? Okay, options are like fluconazole, micafungin, liposomal amphotericin B, plain amphotericin B. I'll say the options again and don't check out the notes. Answer from your pharmacology. Fluconazole, micafungin, then is liposomal amphotericin B and plain amphotericin B. Yes, guys, 5 seconds. Okay, so I'm very sure you were able to work out the answer, that is micafungin. We give echinocandins for management of these patients because fluconazole is like a fungistatic drug. I need to give fungicidal. So it is echinocandin that would be given. So there are many of them available. One of them is like micafungin. That's like, these are like fungicidal drugs that we give for invasive fungal infections in a patient. So depending on the culture reports, we'll have to decide what antibiotics would be given. But CLABSI is again an important cause of death in intensive care unit. And a lot of patients of ventilator-associated pneumonia can deteriorate. They might be on multiple antibiotics, including on meropenem, but ultimately due to multi-drug resistant, we lose those patients. Now, as far as pneumonia, pleural effusion, and pneumothorax are concerned, I have, like for pneumonia, I did not say anything with respect to tracheal position. The tracheal position will be central. But for the case of a pleural effusion, you will always be having a contralateral deviation to the opposite side, obviously. That is, fluid will be putting pressure. For pneumothorax, again, the same thing. It would be contralateral deviation of the trachea. As far as the percussion note is concerned, it would be dull note for pneumonia. For pleural effusion, you will say that the percussion note is stony dull, and for for pneumothorax, I've already explained to you, that would be hyperresonant note. In our lungs, it is resonant. Here, it would be hyperresonant. Then absent air entry and absent breath sounds are a feature of pneumothorax. Absent air entry and absent breath sounds are a feature of pneumothorax. For pleural effusion, however, mark my words there, for pleural effusion, the air entry will be less because the lungs are squeezed by the fluid. So the air entry in this particular case would be reduced, and the breath sounds in this case will appear distant. So just like in pericardial effusion, there are distant heart sounds, here there will be distant breath sounds present. And in pneumonia, air entry will be normal. This is a common error point, guys. Air entry क्यों normal होगा? क्योंकि there is no obstruction in the airways. Where is the pus in pneumonia? In the alveoli. In the alveoli. So air entry will be normal in this particular case, but the nature of breath sounds in this case will change. The nature of breath sounds in this case would be with respect to bronchial breathing. So remember the information there. Bronchial breathing is where the inspiratory-expiratory ratio 1:1. We also call it a tubular breathing. So breath sounds with respect to pneumonia is bronchial breathing. The air entry is normal. There is no obstruction of the airways, but in pleural effusion, the airways are squeezed from outside, and there's a distant breath sounds present. And for pneumothorax, तो कभी भूलना ही नहीं है यार, ये तो this is like non-negotiable. Absent air entry and absent breath sounds are a feature of pneumothorax. And now we will write about conditions where we get a ipsilateral tracheal deviation. Normally, it's always a contralateral tracheal deviation, but I'll be writing before you conditions in which you get a ipsilateral tracheal deviation in a patient. Yes, guys, this would be with respect to one, idiopathic pulmonary fibrosis, then can be a segmental collapse of the lung. So whenever we read about like collapse, segmental collapse, or idiopathic pulmonary fibrosis, that's where we get a ipsilateral tracheal deviation. That's just an extra point to be remembered. Otherwise, by default in pleural effusion, which is massive, and pneumothorax, it will be air at positive pressure that will be contributing to a tracheal shift in the patient. Also, I want to say that overall the most common cause of pneumonia when it comes to AIDS patients is not Pneumocystis jirovecii, it is pneumococcus. This was asked in NEET PG also. It was almost a 4 or a 5 line question, and like students were so because CD4 count low was also given. So a lot of students, they just said, sir, CD4 count was hardly 100, so I answered Pneumocystis jirovecii. I said only one thing, man, CD4 count does not diagnose the infection, right? CD4 count will tell you increased susceptibility, but HIV positive patient would be living in the community, so he will also get a community acquired pneumonia. So the most common cause of pneumonia in AIDS patient is not Pneumocystis jirovecii. When will you answer jirovecii? Only if the bronchoalveolar lavage image is given in the question that I'm going to show to you subsequently. Otherwise, this is an important question which can cause like loss of like an important precious mark, because jirovecii is like so tempting to answer here, that you need to curb that impulse. Similarly, the most common cause of tension pneumothorax is not a penetrating trauma. It's not a penetrating trauma. Harrison says it is a barotrauma. I agree, surgeon will not dispute that. He will say no, trauma is because they see trauma only, right? But Harrison is like a balanced book which is mentioned in overall that the most common cause of tension pneumothorax is barotrauma followed by penetrating trauma. Then what is the best site for insertion of a wide bore needle with respect to tension pneumothorax in adults? Then I have already explained to you, it is fifth intercostal space. The site where you will be putting it is usually anterior to the mid-axillary line. Tension pneumothorax in a kid would be like second intercostal space. Then you have to go a little lateral, because if I go medially, I can injure the great vessels related to the heart. So I want to go lateral to the mid-clavicular line. And then comes another important aspect, atypical bacteria by the name of Legionella pneumophila. Legionella pneumophila can cause development of SIADH. Just you are comfortable with the fact that oat cell cancer causes SIADH. No, most common paraneoplastic manifestation of oat cell cancer is SIADH. In the same spirit, SIADH can be associated with Legionella pneumophila. And this will be the only MCQ where because of SIADH, hyponatremia would be described to you. In no other pneumonia MCQ, electrolyte report will be given. If they give you a pneumonia patient, right, cough, breathing difficulty, sputum, and then say person is sick, saturation is dropping, X-ray is given, and you know that, okay, I'm dealing with a case of pneumonia. In your mind, you're calculating curve 65 score. He's not even asking you that. He will mention in this particular question, patient is drowsy. So you'll say, okay, man, curve score is like, going towards that state where I need to admit the patient, but the drowsiness is not due to hypoxia. Pneumonia patient being drowsy is either due to hypoxia, like hypoxic encephalopathy, but in this case, it will be an electrolyte imbalance because Legionella causes SIADH. So if you ever get a question in which hyponatremia is given with pneumonia, your answer is always Legionella pneumophila. And this is one bacteria that can cause both typical as well as atypical pneumonia. Then is another question in which he will mention regarding pneumonia, but then he will also say person is having low hemoglobin. I mean, normally a pneumonia patient is not supposed to have a low hemoglobin. Evidence of hemolysis, how will he write hemolysis? He will say LDH values in the patient are elevated. Then the organism that is to be thought of is Mycoplasma pneumonia. There's a black urine in this patient as well. The reason for that black urine is, let me say this rectangle represents this bacteria by the name of Mycoplasma pneumoniae. Mycoplasma pneumoniae is a bacteria which is one of the smallest bacteria. It does not have a cell wall. It has a cell membrane, and present on this cell membrane a couple of antigens which are called as P antigens. At the moment I said this bacteria, the name of the bacteria is Legionella. The name of this bacteria this time is Mycoplasma pneumoniae, and this has P antigen present. Now the problem is that our red blood cells also have an antigen which looks like the P antigen, and therefore the antibodies which are produced against this bacteria will get confused. I'll repeat the data once again. There is an antigen sharing with respect to the bacteria. Like the black is the representation of bacteria. The antigen chemical structure is identical to a protein which is present in the RBC membrane of ours, and therefore the antibodies which are produced in the body of this person are like confused, because antibodies are supposed to destroy the bacteria, so obviously they will do that, but they will also damage the red blood cells. Self RBCs will be affected, and therefore this person will develop autoimmune hemolytic anemia. Look at the peculiar thing I'm teaching you. Person had suffered from pneumonia with Mycoplasma pneumoniae, and now he's having passage of black color urine, because when the RBCs will burst, then there would be hemoglobin coming free in the blood, hemoglobinemia, and this hemoglobinemia would then translate into hemoglobinuria, because hemoglobin will be filtered across the kidney into the urine, and hemoglobin is not red in color, it is brown to black in color. So therefore this person might be passing a black color urine. Look at the peculiarity. Pneumonia patient passing black urine is always a atypical pneumonia. So I hope I've been able to justify before you. Earlier the word atypical pneumonia was coming because there was an electrolyte imbalance, but this time it is not electrolyte imbalance, it is cross reaction. Antibodies produced against the bacteria are getting confused. They're attacking self red blood cells, so that's why the name is autoimmune hemolytic anemia, hemoglobinuria. And when I'll write the description now, you will say, yes boss, we have read about it. This description that I've given before you with respect to Mycoplasma pneumoniae is also written in books as PCH, that is paroxysmal cold hemoglobinuria. So one of the questions that is taught in pathology, though at that point of time, most of the time this explanation would not be coming, they just say PCH is seen with mycoplasma, maybe some mnemonic or hack would be taught to you. But what I've tried to do is explain with rationale. Like you can see the word cold hemoglobinuria describes that, from the cold perspective, and like cold means like pneumonia occurring in a person. Like that's one way to remember. And paroxysmal cold hemoglobinuria is contributing to formation of these autoantibodies which are attacking self red blood cells. The name of these antibodies is again to be remembered. The name of these antibodies is called as Donath-Landsteiner antibodies. When you check out your pathology notes, when you will check out the topic of PCH, that is, this name will come up once again. So I had to go into this discussion to sensitize you to the fact that Mycoplasma pneumoniae is one of the smallest bacteria, and this does not have a cell wall. It has a membrane on which an antigen that is present will cross react with the antigen present with respect to RBCs, and that's why, because of this cross reaction, RBCs get busted. When RBCs get busted, therefore LDH will rise, hemoglobin will fall. So either you can solve the question on the basis of lab report, and if you are not analyzing the lab report, another thing would be written, that is change in the color of the urine, because hemoglobin is not red in color, it is brown to black in color. So this patient had a pneumonia and is now developing a black color urine. That is why I'm calling it a atypical pneumonia. For Mycoplasma pneumonia, I can also say that these patients will be having symptoms that will be like, not very aggressive like that of pneumococcal pneumonia or Pseudomonas pneumonia. But like these patients, x-rays are going to be totally white. Like you will also notice that Mycoplasma pneumonia, in fact I'll write it here separately apart from PCH fact, Mycoplasma pneumonia is also called as walking pneumonia. Why it is called as walking pneumonia is because patient will be a walk-in into the outpatient department, but when you will do x-ray for this person, like this patient came in the OPD, he said, I'm having fever, I'm having cough, I'm having breathing difficulty. Normally pneumonia patients are supposed to be very sick. We don't expect them to walk into the OPD. We expect them to be coming on a wheelchair, we expect them to be coming on a brought on a stretcher, but here the patient has come walking into the OPD. And when you will check out the x-ray of this patient, the x-ray is going to be so white that you'll think, okay, this patient's x-ray looks like a ARDS patient's x-ray. I mean, like so much of whiteness in an x-ray that I was literally thinking maybe the radiology people messed up. They have put somebody else's x-ray. I thought somebody else patient, ARDS patient in the hospital, his x-ray has been like, tagged to this particular person. So I even maybe, I thought like, let me call up radiology and try and find it out. But like most of the time with like the technology that we have and barcoding that we have, it is very, very unlikely that we'll be having any situation where such for wrong reporting can be done. So finally, the conclusion is that in this condition, there is a clinico-radiological mismatch. What I imply by clinico-radiological mismatch is that the patient's symptoms are not going to match with the X-ray. The symptoms are going to be relatively lesser, and the X-ray is going to be extremely, extremely white as what you can imagine for an ARDS patient. So because of the two reasons that I mentioned, clinico-radiological mismatch and the black urine and evidence of hemolysis, that is why it is called as atypical pneumonia. Minimum that I expect you to know right now, right here is if they give hyponatremia, it is Legionella, and if there is a hemolysis evidence given, then you will say paroxysmal cold hemoglobinuria due to Mycoplasma pneumonia. Next up is organism-specific pointers to pneumonia. The first one is for Legionella pneumophila. As I explained to you, this can cause both typical and atypical pneumonia. The best test for this condition should be answered as a urine Legionella antigen, but then we use a selective culture media as well. The name of this culture media is very peculiar. This is a black color culture plate. It's called as buffered yeast charcoal extract. BYES is the name of the culture media that we use there. I'll write the full form here as well, but the peculiarity of this culture plate would be that it will be black in color, because traditionally we see like, that blood agar or chocolate agar for Haemophilus influenzae. But at the moment I mentioned a black colored culture plate, that's called as buffered yeast charcoal extract. Now, as far as the drug of choice for management of this condition is concerned, because it is an atypical pneumonia, so you will answer azithromycin for management of this condition. The second entry that I would like to mention in this particular table is for Staph aureus, which is a cause of nosocomial pneumonia or hospital-acquired pneumonia. They have also given a question like after how many hours of hospitalization. Like suppose this patient was admitted for elective cholecystectomy and on the third day of admission he develops a pneumonia, then he would have got it from the hospital environment. Like suppose somebody developed a pneumonia within 24 hours of hospitalization for some elective procedure, then he would have been carrying the infection from the home. But if somebody develops it after 48 hours of admission, then it is hospital acquired infection. And it's not only the cutoff that is important, the radiological finding is also important. What you can see here is multiple small chota cystic cavities which are present in the lung of this patient. These chota small lung cavities will ultimately unite with each other to form a lung abscess. These chota lung cavities are what are called as pneumatocells. So this is a radiology question that pneumatocells are found in. Answer is Staph aureus pneumonia. And these pneumatocells unite with each other to form a big cavity. This big cavity will ultimately be filled with pus. The pus due to gravity will obviously settle at the bottom, and superiorly there would be air present. The air will be visible as black and the pus will be available or visible as white. So what I also want to bring to your attention is that in the x-ray of these patients, in the later part of the illness, he may mention that there is a presence of an air fluid level. This is again very peculiar because traditionally you read about air fluid level with respect to like an x-ray abdomen, but in this case I'm describing a air fluid level in x-ray chest of the patient, where you can see there would be a concentric shadow of air on the top, and then subsequently there would be like pus at the bottom which will appear white, and I'll show you an image of lung abscess subsequently as well. Now the next one is Klebsiella pneumoniae. If you ever read a question that begins by saying alcoholic with pneumonia, it's always Klebsiella pneumoniae, and the hint in the question can be a red currant jelly sputum. And in fact, sometimes the pus in this condition, like you can notice a significant consolidation that is happening in this area, where I'll be able to auscultate bronchial breathing, where I'll be able to like do percussion and there would be a dull note present. But you can notice this convexity, not a concavity, but a convexity that is present. This convexity is what is called as bulging fissure sign. So this is again a radiological finding that helps you identify that the organism responsible is Klebsiella pneumoniae. This entire presentation that I have given for Klebsiella pneumoniae in microbiology is also called as Friedlander's pneumonia, because in microbiology, Klebsiella pneumoniae is called as Friedlander's bacillus. So the term that's used here by the examiner to quiz you about this entire presentation is called as Friedlander's pneumonia. The pointers to be remembered are a total of three: alcoholic with pneumonia, red currant jelly sputum, and then is bulging fissure sign. Those are like the classical terminologies for this necrotizing pneumonia. I mean, the damage in this condition can be so extensive that even this condition can contribute to development of cavity in the lung, though uncavity and then a lung abscess. Though overall, if I talk about like what is the most common cause of lung abscess, then overall most common cause of lung abscess would obviously be answered as like Staphylococcus aureus. But any organism that can contribute to necrotizing pneumonia will cause a lung abscess. Next is the situation of anaerobic lung abscess. You can see a big cavity at the moment. I'll just put the markings here. It's irregular margins, and then there is like it's a big cavity which is filled with pus. So like why is somebody developing a anaerobic lung abscess is mainly because of microaspiration. So the possibilities in the question can be either he can mention this guy is comatose. In all comatose patients in CNS have been very vocal about intubating the patient with a cuffed endotracheal tube to prevent any aspiration of own saliva. So either he could begin with a comatose patient. Now the reasons for coma can be like, he can begin by saying drug intoxication. Like this guy, he ate, like on the Holi festival, he drank alcohol, he drank a lot of bhang also. So drug intoxication is one of the reasons, or comatose could be due to head injury. Then in my CNS discussion, I said one of the leading cause of death in Alzheimer's disease and Parkinson disease is aspiration pneumonia. So even in Alzheimer's and Parkinson, in the later part of the illness, the gag reflex and the cough reflex would get suppressed. So in all of these situations that I've written here, whether it is comatose due to drug intoxication, head injury, Alzheimer, Parkinson disease, the common denominator is that the protective lung reflexes are getting suppressed. Protective lung reflex would mean gag reflex. Protective reflex would mean like a cough reflex. If any of these two reflexes or both of these reflexes are gone, then there's a high chance of microaspiration of own saliva and there would be anaerobic lung abscess developing. For this anaerobic lung abscess, it can be a two-step question. He may not ask you regarding this, like this is an anaerobic lung abscess, because that is understandable. If somebody's gag reflex, cough reflex will get suppressed, then microaspiration saliva will occur. He will ask you what is the treatment. Then the treatment to be given for this particular case would be answered as clindamycin. Here, because it is anaerobes, I've seen a lot of people answering metronidazole as well. So metronidazole will not work very well for this condition. So what we need to use is clindamycin for management of anaerobic lung abscess. The reason for this is microaspiration of saliva due to impaired gag reflex and cough reflex due to neurological disorders. Now comes the much awaited Pneumocystis jirovecii. For you to answer Pneumocystis jirovecii, what should be the hints that are present? The question will begin by describing a AIDS positive patient, but that is not the answer. Like AIDS patients normally would be having pneumococcal pneumonia. So what should be given in the question is, one is the X-ray findings. Like if you look at the X-ray here, the positive findings, or I would say there is like bilateral infiltrates present. There is no like pan consolidation or extensive consolidation. It's like multiple white shadows, which are more on the left side as compared to that on the right. So bilateral infiltrates would be given. Now, the next thing that we'll do in this patient is a bronchoalveolar lavage, or we can take the sputum of the patient as well, and we will be subjecting it to a stain. The green stain that you see here, this is called as Gomori-Methamine stain. In fact, I can say that in your exam, from the pneumonia perspective, this is one slide which is very frequently asked, Gomori-Methamine stain, and then you can see this black cyst of Pneumocystis jirovecii. The appearance of these is what is referred in the textbook as like a ping pong ball appearance. The Gomori-Methamine stain shows a crushed, the word would be that the Gomori-Methamine stain shows the presence of a crushed ping pong appearance of the cysts of Pneumocystis jirovecii. That's like the classical word that he wants to hear. Additional point that may be given in some questions is increased alveolar arterial gradient. Yes, guys, A minus A gradient. Normal value is about 5 to 15. Here it is increased because there is like a interstitial pneumonia present in this patient. So if any of these data are given in a AIDS positive truck driver, bilateral infiltrates, obviously he's supposed to have cough and breathing difficulty and fever. So those standard prerequisites are there. I've not written that. That's pretty obvious. Fever, cough, breathing difficulty. But then bilateral infiltrates in a chest X-ray, sputum showing onagamori methamine stain, crushed ping pong ball appearance. Or for that matter of fact, he says increased alveolar arterial gradient. That is when we will think in terms of pneumocystis jirovecii. And even in this case, it can be a two-step question. Instead of simply asking you like, okay, what is the diagnosis? He might say, what is the treatment? So for the treatment of this condition, we'll be using cotrimoxazole. Now, cotrimoxazole in some MCQs is written as TMP-SMX, that is trimethoprim and sulfamethoxazole. This is the drug that is always present in ratio 1:5. Trimethoprim is more lipid soluble, so the ratio is about 1:5, and the alternative name for this is cotrimoxazole, or is also called as Septron. Now, all these cases of pneumonia can deteriorate into ARDS, and ARDS became famous because of COVID-19, but any bacteria could be responsible for it. And you can notice extensive bilateral whiteout. In fact, he will say the word bilateral infiltrates, and this would be a total whiteout. I mean, the lung is always black, and here you are literally hunting for the black. I mean, it's mainly totally white. ARDS is an example of non-cardiogenic pulmonary edema. Traditionally, we read about cardiogenic pulmonary edema, that is a bat wing edema, but this is a non-cardiogenic pulmonary edema. So we always have to do echocardiography in ARDS diagnosis so that we can rule out the cardiogenic cause. I'll tell you those diagnostic criteria also. They called as Berlin's criteria. Let's work out the causes. Overall, if he says what is the most common cause of acute respiratory distress syndrome, then the first cause of this would be answered as pneumonia. It can be bacterial, it could be viral, it could be fungal pneumonia, whatever, but pneumonia is the number one cause. After that, the answer would be given as sepsis. Sometimes the question might be written as like, what is the direct cause? That would be obviously pneumonia. Indirect cause would be answered as sepsis, because in sepsis there would be like cytokines that would be released. Then apart from pneumonia, I would like to mention a couple of other important conditions. One of them is, he might say patient was given fresh frozen plasma, and within 6 hours of infusion of the fresh frozen plasma, there was a breathing difficulty. So in fresh frozen plasma, there could be antibodies that could be like causing damage to the lung endothelium, and there's a non-cardiogenic pulmonary edema. Fresh frozen plasma more than blood transfusion is one aspect for TRALI, that is transfusion-related acute lung injury. Within 6 hours of the transfusion, there would be starting of respiratory distress in a patient is another pointer which is to be remembered for giving answer as transfusion related acute lung injury, which results in acute respiratory distress syndrome. It can be seen after blood transfusion also with packed RBCs, but then with fresh frozen plasma, the chances are relatively higher. Then after TRALI, another cause to be remembered is aspiration of stomach acid. Like this patient was intubated, there was an emergency intubation done in a head injury patient, and while that rapid sequence intubation, the patient vomited. So there would be aspiration of stomach contents into the lung of the patient. The chemical pneumonitis that develops due to aspiration of stomach contents is what is called as Mendelssohn syndrome. So among the direct causes, the important ones could be pneumonia, obviously number one, but TRALI and Mendelssohn syndrome could also be present. Meaning of the word Mendelssohn syndrome is aspiration of stomach acid contents during a rapid sequence intubation. Now, as far as the diagnostic criteria for this condition is concerned, we'll first have to take into consideration PaO2 FiO2 ratio. Normal PO2 FiO2 ratio in you and me would be like in the range of about 500 or more, but in these patients, the value would be always less than 300. In fact, if he mentions in a question value between 200 to 300, then we'll say it is mild. If the values are between 100 to 200, we'll say moderate. Anything less than 100 is like severe. So sometimes this categorization can be mentioned with respect to mild, moderate, and then subsequently a severe acute respiratory distress with PO2 FiO2 ratio. Then as I said, because this is a non-cardiogenic cause, so we need to rule out presence of left atrial hypertension, because if pressure in the left atria is more, then it's always a left ventricular failure, and that means cardiogenic pulmonary edema. So we always need to do an echocardiography in these patients to prove that the pressure of the left atria is normal. We need to demonstrate that there is no elevated pressures in the left hand side. In fact, for the left hand side, the term that he might use is not left atria. He might write the word pulmonary capillary wedge pressure, PCWP. Pulmonary capillary wedge pressure. Okay, I'll write it separately, otherwise it will cause a confusion. Pulmonary capillary wedge pressure, PCWP, normal value is 8 to 12 millimeters of mercury. This is always elevated in patients of, super elevated in patients of cardiogenic pulmonary edema. Like if a person is having mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, if there's a cardiogenic cause, there's a cardiogenic pulmonary edema, then pulmonary capillary wedge pressure would be super elevated. But our case is non-cardiogenic pulmonary edema, so the echocardiography, the left atrial pressure should be normal, and the X-ray should be showing extensive amount of bilateral white infiltrates. Like the X-ray will be so white that you will be literally hunting for the black component present here. And this is totally different from the bat wing pulmonary edema. We got bat wing pulmonary edema will start from the heart, but here, like I've not started the edema from the heart, I've shown it directly in the lung fields of a patient. And like I said, the lungs will be so white that you'll be hunting for the black component. And if this happens within 7 days of lung injury, we say person is having ARDS. Let's do the diagnostic criteria. The criteria say that I moved the slide deliberately. PO2 FiO2 ratio should be less than 300. The left atrial pressure should be normal on an echocardiography, and the changes in the lung should happen within 7 days of an insult. Insult can be pneumonia, sepsis, Prahlad, Mendelssohn syndrome, toxic gas inhalation, like in Bhopal gas tragedy that occurred way back in 1980s in India, the worst industrial disaster in the world. People of Bhopal, they died of toxic gas inhalation that was leaking from that Union Carbide American factory. The gas was methyl isocyanate, so there also people died because of ARDS, and you can see the extensive bilateral infiltrates that will develop in the lungs of the patient. But obviously, like CT chest may not be available routinely, but chest X-ray would be available, and that is why I said bilateral infiltrates within 7 days of lung injury. Then they would love to ask you what is the management of this condition. So there are two aspects from the management perspective that I would like to state. One is that the person should be subjected to a low volume ventilation. Normally, whenever we ventilate a patient, the tidal volume can be set on the dashboard of the ventilator. The formula for setting the tidal volume is 12 ml per kilogram of body weight. But in ARDS patients, we don't ventilate at 12 ml per kg. We rather ventilate them at 6 ml per kg. Why we do that is because the alveoli are already injured. If you will fill the air at 12 ml per kg in the lungs of this patient, then it will contribute to barotrauma. Like if I have to ventilate somebody with Guillain-Barré syndrome, in Guillain-Barré syndrome, there is no damage in the lungs. So I can take the settings on the ventilator as 12 ml per kg. This is the traditional ventilator setting. Even if you don't remember that number of 12, I just want to explain from the COVID time that in COVID initially we were ventilating patients at 12 ml per kg. They were dying because they were developing pneumothorax, and then we had to put in a chest tube that used to worsen the patient. Then we realized we were doing wrong. In COVID we gradually learned how to ventilate patients, and you saw suddenly we were able to get patients off the ventilator in spite of the fact that they developed severe COVID-19, because we started ventilating them at 6 ml per kg. That is half of what is normal. This is the normal ventilator setting. This value 12 you don't need to note down. This is just for understanding purposes that normally in Guillain-Barré syndrome or in any patient of diaphragmatic paralysis, I will ventilate at 12 ml per kg. But if alveoli are injured in acute respiratory distress syndrome, I will ventilate at 6 ml per kg. In the paper, he will not ask you the word 6 ml or 12 ml. In paper, he will ask you this word that aside low tidal volume ventilation will be done in the patient. And along with this, we will keep the PEEP. PEEP stands for peak and expiratory pressure. So the PEEP of this patient will usually be kept as more than 5 centimeter of water, and the tidal volume settings would be kept on the lower side. The rationale for keeping a high PEEP is that it causes like a forced opening of the alveoli. If you force open the alveoli, then the surface area available for gas exchange will improve. I said if you generate a peak and expiratory pressure, just go by English, and expiratory pressure, you are inflating the alveoli. If you inflate the alveoli at the end of the expiration, you are causing a increased surface area available for gas exchange, and that increased surface area available for gas exchange would be the recruitment of alveoli that would be done in this case. So the statement is low volume ventilation would be like the tidal volume is kept on the lower side, the PEEP is on the higher side. That is what he will make permutation combinations. Low tidal volume, low PEEP, high tidal volume, high PEEP, and then low, high, high, low, and low, high. I mean, I hope you got the concept right. It's low tidal volume and a high PEEP that would be used for management of this patient. And second would be a prone position ventilation. We will be ventilating the patient while we keep the patient on the belly. If you remember COVID time 2021-22, in COVID-19, we used to tell the patients to sleep on the belly. those who could not be hospitalized, because it improves ventilation perfusion. So this is again very peculiar, because normally in respiratory diseases patients are made to sit up in the hospital bed, or we even sometimes provide a small table in the front so that they can lean forward and relax their shoulders and use the accessory muscles of respiration. So most like respiratory patients would be sitting forward, hunched position, hands on their thighs, leaning forwards like this. But here you will be maintaining the patient in a prone position, that is patient would be lying on a belly. So prone positioning is itself a question, that in which respiratory condition would prone positioning be recommended. And then an additional thing which I would like to add is that for COVID-19, now obviously now COVID-19 is not anymore present. For COVID-19 we were using steroids, that is methylprednisolone. This is obviously not valid as of now. This is just to say that for COVID-19 pneumonia, which was causing conversion into ARDS, that we were giving steroids to control the cytokine storm that these patients were developing. These diagnostic criteria were formerly called as like Berlin's criteria, but nowadays this term may not be used. It is only for historical importance that I might write this word Berlin's criteria for mentioning like for the older MCQs variety. But what they will ask you simply diagnostic criteria of ARDS. Your answer would be that the PaO to FiO2 ratio should be less than 300. There should be normal status of the left atria. The pressures in the chambers of the heart should be normal. No end diastolic pressure elevation should be present, which is a feature with heart failure. Bilateral infiltrates, and within 7 days of lung injury, these manifestations would be developing. So these are features of acute respiratory distress syndrome or ARDS. And now we will talk about COPD, that is chronic obstructive pulmonary disease, which would be related to cigarette smoking. And here we will first talk about Modified Medical Research Council, MMRC, grading of dyspnea. MMRC stands for Modified Medical Research Council grading of dyspnea. In grade 1 dyspnea, though there's a grade 0 also, but I'm focusing on what they will ask you, that is grade 1. You can just draw an image like this showing that a person is going up an incline. So the shortness of breath is experienced by the patient, but this shortness of breath is when the patient is walking up. The patient is walking up an incline, not experienced by the patient the shortness of breath when he's walking on a smooth surface. Now for the second one, I told this person to take a walk in the hospital corridor with his wife. This is a cigarette smoker. He's walking with his wife at the moment. His wife is also 60 years of age, and this particular person is also 60 years of age. And you will notice that this person will be having shortness of breath and like difficulty in breathing when he's walking, and he will be walking slowly. Like in this patient, the breathing difficulty is coming even when the patient is walking slow as compared to peers. Like his wife is 60 years of age, she's also walking with him. Like two people of 60 years are walking together, and I am comparing with the same age patient that he walks slowly. The patient is walking slowly as compared to peers, and like if he tries to walk fast, there's a shortness of breath that would be experienced by this patient. The breathing difficulty would come in. At this moment, I want to also say the fact that we will not compare this patient with a younger patient. Like I'm not making him walk with his grandson or granddaughter, because like his grandson is 5 years of age and they always want to play. So they will run, they will walk fast. So I don't want this guy to walk with a person younger than his age, like a child or adult. I want him to walk with somebody of the same age group. That is why I said the word peers, that is people of the same age group, and the person is walking very slowly. And if he tries to catch up with them, that's when the breathing part difficulty will become noticed. Now for grade 3 dyspnea, same patient, he did not follow my advice and has come to me after, let me say, another 2 years. Now what will happen is he will walk, like, let me say 100 yards, then he will stop. Like I asked him, what happened? He says, I'm feeling very uncomfortable and I'm having breathing difficulty. Let me catch my breath. Then he will again walk 100 yards and then he will again stop. I said, come on, man, like I expect you to do better. So please don't stop. He's still walking with his wife. I made him walk with his wife. She's also 60, he's also 60. This cigarette smoker will be walking slow as compared to peers. That is okay. But at this moment, what you will notice is that the information that I'm saying for grade 3 dyspnea is same information as 2. The information that I'm saying is same as the information provided in 2, but the additional point is that the patient stops intermittently, that is to catch his breath. So I told him next time we will try to walk 200 yards instead of like 100 yards. He says, okay, sir, I will try. But after reaching 100 yards, maybe 105, 110, he will just stop. I said, come on, you promised me. He says, sir, hota nahi hai, sir, I've tried, I'm having breathing difficulty, let me catch. He's not going to sit down. He's saying, I'm having breathing difficulty, just let me rest for a while and then I'll again try to do the same thing. So the difference between 2 and 3, as you can see in the discussion, is in 2, he walking slow as compared to peers. In 3 also it is walking slow as compared to peers, but he's stopping intermittently. And when it comes to the grade 4 in MMRC, I can just make a symbolic wheelchair here. Like today the weather is very very good, there are roses present in the garden, and like it's a very beautiful weather. So I told the COPD guy, sir, please get up from the chair and let's see how you walk in the park today, the weather is so good. He refused. Normally a old person, going out in a park and children playing, a good atmosphere, a person would be like, more than willing to go into a good ambience or a good atmosphere. The guy refuses to walk. So at this particular point of time, we will be noticing that the person will be experiencing shortness of breath, and this shortness of breath would be present at rest also. That is while he's on a wheelchair or he's on a chair and the patient refuses to go out. A lot of these patients might be purchasing a motorized wheelchair in future to be able to continue with their physical activities. So the message is, if he goes up an incline, that's gonna be 1. If this walking slow as compared to peers, so shortness of breath is coming, it's 2. If he stops intermittently and the breathing difficulty is noticed, that's gonna be 3. And if it's like wheelchair bound, shortness of breath even at rest in a person, like the mobility part of the patient is significantly compromised, that would be like 4. And at this moment I would just like to modify this statement by saying that this shortness of breath would be translated into hampering daily activity also. Daily activity would mean, like I can say, like if I expect this guy to go to the washroom, daily activity, like if he has to go to the washroom to just urinate or defecate, he will be too breathless to do that activity. So sometimes family members will have to literally push the wheelchair to the washroom of this patient, assist them so that they can do this activity. Or for that matter of fact, another aspect can be like a change of clothes. Now these are activities that we don't even think about. No, like if I say washroom, change of clothes, etc., these are not kind of physical activities that we have to think about. We don't even like realize that we just went to washroom and we changed clothes, whatever. Here, like daily activities in a patient would be significantly compromised. So I rephrase that statement to say that, yeah, the guy is having breathing difficulty at rest, but that would be limiting to such an extreme event that daily activity, there would be a shortness of breath experienced by a patient. So these are like 4 statements that I want you to remember for the MMRC grading of dyspnea. And now we will study about gold grades of COPD. Gold's grade of COPD would be like mild, moderate, severe, and very severe. And this is where a large number of questions have come. So we need to remember that if the FEV1 of the patient is more than 80%, and the timed vital capacity will be given in all of these questions, it would be less than 0.7. In fact, that is standard definition of word obstructive airway disorder. In restrictive airway disorder, time vital capacity is more than FEV1, FVC ratio is more than 0.8. Here it would be less than 0.7 and FEV1 will be more than 80%. If they give you a question where FEV1 is between 50 to 80%, and along with that the time vital capacity is less than 0.7, both information should be given, then you will say it is gold 2 or moderate level of COPD grading. In case he gives you severe, then your FEV1 values would be given between 30 to 50%. This is the NEET PG MCQ that had come. And what happened in the paper was, a couple of guys, they casually answered as FEV1 less than 30. That is not for severe, it is for very severe. Why this is important is, or why this was asked is, because normally all classifications will have like mild, moderate, severe, but here it is 4: mild, moderate, severe, and very severe. So you need to remember that for severe it is not 30%, it is more than 30%. That is the question that you will get in a lot of apps also, that they'll ask you what is severe COPD. Don't answer less than 30, don't answer less than 30, answer it as 30 to 50% for the gold grades. The gold would stand for Global Initiative for COPD Management. That's just the number one authority that is going to be dealing with COPD. So one is MMRC grading of dyspnea, then is the grading of COPD severity that I have mentioned at the moment. Let's just do the MMRC grading once again without looking at the slide. Going up an incline, breathing difficulty. Walking slowly as compared to peers, if it tries to catch up, breathing difficulty becomes accentuated. Breathing difficulty is there, becomes accentuated. In 3, he has to stop intermittently to catch the breath. And in 4, it is like day-to-day activities like going to the washroom, etc., would be causing severe disability in a person. Like activities that we don't even think about would be causing a problem. Now what he has done in the update is, in the update he has mentioned gold groups as like A, B and E. Earlier it was A, B, C and D. Here we will take into consideration, low symptoms, or like we will take into consideration exacerbations that are happening in a patient. Most of the time in the MCQ, they will mention that patient is having multiple hospitalizations and multiple exacerbations. If it is going to be multiple exacerbations and multiple hospitalizations, I need to be more aggressive. Like in gold group A, like there are low symptoms and maybe no hospitalization in last 1 year. Low symptoms and no hospitalization 1 year. I can use any BD, that is any bronchodilator. Here he says you can be using LABA, you can even be using SABA in a patient. I mean, if there is a need, then any bronchodilator can be used. But if the person is having more symptoms, then I would like to combine two drugs, that is LAMA with LABA. That is most of the time we'll be giving to the patient tiotropium, which is a long-acting LAMA. I mean, LAMA is meaning long-acting. And can you tell me from your knowledge of pharmacology, the longest-acting beta-2 agonist, ultra-long-acting beta-2 agonist, which works for 24 hours? Yes, your answer here would be indacaterol. The molecule that I'm writing at the moment will work for approximately 24 hours. I can be using formoterol also, it works for about 10 to 12 hours, but indacaterol will be working for approximately 24 hours. So this is the molecule that will be preferred at this moment. And now whether to go forward or not, I will be doing a test in the patient, that is absolute eosinophil count. This again is a question, that absolute eosinophil count, because normally you read about eosinophil count being used for like management of asthma, or like it is a feature that is seen with allergic asthma. But today I'm saying I'm using eosinophil count in the blood for as a guide to treatment in COPD. So if we will give you a situation of multiple exacerbations and hospitalization, one, you will answer this as gold group E, and in this case you will say that the decision making will be based on blood eosinophil values. If they're more than 300, that is when you get benefit from steroids. I mean, if the sputum eosinophils of the patient are more than 300, that is when we get benefit from steroids. That is obviously inhaled corticosteroids that could be given like budesonide or beclomethasone or fluticasone. Standard instructions would be rinse the mouth with water, because you want to decrease the risk of oropharyngeal candidiasis. But I mentioned a step-up treatment for these patients. The step-up would be, initially we can be using a LABA. Now, if the person is having like, more symptoms, then I will upgrade to LABA plus LAMA. And then subsequently, as you saw, that if there are multiple exacerbations, hospitalizations, then I will do a test by the name of blood eosinophil count, that is called as absolute eosinophil count. And then I will add ICS in this patient, that is inhaled corticosteroids. I'll just erase it. I just wanted to say that there's a step up that I'm basically discussing at the moment. And the most important thing is, or most of the questions with respect to gold groups will be mentioning for gold group 3 treatment. Then they will ask you regarding gold grade 3 for severity. And then they will ask you with respect to what I mentioned was MMRC grade of dyspnea. 3 must know MCQs on this particular page are: one is MMRC grade 3 is difficulty in breathing, that is accentuated and walking with another person of the same age so bad that the patient has to stop intermittently to catch his breath. That is point number 1. Then is severe COPD. Severe COPD is defined as FEV1 between 30 to 50% and not less than 30%. The third point is he will give multiple hospitalizations, exacerbations. You will say the group that he will belong to from the allocation perspective for treatment. This is allocation for treatment would be group E, and we will be using 3 things: LABA, LAMA, and then inhaled corticosteroids with absolute eosinophil count being used here. And yeah, at the same time, I can say that single canister should be used. I mean, I'll not use 3 different canisters or meter dose inhalers. It is like a single canister having all the 3 medicines that would be used. Then is couple of miscellaneous informations here, like clubbing is not seen in COPD. The counterpart MCQ that I would like to mention for this is fastest clubbing is seen in. Fastest clubbing is seen with respect to lung abscess. And one of the important causes of lung abscess was discussed just previously, that is going to be Staph aureus. Initially, pneumonia will cause pneumatoceles, and then they'll unite to form a big cavity containing pus, that is a lung abscess. So fastest clubbing would mean that there would be like that parrot beak appearance of the nails. Parrot beak. Normally our nails would look like this, no? Like if this is the representation of nails in us. In this condition, there is production of a cytokine by the name of platelet derived growth factor, and this excess production of PDGF. What is the cytokine involved in clubbing? It is called as PDGF, platelet-derived growth factor, and it will cause development of clubbing. Clubbing is seen with lung cancer. In lung cancer, it will take like maybe 2 months, 3 months to occur, but here it will occur over like couple of weeks itself. So that's fastest clubbing is seen in lung abscess, but clubbing is not seen with COPD. Then you will also notice that in COPD, the patient will be having a barrel-shaped chest. Meaning of the word barrel-shaped chest is that the anterior-posterior diameter of the chest will be more than the transverse diameter. In you and me, the transverse means shoulder to shoulder diameter. Yours and my transverse diameter is more than our AP diameter. But in this patient, it is the AP diameter, the anterior-posterior diameter of the chest, which is more than transverse. And the patient will try to sit in a tripod position, leaning forward in his arms, and there would be a Hoover sign that would be present. Hoover would mean that the chest would be sucked inside. When you and me breathe, our whole chest expands. When you and me breathe, we have a bucket handle movement of the ribs and our whole chest expands. Here, the chest would be sucked inside. That paradoxical inward movement of the chest is what is called as Hoover sign. It basically tells you that the muscles are working more than normal. Diaphragm is contracting with more force than normal to enforce, that the patient's lungs can be ventilated better. And COPD is an example of a condition where there can be an exacerbation and person can develop carbon dioxide retention. At this moment, I also want to say that in COPD, asthma, both of them, residual volume in the patient is increased. In both COPD as well as in patients of asthma, what we will notice is residual volume will be increased due to air trapping. The reason is residual volume is increased due to air trapping. That's a common statement which is to be remembered with respect to both asthma and COPD. I'll just discuss the diagnostic criteria for these two also. But since I said residual volume is increased due to asthma and COPD, the question rises, how would we measure it? Then the answer is not spirometry. Spirometry cannot be measuring. Spirometry cannot be measuring residual volume. The method used is body plethysmography. This is more of a physiology-based question, but has to be remembered. What is the best method to measure residual volume? Body plethysmography. It is not spirometry. Then emphysema will be having alveolar scarring because emphysema has alveolar scarring. So DLCO, that is diffusion capacity of the lung for carbon monoxide, or for that matter of fact, any gas will be substantially reduced. Alveolar scarring is the reason why the surface area available for gas exchange would be lesser. In contrast, when it comes to asthma, the DLCO value will be increased. I'll describe DLCO again, diffusion capacity lung in asthma time, but at the moment the rationale is alveolar scarring. Then we will have to give steroids intravenously. Intravenous hydrocortisone is used in both COPD exacerbation and severe acute asthma management. Management of asthma, severe acute asthma will be discussed in a while, but we should not be using oral steroids in a patient. And the most important MCQ is he will give you acute exacerbation of chronic bronchitis, acute exacerbation of COPD. I've already spoken about it in the APG section. This causes carbon dioxide retention. Whenever you have carbon dioxide retention in the body, this will cause type 2 respiratory failure. Meaning of the word type 2 respiratory failure is that the PO2 will obviously be less because it's a lung disease, and PCO2 will begin to rise. This rise of PCO2 will make the patient become drowsy, and sometimes you might even get a development of asterixis in a patient. Rise of PCO2 will make this patient start feeling drowsy, and along with that, there can be a flapping tremor. Traditionally, we read about asterixis with hepatic encephalopathy. We read about asterixis with uremic encephalopathy. But today I'm teaching you asterixis with carbon dioxide retention and type 2 respiratory failure. Type 2 respiratory failure, what does it mean? Type 2 respiratory failure is buildup of carbon dioxide in the body. What do you mean by the word type 2 respiratory failure? Is always a buildup of carbon dioxide in the body, and that will contribute to respiratory acidosis in this patient. So how will I manage this patient is like the most important MCQ of this particular slide. Your answer is tight fitting face mask. We'll use a NIV in the patient. I taught you mnemonic by the name of ABC earlier: acute pulmonary edema, acute exacerbation of chronic bronchitis, severe COVID-19, and NIV has come up in the discussion again. But don't answer it for mortality reduction in COPD. If he says what is the best intervention to reduce mortality in COPD, the first intervention is obviously quit cigarette smoking. So I will mention about nicotine de-addiction also. I'll also mention what are the drugs that can be used for nicotine de-addiction. But at this moment, from the therapeutic perspective, from the perspective of pulmonology, what you need to do in the patient is use LTUT. LTOT stands for long-term oxygen therapy, where we use low-flow oxygen. We don't give oxygen at 6 liters per minute. We give them oxygen at a rate of 1 liter per minute. LTOT is long-term oxygen therapy. The oxygen is given at 1 liter per minute, and the device that we use and ask them to purchase from the market from where the LTOT is given is oxygen concentrator. It will give oxygen even at 6 liter per minute, but we will tell the patient not to keep the settings at 6 liter. We want some residual hypoxia. This is the second most important information on this particular slide, that in patients who are suffering from like COPD, we don't want a saturation of 95 to 98%. We deliberately want a target value of approximately 98 to 88 to 92%. That residual hypoxia will cause a continuous stimulation of the respiratory center. We want the respiratory center to work harder than normal because lung tissue is damaged now. Lung tissue is damaged in this patient. And then comes a word of wisdom. NIV is contraindicated in unconscious patients with cardiovascular instability. So if the patient tends to have like a drop in blood pressure or the patient becomes unconscious, then we will not, because then aspiration risk will be more. Now if you're putting a tight fitting face mask and God forbid if the patient vomits, all the vomiters will go in the lungs of the patient. Aspiration pneumonia risk is there. So NIV is contraindicated in unconscious patients. It is the preferred treatment in a person of COPD who's going towards drowsiness. But once he converts from drowsiness to unconscious, difference is drowsy patient, I can still awaken the patient. I can say jago. Right, patient will open his eyes, talk to me. So if I go to the bedside, patient is lying with his eyes closed. I started talking to him, he opened his eyes. So I can say, okay, drowsy because of illness, and he started talking to me, or he at least tried to acknowledge my presence. But if the person is lying with his eyes closed, not opening his eyes, then I will not use an IV. Then I have to intubate the patient only. These are 4-5, like in fact not more than 4-5, like high yield MCQs that you need to remember. Starting from clubbing is not seen in COPD, fastest clubbing is seen in lung abscess, and ending with 3 core things that I'll say once again. Treatment of choice for acute exacerbation of chronic bronchitis. If you forget everything about COPD, I understand that. I finished that in almost 2 pages. But if you forget everything about COPD, chalega, but you can never be forgetting this statement of mine. Acute exacerbation management is NIV. We will give IV steroids, chalega, bronchodilator, steroids, nebulization, everything will be on, but we have to go in for NIV in a patient. And how to prevent these manifestations from occurring is put them on LTOT, long-term oxygen therapy. We'll ask them to purchase an oxygen concentrator, and this can be powered into electrical source. It will make oxygen from air. Oxygen concentrator makes oxygen from the air, and we will give them oxygen with help of a transparent plastic nasal cannula. It has to be good quality, 1 liter per minute for 16 hours per day. That's why the word is LTOT. It is long-term oxygen therapy, and the objective is to achieve a target SpO2 of 88 to 92% to keep some residual hypoxia, to make their lungs do more hard work, because lung parenchyma is injured. So I want to increase the work of breathing. For nicotine reduction, if he says like what is the main medicine that would be used, then you would be knowing from pharmacology the name of the molecule is varenicline. What varenicline does is it blocks these receptors which cause dopamine release in the brain. This medicine is a alpha-4 beta-2 partial agonist. You know sufficient pharmacology to know that even a partial agonist can block the effect of the drug, that is nicotine. So nicotine reduction, the drug of choice for nicotine reduction should be answered as varenicline, that is by brand name of Chantix or Champix. They are available as 0.5 to 1 milligram tablets to be given for 3 months, and they basically block the so-called pleasure that comes from smoking by inhibiting the release of dopamine. Now we'll focus on a common error that can happen in a question. Like he mentioned, this female, she's having breathlessness and cough for a couple of years, which has worsened. She's having a smoking history also. So like it tells us that the patient is having like COPD. Then he mentioned a bronchodilator based improvement of FEV1 also, and the X-ray showing emphysematous changes. So everything looks to be in favor of that the patient is having COPD. But then there are 2 pointers which are going against COPD or like would cause confusion in your mind. One is history of atopy, and second is that in this patient the improvement is 12%, though I'll discuss that in asthma, but from the main videos you would have said that in asthma the cutoff is usually like 12% or higher. So here you have to think, should I answer as asthma, should I answer as COPD, or should I answer as asthma COPD overlap, because history of allergy is also there and the FEV1 improvement is pretty substantial going towards the asthma range, So the answer in this question would be given as option number A, that is the asthma COPD overlap. There, I mean, like one I have COPD, one I have asthma. Differentiation is based on the FEV1 changes. If FEV1 changes after bronchodilator is less than 12%, I say it is COPD. If it is more than 12%, I say it is asthma. But if it is at 12% and there is a history of atopy present, then I will say it is asthma COPD overlap. I'll say that again. If you give a bronchodilator and the change in FEV1 before bronchodilator and after bronchodilator is more than 12% asthma, less than 12%, then you will say COPD at 12%, and along with that atopy history given, you will say asthma COPD overlap syndrome. Guys, this crazy question came in FMG exam. When I checked out this question, initially I thought, man, this must be any set question that is asking so deep. He asked that question in FMG exam. Anyway, the point is these examiners sometimes to satisfy their ego, they put up, this is what I sent this question to a respiratory specialist. Even he was in a dilemma. It can be any of the two. So if a respiratory specialist can be in a dilemma, you can understand a MBBS student would not be in a very good position to solve these kind of questions. But some of these questions, which I can call as bouncers, would always be present. And yeah, just a word of mention here, residual volume due to air trapping is increased in asthma COPD, but spirometry does not measure residual volume. So you will have to utilize body plethysmography as a method for this. Next up is the topic of bronchial asthma, where the main important diagnostic criteria, which has been asked upteenth number of your times, is that what is the change in FEV1 before and after giving salbutamol to the patient? Because asthma is a reversible airway disorder. Therefore, for demonstration of this reversibility, the FEV1 should be rising by minimum at least 12% or at least more than 200 ml of air. Like suppose before giving bronchodilator, like lots of time in MCQs, they might write the word pre-BD, that is before giving bronchodilator to the patient, the FEV1 of this chap was suppose 50%. Now I have given salbutamol to this patient. I told him to wait outside the spirometer room for 15 minutes. After 15 minutes, my technician will call up the patient again in the spirometer room, and I will ask him to breathe out into that mouthpiece of the computer of the spirometer. When he will blow into the mouthpiece, the FEV1 recording of this person is now coming to be 65% because salbutamol will be causing beta-2 agonism, and that beta-2 agonist will cause bronchodilation. So FEV1 is rising. The increment is more than 12%. So I'm saying it is bronchial asthma. I've already explained to you that when it comes to COPD in a patient, the change of FEV1 before and after giving salbutamol to the patient will be less than 12%. If it is equal to 12%, then it is asthma COPD overlap. If it is more than 12% or more than 200 ml air, then we are saying it is bronchial asthma. The word pre-BD means before giving bronchodilator, post-BD means post-bronchodilator as the name suggests, and we don't check immediately. We wait for 15 minutes for salbutamol to have its basic effect on the beta-2 receptors, and then the bronchodilation part will show a increment in the value of FEV1. The next aspect to be remembered is that DLCO is increased in asthma. The reason for this is in contrast to patients of like emphysema. Emphysema has alveolar scarring. So diffusion capacity of the lung for carbon monoxide is reduced in emphysema. But in asthma, because there is more blood vessels present around the each of the alveoli, there is hypervascularization of airways, and this explains that there is more surface area available. More surface area available means better transmission of gas basically present. For DLCO, increase or decrease, like usual questions are asked, so I'll just mention a quick mnemonic here as well. If he specifically says in the question in which condition would you be having is a DLCO of the patient showing a rise versus a fall, most of the time he will ask you the rise. Then you can remember a mnemonic by the name of ACP. Obviously not Assistant Commissioner of Police that I'm saying, but DLCO is increased in A, C and P. So let's just put up the data. Asthma, then is congestive heart failure. Yes guys, you will answer DLCO being elevated. Then is going to be pulmonary. This is pulmonary hemorrhage syndrome. Pulmonary hemorrhage syndrome is also called as Goodpasture syndrome. In Goodpasture syndrome, because there are antibodies which are present against the basement membrane, so basement membrane will be destroyed, and if anatomical layers of the lung become lesser, then the gas diffusion will be better. So ACP is a mnemonic for DLCO being increased. Contrast this with DLCO being lesser. The best example of DLCO being lesser is interstitial pneumonia. And the best example of interstitial pneumonia that I can mention before you is like pneumocystis jirovecii pneumonia, or I can mention the word bird handlers pneumonia, COVID-19 pneumonia. In all of them, the DLCO, that is diffusion capacity of the lung, will become lesser, or another condition where DLCO will be less would be interstitial lung disease. This data that I mentioned before you is from physiology. If you are aware of this, no need to note it down, just can keep a mental note of the same. But yes, the important aspect is DLCO is increased in asthma. The rationale is hypervascularization of airways, so more like surface area available for gas exchange. Whereas when it comes to emphysema in a patient, I'm writing the word emphysema now. When it comes to emphysema in a patient, there is a alveolar scarring that is happening. So because of that alveolar scarring, the DLC of the patient would be lesser. Then we have childhood asthma versus adult onset asthma. The adult onset asthma is idiosyncratic asthma or intrinsic asthma. Remember like this, E alphabet comes before I. E alphabet comes before I. Children would come before adults. Now, first we are a child and then we become adult. I mean, that's just a hack to remember. If you read the word extrinsic asthma, that is childhood asthma, is always having a good prognosis. That is, childhood asthma is related to immunoglobulin E. In childhood asthma, you will always notice IgE levels would be elevated, response to steroids will also be good, and most children having childhood onset asthma after 10 years of age, the severity of the disease will become relatively less. But in adult onset asthma, which is intrinsic asthma, which is beginning with alphabet I, IgE levels will be normal, and it can coexist with nasal polyps that you tend to read as Samter's triad in ENT as well. So I'll not get into that Samter's triad, will just make a verbal mention of the same. And like in adult onset asthma, the severity tends to increase with the progressive age of a patient. So adult onset asthma tends to worsen with age, and why it's called as like idiosyncratic is because immunoglobulin E levels in this condition are normal. That's the point that the examiner wants to hear from you, that in adult onset asthma, IgE levels are normal and it's predominantly a neutrophil based inflammation, whereas when it comes to pediatric onset asthma, it's mainly a eosinophil based inflammation that is present. That is why we get a better response to steroids in pediatric onset. Now, the latest test which is available for diagnosis of asthma is called as FeNO, because asthma has hypervascularization, it has inflammation present, and that inflammation produces nitric oxide, which can be measured. Values of more than 50 particles per billion indicate eosinophilic inflammation likely and steroid responsiveness as well. In fact, I can at this moment say a term by the name of type 2 asthma. Type 2 asthma is a phenotype which responds very well to biologicals as well as to steroids. In type 2 asthma, that is like the term type 2 asthma is used. Like normally we read about type 2 diabetes, but I'm teaching you a type 2 asthma, which is mainly based on cytokines like interleukin 4, interleukin 5, and interleukin 13, and these respond very well to biologicals. So I will speak about biologicals like benralizumab, etc. in the later part of the discussion, but I wanted to bring to your attention 2 points right now. FeNO is the latest test for diagnosis of bronchial asthma. In this condition, we are checking for exhaled nitric oxide. Please don't mix it with inhaled nitric oxide test. That inhaled nitric oxide test is also called as vasoreactivity test. This has been mentioned with respect to pulmonary artery hypertension. I repeat my statement. If you read the word inhaled nitric oxide test, then we call it a vasoreactivity test, and that is used for evaluation of patients of pulmonary artery hypertension. That's again an important question, inhaled nitric oxide test. But if you get a question in which he mentions the word exhaled nitric oxide, then it is going to be bronchial asthma, and especially which variety of bronchial asthma, your answer would be type 2 asthma, in which we will have to use biologicals, because here cytokines like interleukin 4, interleukin 5, and interleukin 13 would be present, and FeNO values more than 50 particles per billion indicate a high possibility of eosinophilic inflammation. At the moment, the data is FeNO is exhaled, and for inhaled it's for pulmonary artery hypertension. But in like government hospitals, we don't have such fancy tests available like FeNO. So in a government hospital, what we will be using is a simple flow volume curve, as you can see here. And in a flow volume curve, you will notice a concavity because there's a bronchospasm, so it will take longer time for the air to go out. I'll just hand draw this line representation here. This is like status of lungs of you and me. This is a baseline representation. For an asthmatic patient, the inspiration part is normal. The asthma is a disorder of expiration, guys. So inspiration part will be normal. This is inspiration part inferiorly. This is expiration part superiorly. When person will be asked to breathe out, that is when you will notice this severe concavity that is coming, because there's a prolongation in exit of air out of the heart, exhalation of air out of the lungs of the patient. Obviously, asthma is a disorder of expiration, so that is why I highlighted this curvature present here. And if I will give bronchodilator to this patient, then you will notice that this concavity will become lesser. So what I did with my patient was I told him that we will now give you salbutamol. Please sit outside the spirometer room after giving 2 puffs of salbutamol. After like 15 minutes, when I will call the patient again, the inspiration part will remain almost the same. It will trace the original blue curve. But now you will notice that because the bronchospasm will become lesser, so more air will be able to go out of the lungs. And I've also reduced the concavity present here. And the computer by itself can calculate the change in the surface area available or area under the curve. I can say mathematics now. This area under the curve is the one that is increasing here, and that's the value of 12% that I was explaining to you. Guys, bronchial asthma is a disorder of expiration. These patients will have to spend energy in pushing air out of lungs. Expiration is a passive process. You and me don't spend any energy, but asthmatics, they get fatigued and tired of breathing because they have to push air out of the lungs because of the bronchospasm component. What I've shown before you in dotted red will be written as like pre-bronchodilator. BD means bronchodilator. And the dotted green that I've shown before you, this is the report of the patient post bronchodilator. So what we are noticing is the surface area and the curve is improving as compared to what is earlier. And apart from this, this is the traditional way of identifying bronchial asthma in our hospitals. We tend to call it flow volume curve. I will teach you flow volume curve of restrictive airway disorder also when the time comes. But at this moment, this is the conventional way. And the increment that is shown here is about 12% increase in the surface area, which is the first statement that I said. Let's revise the facts on this particular statement. First is FEV1 should rise by 12% or 200 ml of air after giving bronchodilator. DLCO will be more rational. I explained superiorly, more surface area available. In adult onset asthma, we don't get good response to steroids, and rather the disease worsens with age. It is called as, that's why it is called as idiosyncratic and intrinsic asthma. Extrinsic is the pediatric onset one, which was very good response. Pheno exhaled for inhaled answer pulmonary artery hypertension, and then is the flow volume curve here. So a lot of data was condensed into one single slide, but that covers a significant large number of questions. Now coming to the management of a case of bronchial asthma, like the scenario given to you is acute exacerbation. This patient after the Diwali season is having a attack which is so bad that the person is not able to like even breathe properly. So the person has called you and is asking you like what medicine should he take. I know it's a recorded class, but I'm going to put up a quick question to you guys. What would you recommend for acute exacerbation of asthma? Options are SABA or LABA. SABA is short-acting beta-2 agonist. LABA is long-acting beta-2 agonist. What would you recommend? Guys, for management of an acute exacerbation of bronchial asthma, SABA is not recommended anymore. He says SABA, the problem is one, it will act for short duration. Second, there's a risk for tachyphylaxis. That means tolerance to the drug is there. So we don't recommend like SABA for the patient. Rather, what is recommended nowadays is a LABA with rapid onset. The LABA with rapid onset that we're talking about is formoterol, and this would be combined with inhaled corticosteroid because asthma is an inflammatory disorder. So that is why we are giving inhaled corticosteroids to the patient, and this should be obviously like budesonide along with formoterol. That is the medicine that would be used. The main message is SABA alone use is discouraged. He says tachyphylaxis risk is there. Tachyphylaxis means tolerance, and multiple dosages would be required. It will fatigue out the patient, tire out the patient. So for acute exacerbation of bronchial asthma, the recommended treatment is LABA with rapid onset with inhaled corticosteroids. Obviously, by default, you will be telling the patient that you have to take, you have to rinse the mouth with water after every usage. Now the difference between step 1 and step 2, the medicine is the same. It is low dose ICS and LABA only. The only difference is how frequently are you taking the medicine. Like in the initial part, the patient could be having less than 2 attacks per month. So if the person is having less number of attacks per month, then I'll be using medicine less frequently. If the patient is having more than 2 attacks per month, like after the Diwali season, I said the attack frequency will tend to increase. So the patient will be taking the medicine more frequently. So the message at the moment is with respect to step 1 and step 2, the difference is only with respect to how frequently the medicine is being used. In step 3, again, it is low dose maintenance inhaled corticosteroids and LABA. But in this particular case, now what we will be recommending to the patient is to take the medicine on a daily basis. This is because now the attacks have started occurring daily. Like now the month is November middle, or like a lot of smog in India. No, North India, you would have seen November, December, you look at the sky, it's all gray. So because of the poor AQI hitting up to 1000 in Delhi, the symptoms are occurring in a patient on a daily basis. So I will be recommending the same medicine, but it would be taken on a daily basis. Would be taken on a daily basis by the patient. The difference between step 1, step 2, and step 3 is only with respect to the frequency of administration of medicine, but it will still remain low dose inhaled corticosteroid. Now, if symptoms are occurring in spite of this, and night awakenings are also there, like I'm writing night awakenings plus minus for step 3. But suppose I say that the night awakenings are also present and they're more frequently happening, then I will upgrade the dose of steroids and I will go to medium dose inhaled corticosteroids with the LABA. And in spite of that, if symptoms are occurring, what will you do? Then your answer is you will add LAMA. The concept to be understood is in 1, 2, and 3, the difference between 1 and 2 is less frequency versus more frequency of the same drug usage. In step 3, it is daily administration of the medicine that is to be taken. Then what will you do next? It is after low dose, it is medium dose steroid. For medium dose, we don't usually recommend a high dose steroid. We recommend adding on a LABA. Along with this, we refer for assessment of phenotype because most of the patients at this point of time might be having a type 2 asthma, and these patients of type 2 asthma, the testing done is pheno. We will be able to manage these patients very well using biologicals. He says we can use high dose maintenance inhaled corticosteroids, but again, like I'm saying that this is like fraught with risk of adrenal suppression. Yes, guys, do like high dose steroids cause Cushing syndrome, yeah, and they cause adrenal suppression also. So like in government hospital, we use oral steroids also, but here he says like one thing I want to say that oral steroid use is strongly discouraged in both COPD management. In government hospital, left, right, and center, you will be writing oral steroids in exacerbation, because we don't have facilities for all this. What you do in the OPD and what you should be doing ideally is totally different, guys. Oral steroids are a big no for both asthma management. You do MCQs on this. You can use theophylline. Theophylline also causes side effects in COPD patients, poor patients, but don't give oral steroids. Though I mean that's what we do. We give methylprednisolone short duration, but he says not recommended. He says rather what you are supposed to do, because in your exam they'll ask you the American algorithm. So your answer would be that if it is going to be upgradation of treatment, I'll be giving LAMA to the patient. And after that, I will consider biologicals. Biologicals could be like mepolizumab. Mepolizumab is a molecule that will block interleukin 5. It is produced by eosinophils. It helps in eosinophil survival, so it would be useful. And then benralizumab is a molecule that blocks the receptor of interleukin 5, which is produced by like eosinophils and helps in histamine production. If I just quickly run through the data here, one is the word MART. MART means that there is like maintenance and relief that we are doing in a patient that was in step 3. AIR stands for anti-inflammatory reliever. In fact, the terms that you should be very comfortable by this particular point of time is controller and reliever. Controller means that it will be preventing the future attacks from occurring, and reliever means that it will cause an immediate relief. So the controller medicine that you are using that will prevent the further attacks is inhaled corticosteroids. The reliever that you are using in the patient to take care of the current attack is English no reliever. Immediate relief is LABA, because LABA for Metrol is rapid acting in onset. What you saw here was that what we do in our patients is we prescribe a single puffer of low dose inhaled corticosteroids with LABA, and I will ask the patient to use it as and when required. Now, if the attacks are persisting, the frequency of usage of these will continue. I mean, they will be taken more frequently. But suppose the person is taking the medicine and at the moment, like daily symptoms are occurring in a patient, then earlier it was as and when needed. Earlier I had written as and when needed, but I will upgrade from as and when needed to daily. That is like what was being discussed with respect to step 3. And then if there is still not an improvement, I will be upgrading now to medium dose inhaled corticosteroids with the LABA. If there is still not an improvement, then what will you do? Then your answer will be, I will add in this medium dose inhaled corticosteroid will continue and LABA will continue. But what will you do is add LABA, and you will also consider biologicals at this particular point of time. So this is the step up algorithm that you need to remember. Low dose ICS with LABA as needed, then upgrade to daily, then daily medium dose inhaled corticosteroids with LABA. To that you have to add LAMA, that is like tiotropium, and then biologicals to be considered like mepolizumab and benralizumab. And when it comes to severe acute asthma, Severe acute asthma is what is previously referred as status asthmaticus, where the patient will progress towards the silent chest. I mean, like silent chest is obviously bad news because now the person would be on the verge of dying. So what I can say is I've divided asthma into three parts. It is acute. Initially, the word was acute exacerbation of asthma. This is the mildest form of asthma. From acute exacerbation, patient will upgrade to severe acute asthma and then to impending respiratory failure. How do you differentiate between the two is that in severe acute asthma, patient will be saying, I am not getting breath, like he will speak in words. But if he will not be able to speak totally mum, that means the diaphragm of the patient is beginning to fail. You will start getting tachycardia. You might get pulsus paradoxus. Due to hyperventilation, there would be carbon dioxide washout from the body. So there would be respiratory alkalosis and there would be a loud wheeze. But ultimately, the muscles will get tired. And when the muscles will get tired, the person will start developing paradoxical breathing. Our breathing is thoraco-abdominal. Our chest moves more than the abdomen. Now it was abdominothoracic breathing. Abdominothoracic breathing would be that the abdomen will now be trying to move the diaphragm because diaphragm is tired. In this time, you have to intubate the patient. You have to manage the patient by like ventilatory support because patient is now going towards carbon dioxide retention. The chest would be totally silent. Guys, this is status asthmaticus full-blown development. Now the term status asthmaticus is not used. We use the term asthma with impending respiratory failure or imminent respiratory arrest. At this point of time, you will not get a tachy, but you will get a bradycardia. Person will not be able to talk. He'll be lying with his eyes closed. If an asthmatic is lying with his eyes closed and the chest is silent, it is super bad news. You will have to intubate the patient. Let's look at the treatment for severe acute asthma, that is one in the middle. The severe acute asthma patient will need hospitalization. So you will say that I will be admitting the patient in the emergency department and I will be doing nebulization with SABA, that is salbutamol. This is where salbutamol is used. So if you answered salbutamol earlier, then that is wrong, guys. Salbutamol is not used in acute exacerbation. It is used in severe acute asthma exacerbation. This would be done at least next 3 times every 20 minutes. Like patient came right now, 3 times you will do nebulization with salbutamol over the next 1 hour every 20 minutes. Over the 3 times over the next 1 hour every 20 minutes, we would be doing nebulization of this patient with salbutamol. Lots of us, when we start nebulization, we don't attach oxygen inlet. Like there's an inlet for oxygen at the backside of the nebulization chamber, so that oxygen must be attached. It must always be by default a oxygen driven nebulization and not like air driven nebulization that worsens the ventilation perfusion imbalance. The oxygen that you're giving should also be warm and should be humidified, that is from the piped hospital supply. Don't give oxygen directly from the cylinder because it would be chilled and cold. It will worsen the bronchospasm. So oxygen driven nebulization should be done. Lots of time because of paucity of the points for oxygen. In government hospital, we might be starting the nebulization without giving oxygen to the patient. That is a air-driven nebulization. He says that worsens ventilation perfusion imbalance. So we should be giving is a oxygen-driven nebulization, and obviously salbutamol is going on. Now here he has also asked a practical question. He said what parenteral bronchodilator can be given if the nebulization port is not available. Like suppose in your hospital 2 nebulization ports are there. Peak winter, cold December evening, and the 10 patients in the queue. So you already made like a roll number wise, you allocated them chits that after you, then the second person, third person, but the 10th person in the line will complain that my number will come after a very long time, I'm dying. So what you can do in that person is, he gave a practical situation. He said you are in a government hospital, limited setup. There are 2 nebulization ports available with oxygen, and you have 10 patients in the queue. So what parenteral bronchodilator can be given while the patient is on a waiting list for nebulization? You can give subcutaneous terbutaline to the patient. I've written plus minus after this to say that you will not give it in all cases if nebulization with salbutamol is not available. If nebulization with salbutamol is not available, that is when this strategy would be used of giving parenteral bronchodilator to the patient. Then you will secure a IV line and you will give hydrocortisone. I have already explained to you, hydrocortisone is by default given to all patients of COPD exacerbation and asthma. He has also asked why would you give it? So it will inhibit an enzyme. The name of this is phospholipase A2, and this is the villain which is responsible for production of those cytokines which play a role in pathogenesis of bronchial asthma, like leukotrienes, leukotriene B4, C4, D4. They all like cause pathogenesis of asthma. So we are trying to cut down on the mediators for asthma. Then I will use an IV line, a separate one, to give magnesium sulfate. Yes, guys, the same medicine that we use for management of eclampsia is being used even here, because magnesium is an antagonist of calcium. The rationale is magnesium is an antagonist of calcium, and calcium is required in the body for constriction of the smooth muscle. Magnesium is an antagonist of calcium, and calcium is required by the smooth muscle, which is responsible for bronchoconstriction. So if you will antagonize calcium, then you will not be able to cause a bronchoconstriction. So what magnesium will do is it will inhibit the development of bronchoconstriction. I repeat that again. We have smooth muscles in the airways. The smooth muscles in the airway will basically require a bronchoconstriction. I mean, they cause a bronchoconstriction, but for that calcium is required. If you antagonize calcium, then bronchoconstriction, whatever has happened has occurred, but it will not worsen. So we give magnesium sulfate for management of these patients. We don't use aminophylline. Earlier, when I was a student your age, at this point of time, it was aminophylline that used to be used, but now we don't use aminophylline. Aminophylline infusion is not recommended at all. Why aminophylline is not given? Because it increases the risk of arrhythmias. One of the risks that can occur is multifocal atrial tachycardia, or it can cause a paroxysmal supraventricular tachycardia. So aminophylline has been discontinued now, and what is given in its place is magnesium sulfate. If in spite of all the things the patient is still mum and is not responding to commands and is developing a bradycardia and there's a shallow breathing, I repeat my statement, patient is not responding, not opening his eyes, and there's a bradycardia, respiratory, he's breathing fast, but muscles of respiration are like tired. So there's a shallow breathing that is happening in a person. There's abdominothoracic breathing. That means the person is going into what I described earlier, that is impending respiratory failure. In this particular situation, if he says, what will you do? So all the treatment that I mentioned will continue, but now you will have to put the patient on a ventilator. So for patients of patients of asthma with imminent respiratory failure, patient has to be put on a ventilator support. If I summarize the information provided, I can say the following facts: that for patients of acute asthma, we shall be using LABA with inhaled corticosteroids. If it is going to be severe acute asthma, I'll be doing nebulization with salbutamol, give oxygen to the patient, attach it to the nebulization chamber inlet, give hydrocortisone max self to the patient, and sometimes if required as a sixth drug, which I can just mention as optional addition, is the sixth addition that I can add here is ipratropium bromide. Ipratropium is again an anticholinergic drug. It's a cousin brother of tiotropium that I was using earlier as a long-acting agent, but at the moment I need a drug which is not very long-acting. So ipratropium would be sufficient to be given in the form of nebulization. So this can be added to the ongoing nebulization of this particular patient. These are like the drugs which we use for management, and after my discussion you will notice that though you have studied pharmacology, but when to use SABA, when to use LABA is what I find students are always struggling. So I hope after this you'll be able to answer more accurately. And now I mentioned asthma which is so severe that patient can die at home. So for these patients of brittle asthma, you will be recommending to purchase EpiPen. Though a lot of them it's not available in India, so it has to be imported from abroad. This EpiPen is subcutaneous epinephrine that needs to be given. The subcutaneous epinephrine is EpiPen. It's not available in India most of the time, so you might have to get it imported through a chemist can do that obviously. So subcutaneous epinephrine, brittle asthma where attacks can be so severe that person can die at home, hyperparoxysmal attacks. So patient needs to carry a EpiPen, and whenever they have an attack, they can themselves take this subcutaneous injection. It is having an auto injector, so you touch it to the skin, it delivers epinephrine, so that bronchodilation will happen, and this will at least prevent the death of this patient from happening at home, or at least he will be able to seek medical advice. Next, I'll describe a case scenario to you of a 25-year-old guy. He had a bike accident and is admitted for polytrauma. There's a respiratory distress on day 3 and he's having a drop in oxygen saturation as well. And you notice that the patient's blood pressure is falling with prominent neck veins. Because in this question, prominent neck veins is given, that means right ventricle of the patient is failing. And this means that there must be some clot that would have developed in the legs of this patient, because he is hospitalized for 3 days. So the guy is having deep vein thrombosis. And because of deep vein thrombosis, there are clots developing in the soleal veins, and these clots ultimately got like dislodged from this area, and they went into the right side of the heart, and they are blocking the pulmonary artery, contributing to right ventricle failure. So the diagnosis of this particular patient is not fat embolism. It would be given as pulmonary embolism. Fat embolism is based on GERD criteria that I'll just explain to you in a couple of minutes. But every time they give you a trauma case, don't assume that it is fat embolism. Check out if there is a feature of right ventricle failure given and hypotension given, because if that is the case, it's gonna be a pulmonary embolism. In fact, in the exam, they can also give you a CTPA, which is the investigational choice for this condition. You can see here anteriorly placed is the ascending aorta of the patient. This AA is the ascending aorta. This is the descending aorta. This is the pulmonary artery in the middle, and you can see a big clot bang in the middle of the pulmonary artery, which is preventing the blood from going forwards. You can also see at this moment, this is the bronchus. This is the bronchus. This posteriorly is the esophagus of the patient. So this is a very like a famous image that is repeated in your paper, where there's a big clot present in the pulmonary artery. And where did this clot come from? It came from the legs of the patient. He can also, instead of asking you the diagnosis, say that for suspected case of pulmonary embolism, what is the first investigation that you'll be writing for this patient? So the first investigation or screening test that I will be doing would be by the name of D-dimer assay. The test that I'll do is by the name of D-dimer assay. D-dimer is a test that helps you identify that there are clots which are present in the body, or tendency to form clots is there. If he says what is the non-invasive test to identify the cause, he's asking you regarding what will you do to identify the deep vein thrombosis. So your answer will be, I will be using Doppler of the extremities, and on Doppler of the extremities, the finding will be non-compressibility of the veins. Normally the veins can be compressed, but in this condition veins cannot be compressed because there's a big clot present. The investigational choice for this condition is CTPA, that is CT pulmonary angiography, that can show an obstruction in the pulmonary artery. Now, what is the treatment of choice? The treatment of choice is to destroy the clot, which is occluding the pulmonary artery of the patient. So we will be giving L-teplase to the patient. Along with L-teplase, an additional thing that I'll be using is heparin, that is unfractionated heparin, or I can even use like low molecular weight heparin like enoxaparin to prevent the further propagation of clots in the legs. Now, I have destroyed the clot in the pulmonary artery, but a new clot can develop in the legs, and that can come up again in the heart. So to take care of the deep vein thrombosis, I also need to give to this patient either the plain heparin. Plain heparin is written as UFH, unfractionated heparin, or enoxaparin, that is low molecular weight. The advantage of low molecular weight heparin is it needs to be given once a day. But the main treatment for this guy, if you want to increase the blood pressure, the BP was crashing, then the main drug that is given for this condition is L-teplase. This is like the drug of choice or the main management that we do for a case of massive pulmonary embolism. If it is chota clots, if it is submassive pulmonary embolism where small clots are there, then small clots will not block the pulmonary artery, then I don't need to give L-teplase. L-teplase is given only when you have this big clot present in the artery. And how do you know it is a big clot or a small clot? Check out the blood pressure values. If in the question the BP value is given to be less than 90 by 60 millimeter of mercury, you would be giving L-teplase. But if it is submassive pulmonary embolism where BP is like recordable, then you will say that I'll be only giving low molecular weight heparin or plain UFH to the patient. I've not written UFH at the moment because like it's already written there. So the main objective is heparin based derivatives would be used for submassive pulmonary embolism / pulmonary embolism. Lot of MCQs will skip the word submassive. If you read a question that simply says the word PE, that is pulmonary embolism, then answer is heparin. But if he specifies the word massive pulmonary embolism, that means a big clot bang in the middle of the pulmonary artery, then you need to be more aggressive and you will say two things. I will give enoxaparin plus L-teplase to be given. Parameters to be checked to identify the question would be like Homan sign. Meaning of the word Homan sign is that when you will be doing ankle dorsiflexion, it will be contributing to pain in the calf of the patient. I mean, one of the tests that we always do is ankle dorsiflexion in suspected case of deep vein thrombosis. If ankle dorsiflexion causes development of calf pain, it means that the person is having deep vein thrombosis. That's the sign of deep vein thrombosis. The echocardiographic evidence would be clot going in the pulmonary artery of the patient. The Doppler evidence would be like the flow in the soleal veins will be affected. But the main thing is clinical part is Homan sign if given makes it easy. Or like the BP is crashing, that's again an important aspect because this is an example of pulseless electrical activity. Or he may mention echo findings of a dilated right ventricle. The dilated right ventricle may be also written as cor pulmonale or acute cor pulmonale. Instead of writing the word dilated right ventricle, he may write the word acute cor pulmonale. That's like one of the terms that is again a question by itself. What is cor pulmonale? So it is a non-cardiogenic right ventricle failure. The meaning of the word cor pulmonale is right ventricular failure due to non-cardiogenic cause. At this moment, I can say that in this particular video, I've said non-cardiogenic word 2 times. One, I've taught you non-cardiogenic pulmonary edema. That is going to be ARDS, and now taught you non-cardiogenic right heart failure. That is acute cor pulmonale due to pulmonary embolism. Guys, in cardiovascular system, I've taught you most common cause of right ventricle failure is left ventricle failure. So normally right ventricle fails due to left ventricle failure, but at the moment it is non-cardiogenic cause because there's a clot now. There's a clot in the legs that went into the heart, from the heart into the pulmonary artery, and is physically blocking the pulmonary artery. Imagine if your pulmonary artery will get blocked, the poor right ventricle will fail. But this right ventricle failure is not due to left ventricle failure. It is due to a non-cardiogenic cause. So that's why I use the phrase acute cor pulmonale in this patient. The BP will crash because blood will not go in the lungs. If blood will not go in the lungs, nothing will come to the left side of the heart, and that's why the blood pressure begins to crash. So I have to give Elteplase to destroy the clot. I need to give a clot buster medication. The clot buster medication will destroy the clot. The blood supply to the lungs will start once again. This is one of the highly neglected topics that is always asked in the exam, that is pulmonary embolism. Now, there are a couple of common errors that I would like to mention here. Like this is an FMG exam question. He mentioned a patient of colorectal cancer. Cancer is a hypercoagulable state. Cancer is a hypercoagulable state. By default, if cancer is present in any patient, then the risk of deep vein thrombosis in the patient will increase. Here, the patient was undergoing surgery and there's a sudden drop in EtCO2 in a patient. The question said, what is the probable reason for this? Then the probable reason is that this guy was having again clots in his soleal veins, and these clots in the deep veins or in the soleal veins, they went up. They occluded the pulmonary artery of the patient, and if the blood supply to the lungs will go, then the EtCO2 the patient will drop to 0, because if there's no oxygen delivery, there's no carbon dioxide produced in the body. So the answer in this question is option number C. Though in the lot of recall sessions this was discussed by anesthesia people, but it's a hardcore general medicine question that cancer is a hypercoagulable state. Cancer is a just like you are comfortable, pregnancy is a hypercoagulable state. Similarly, like colorectal cancer is a hypercoagulable state. So pulmonary embolism, like most of the time for pulmonary embolism aspect, triggers would always be given. Triggers can be any one of the following. Like you can say after delivery, a lady was having cough pain and then subsequently she had breathing trouble. Or he can mention cancer surgery. He can mention cancer, or he can mention cancer surgery. In fact, both of them are like a double insult. No, cancer is a hypercoagulable state, and after surgery, like patient will be debilitated and they can't walk immediately. So immobilization again results in development of cancer. Then triggers can be in the form of long distance flight, nephrotic syndrome. This was INICET question where he incorporated nephrotic syndrome, OCPs, and even long distance flight like from Bengaluru to San Francisco, about a 18-19 hour flight non-stop to America. So if a person is sitting on a chair for like very long distance or very long time, the long distance flight would again contribute to deep vein thrombosis. So if any one of these triggers are given in a question and then he starts saying that the blood pressure of the patient begins to fall, or he says that the JVP of the patient is elevated. I mean, right ventricle failure is occurring due to a non-cardiogenic cause here. Clots are developing due to the reasons present here. Like in this case, the first line itself was like a trigger for you to think that, oh man, this is deep vein thrombosis risk increased in a person. And then subsequently remaining things are obviously to be understood that intraoperatively, you can't check intraoperatively JVP. Intraoperatively, you can't check out the status of the heart sounds of a person. So it's a parameter that you can check on the capnograph recording, that is EtCO2 that is dropping. So this is like a question where people answered varied, things, but it's like a pulmonary embolism case. And now is a guy who had a bike accident. He's admitted due to polytrauma. The third day, you can see that he's having like desaturation. He's becoming unconscious and unresponsive. Previously, none of the cases became unconscious, unresponsive. Vitals are stable. Still, the guy is unconscious, unresponsive, and there is petechiae noted in the chest wall because this is a case of fat embolism. In fat embolism, the cytokines which are produced will cause damage to the microcirculation of the brain. It will cause damage to the microcirculation of the lungs, and it will cause development of petechiae in the axilla area and the chest wall of the patient. If you get these manifestations written in any question after trauma, the trauma cases, bike accident in this case, and on the first day, second day, third day, sometimes can be as late as third day also. So, I mean, yes, fat embolism usually occurs early by 24 to 48 hours, but can be sometimes delayed also. So, don't go by days. Don't go by days. They will teach you that fat embolism occurs only after 24 hours. No, man, it can occur at 48 hours also. It can rarely occur after 72 hours also, because the fat globules will cause cytokine production, and the cytokine production will take some time. It is not the fat globules going in the brain, it is the cytokines which are produced there which are causing damage. It is a cytokine induced damage to the brain, blood brain barrier, and that contributes to a cerebral edema in this patient. It is cytokine induced damage to the capillaries of the lungs. So in the x-ray, the white spots can be present, that is in the form of like miliary shadows, and then there would be petechia that would be developing, so that is fat embolism. In fact, the criteria that are used for diagnosis of this condition are called as GERD criteria. The mortality rate for fat embolism goes up to 50%. And this would be like commonly seen after 24 hours of a trauma case, but can be seen as late as about 2 to 3 days. And what you need to pick up is any one of these: brain issue, lung issue, petechia. They are the main things. Axillary petechia, hypoxia at FiO2. Instead of writing like, like mentioning chest x-ray showing infiltrates, it is like hypoxia, PO2 less than 60 with FiO2 0.4, with development of non-cardiogenic pulmonary edema. This is also like, cytokine induced damage to the capillaries of the lungs, so it will cause a non-cardiogenic pulmonary edema. And then there could be like CNS issues, that is patient will become unconscious. There can be hemoglobin fall that can happen also. But like in the updated GERD criteria, they don't include the sudden drop in hemoglobin, because there are different versions of the GERD criteria that are available. But what you have to remember in the major criteria are, I'll say again, the major criteria will revolve around one, the involvement of the brain. That is, the person will become unconscious. Like in this case, unconscious unresponsiveness is given. The second feature is the lung involvement in a patient, which are described as in the form of desaturation, PO2 less than 60, SpO2 falling in a patient in spite of giving 40% oxygen to the patient, contributing to non-cardiogenic pulmonary edema. So that's the second one. And the third one that is present is a CNS depression in a patient. So in fact, when I put the arrows for this condition, I'll just highlight the pointers once again, guys. The first point here is axillary or a subconjunctival petechia. Second is the lung issues, that is hypoxia. This can be written as he can write the word snowstorm appearance on a chest x-ray, that is one. Or he can just say like multiple white spots or pulmonary infiltrates that are seen. I mean, instead of writing snowstorm appearance, which is very characteristic, he may say pulmonary infiltrates noted in the chest x-ray of a patient. Or he will say desaturation, SpO2 decreasing, or PO2 less than 60 with FiO2. You are giving oxygen, still the saturation is falling, because there is a cytokine-induced damage to the capillaries of the lungs, that is the alveoli, which is surrounded by capillaries. The capillaries are injured. If capillaries are injured, fluid will leak, and that will cause a non-cardiogenic pulmonary edema. So this is the entire statement here for non-cardiogenic pulmonary edema. And the third important major criteria, central nervous system depression. In some of the older criteria, that drop in hemoglobin was also considered, but you need to remember in the updated criteria, three data that I mentioned: brain involvement, lung involvement, and petechia. Major criteria if present in a patient, along with couple of minor ones. Minor ones can be urinary fat globules, high elevated ESR, pyrexia in a patient, or like thrombocytopenia. Like thrombocytopenia, the petechia part is included as the major criteria, and the thrombocytopenia word is minor criteria. Again, take a note of that. Petechia, physical examination finding is a major criteria, thrombocytopenia is a minor one. So couple of these are major and minor. You need one major with 4 minor. Ideally, for diagnosis of this condition, you need one major with 4 minor, but he says you don't need to be rigid with these criteria, because if any one is also present, like, the patient is becoming unconscious, and at the same time there is like pulmonary infiltrates happening. If the major two of them are present, I'll say, okay, man, I'm considering fat embolism in a question. The most important thing is fat embolism, BP will not crash. If they give you crashing of blood pressure or crashing of EtCO2, if they give you a question in which there is a crashing of blood pressure, like 90/60 in this particular case, you can see the blood pressure was outrageously becoming low. That's the cause of concern. Hypotension, right ventricle failure, that's the kind of data given. Pulmonary embolism. If the blood pressure is not crashing but person is unconscious in PTK, then it is pulmonary embolism. Time frame is not a differentiating factor, or he can give intraoperatively like he gave in the paper, and this was like hemicolectomy being done, and after that the person is deteriorated with drop in ECTO2, drop in drop in the value of end-tidal CO2. EtCO2 value should always be maintained at 35 or more than that. Next, I'll mention some miscellaneous facts here, which are pretty straightforward ones. They have given these images where the students of mine said that they could see irregular breathing. You can see that the depth of breathing is varying every time. So this irregular breathing is what is called as Biot's breathing. Whereas in Cheyne-Stokes breathing, you will notice a very characteristic pattern. The pattern is that initially, like, there is a hypoventilation. This hypoventilation is followed by apnea. Now, due to this apnea, there is buildup of carbon dioxide in the body. Due to buildup of carbon dioxide, the person will start hyperventilating. And then once again in the person, hypoventilation will occur, that are shown in color blue, followed by development of apnea, that are shown in red. And once again, there's a buildup of carbon dioxide in the body. So person will hyperventilate. If you look at the pattern, you will notice that what I've shown here is hypoventilation. After hypoventilation, I have shown apnea. And after that, I have shown hyperventilation. So this pattern, if it is present, hypoventilation, apnea, hypo is in blue, apnea is the red straight line, and the hyper is the black one, then you will say person is having Cheyne-Stokes breathing. But if it's going to be irregular breathing, then we will say it's Biot's breathing. Both of them are seen in patients of raised ICP. So when the question came in the paper, a lot of guys casually answered Cheyne-Stokes breathing, but they did not realize that raised ICP can contribute to both of them. So you have to answer on the basis of the information provided. Though Cheyne-Stokes breathing is something that can be seen not only in raised ICP, but can be seen in even heart failure. It can be seen in high altitude pulmonary edema, and sometimes in some people in deep sleep as well. Biot's breathing is brainstem damage and morphine poisoning. Then is prolonged inspiratory spasm. This apneustic spasm, this apneustic breathing that you are seeing at the moment, this is what is called as a prolonged inspiratory spasm. This is due to injury to the lower pons. This is physiology, but still should be remembered, prolonged inspiratory spasm. The reason is damage to the lower pons, which causes damage to the pneumotaxic center, and thereby there is like this prolonged inspiratory spasms happening in a person. Small breathing is fairly straightforward. Metabolic acidosis, the mnemonic for that is CULT, ketoacidosis, uremia, lactic acidosis, and toxins. So the message is, I mean, all the cause, like every time you read metabolic acidosis in the ABG report, if he will begin by theory, he might give you situation of ketoacidosis. Ketoacidosis could be like starvation or could be diabetic. Then is uremia. He can write the word acute kidney injury, chronic kidney injury by default. I mean, metabolic acidosis occurs in kidney diseases. He can write terms like acute tubular necrosis. L is for lactic acidosis. That could be due to drugs like fenformin or metformin. And T would be due to toxins like methanol poisoning, or toxins could be in the form of like ethylene glycol poisoning, that is the cough syrup that was contaminated. No, like recently there were deaths in India and Madhya Pradesh because of contaminated cough syrup. So what was present in that cough syrup was this product ethylene glycol, and this causes metabolic acidosis and can cause death. The antidote for this is fomepizole. But in all of these questions that I've written for CULT, ketoacidosis, uremia, lactic acidosis, toxins, you will notice that pH, PCO2 and bicarbonate, all three will be falling. In all the causes of CULT, by default, like in the ABG report, I'll write it and erase it because this is discussed in the earlier part of the discussion. Then pH, PCO2 and bicarbonate, all three values would be falling. So these are like the meaning of the word CULT is ketoacidosis, uremia, lactic acidosis, and then the toxins component. Once again, just for reference sake, all three values will be down, down, down. I've already explained to you how to interpret metabolic acidosis. Now comes the aspect of acute mountain sickness, for where the hypoxia that is present is called as hypobaric hypoxia. It's not hypoxic, it is hypobaric. If it is acute mountain sickness, whether he says the word acute mountain sickness, high altitude pulmonary edema, or cerebral edema, in all of them, first intervention is always immediate descent in a patient. Like in FMG exam question, he had mentioned saturation of the person is dropping. What is to be done apart from descent? So we can be putting the patient in a Gamo bag. Gamo bag can simulate high atmospheric pressure. We need to give oxygen and we need to give nifedipine to the patient. Then answer is not acetazolamide. In acute mountain sickness, if saturation of the patient is maintained, then we just have to do a descent and we can give low flow oxygen with acetazolamide or Dexona to the patient. If the saturation in the MCQ is given to be normal, then it is okay. You can just ask the patient to go down, descent, and like take supplemental oxygen and additionally either acetazolamide or Dexona. But if saturation is falling, then your main answer is nifedipine to be given to this patient. And if there is altered sensorium, if the GCS of the patient is also falling, then I need to give Dexona to the patient. So immediate descent, Gamo bag and oxygen is universal data. Immediate descent, Gamo bag and oxygen is a universal data. It is nifedipine, not nimodipine. Nifedipine is the drug of choice for high altitude pulmonary edema. Dexona is the drug of choice for high altitude cerebral edema. If saturation is persisting, which is very, very unlikely, then it's gonna be like just descent to wherever the symptoms first started. I mean, it's not go back to Delhi, like just from wherever, like 1,000 meters below where symptoms started occurring, person needs to descend there. Then chronic mountain sickness would be seen in like Tibet or like in people of Leh and Ladakh. These are like high altitude areas, and person who would live at high altitude will start developing hypoxia. That hypoxia will cause excess erythropoietin production, and because of that excess erythropoietin, the RBC production in the body of these patients will increase. If RBC count will increase, the flow of blood will become sluggish. RBC count is about 5 million, 50 lakhs per cubic millimeter. If it will increase tremendously, it will cause sluggish circulation. It will cause pulmonary artery hypertension and digital clubbing in a patient. So chronic mountain sickness is what is called as Monge's disease. Chronic mountain sickness is what is called as Monge's disease. It causes pulmonary artery hypertension and digital clubbing. But if person like you and me goes to high altitude, then it is hypobaric hypoxia with the drug management that I've said. Acetazolamide is mainly used for prevention, can be given in mild, moderate, acute mountain sickness where saturation is normal. If saturation is dropping, then it is the answers as I've currently explained to you. Then they always give up questions on central sleep apnea, obstructive sleep apnea, and obesity hypoventilation syndrome. How to pick them up? If in the MCQ ABG report is given, in the ABG report, if he's mentioning that the PCO2 of the patient is elevated, like at daytime, the ABG of the patient was done, in the patient, the pH was less, PCO2 was elevated. At daytime, if carbon dioxide is more in the body, that means this guy is having obesity hypoventilation syndrome, which was formerly called as Pickwinian syndrome. This is due to extreme amount of fat in the chest wall of the patient. Here, the cause is not like collapse of the airway. In patients of obstructive sleep apnea, there is a collapse of airway, but the person of obesity hypoventilation syndrome will be having respiratory acidosis. So a lot of questions which will be given to a fat person with snoring will also mention respiratory acidosis in an awake stage. If respiratory acidosis is present in an awake stage, then don't answer obstructive sleep apnea. Then answer as obesity hypoventilation syndrome, and management here is BiPAP. It is called as Pickwinian syndrome. In obstructive sleep apnea, there would be loud snoring, collapse of the airways, but daytime PCO2 will be normal in this condition. Along with that, concomitant hypertension and infertility or erectile dysfunction can develop. You manage the patient with a CPAP. And for central sleep apnea, it is called as Ondine's curse. That is when the person will sleep. That is when the respiratory drive will decrease. Though lots of time, central sleep apnea can be seen even in patients who go to high altitude. But otherwise, it could be stroke, heart failure, and opioids among the pathological causes if you ruled out high altitude in a patient. Here, it is lack of respiratory drive in the sleep, which causes hypoventilation. We call it central sleep apnea. It is like, there was used to be a story of a king who was cursed by a monk that if you will sleep, you will die. So he used to remain awake, but one day the sleep overtook him, and when he slept, he died. That was Ondine curse. It can be seen with stroke because the pacemaker of the respiratory center is getting affected. It's the pre-Butzinger complex in the medulla that's getting affected. So central sleep apnea is easy to identify, that there would be no respiratory drive described in sleep. There would be no snoring described in the question. But if it is snoring with the collapse of the airway, and along with that hypertension, erectile dysfunction, but no respiratory acidosis at daytime, then it is OSA. And if it is an obese person, no snoring, no snoring, or snoring can be given. But if respiratory acidosis is given, this again guys was asked in not NEET PG FMG, obesity hypoventilation syndrome, right? I mean, students are crying after the paper ki sir matlab they made it difficult. I agree, they should not be asking this in an FMG exam. It's a screening exam. They should not be asking this. They can ask this in NEET PG, understandable. That's totally wrong. But पूछा है तो पूछा है यार, like at the moment we have to take a bouncer on the chain वाली बात हो जाती है कि अब ठीक है तो भाई I'll mentally prepare myself to that level कि भाई अब पूछ के देख, right? I'll answer that correctly. So after this I hope it is clear that if respiratory acidosis or ABG का report दिया है ना अगर, and these are the options given, answer, and CO2 is elevated, I mean that you will be able to pick up. Answer is Pickwinian syndrome as obesity hypoventilation syndrome. The flow volume curves, I've already explained to you that initial curves are normal, but you can see a concavity. So I will be writing the word obstructive pattern for this one, obstructive pattern. On the other hand, if the curve is very narrow, this narrowing is because the lung capacities have become lesser. So this is a restrictive pattern that is occurring. Restrictive pattern would be like a person having interstitial lung disease. It could be non-specific interstitial pneumonitis that is described. Then I would like to describe a patient who's having tracheal stenosis. In tracheal stenosis, like prolonged intubation is the cause. You will notice that there is a flattening of the curve on both of the sides. This flattening of the curve is due to tracheal stenosis, that less air is going in inspiration, less air is going in and expiration also. So it will be called as a fixed central obstructive defect. That fixed obstruction is because there is no change in the level of obstruction in both inspiration and expiration. Next, I want to describe a patient who's having a retrosternal goiter. Retrosternal goiter में क्या होता है? The goiter will move down because of inspiration. When goiter will go down because of inspiration, because here inspiration is नीचे and expiration is ऊपर. So when the goiter will go down due to inspiration, because inspiration will cause negative pressure, so goiter will press on the airway of the patient, and thereby there is a flattening. But during expiration, the pressure on the airway will go away, so the curve will take a normal shape. So this particular description that I mentioned is again a obstructive airway disorder, but it is a variable obstruction, that the obstruction is present only in the phase of inspiration. I'll say again, retrosternal goiter, inspiration, the goiter moves down, and when it moves down, it will compress the airways of the patient. If you squeeze the airways, then less air will be going in. That is why in the curve you can notice the flattening happening in the curve. And now when expiration will happen, the gland will move up, the pressure on the airway will go, and the shape maintained will be normal. So what I want to say is that the one that I've currently marked at the moment, I will be calling it obstructive airway disorder because the word is tracheal stenosis. Stenosis means obstruction, but it is a fixed obstruction. But for retrosternal goiter, I want to say that the obstruction is only in the phase of inspiration, when the gland will go down and press on the airways and the obstruction will go away. So I will say the word variable obstruction in this case. So if you look at the report here, the first two reports in the patient are like normal. In the second report, I can say slight concavity is happening, and that has got accentuated. So I can just say that both of these reports that I've shown is that of obstruction only. It is, both of these reports are of obstruction only. The only difference is as far as the magnitude of obstruction is concerned. And to assess whether it is asthma or COPD, these graphs will not tell me. I will have to repeat the test after giving bronchodilator. And if I notice that the concavity becomes lesser, like let us say, hypothetically speaking, this is the initial curve of the patient. This is the first curve. And then subsequently, after giving bronchodilator, the curvature or the concavity is becoming lesser. That means it is suggestive of a reversible airway disorder like bronchial asthma. Obviously, percentages have to be calculated, but I want to say that both of these graphs are showing a variable level of obstruction present. If the total curve is squeezed, like if you look at this one, you will notice that if I just mark it here, right? I mean, if you look at the yellow markings here, then the total area under the curve is substantially reduced. Compare this with the area under the curve. No, I mean, you are having very good surface area under the curve for inspiration. You are having very good surface area under the curve for expiration component. So, I mean, if the surface area is lesser, then I can say there's a pulmonary fibrosis that is occurring. So these shapes are like, I would say, literally self-explanatory, and even these technicians are able to answer. So you and me would be able to do this job. Just hand draw this a couple of times and like maybe once or twice, and you'll get a hang of the information that I mentioned. Both sides flattening, fixed obstruction, one side flattening, variable obstruction. And if the graph is totally pichak gaya, squeezy, right, squeezed, then it's an unrestricted pattern that is occurring. And if it's a concavity, it's an obstructive airway disorder. So fairly straightforward inputs. Okay, guys, so towards the end, we have some data which is an overlap from pathology as well. In whole of pathology, you will read past positive inclusions 2 times. The first time you're going to read that word is with respect to the topic of alpha-1 antitrypsin deficiency that is on the slide. And second is what I've described in the GI part also, that is going to be Whipple's disease. So every time you read a question saying past positive, that purple colored inclusions inside the hepatocytes, it's going to be alpha-1 antitrypsin deficiency. And if I change this data and I say past positive inclusions, but I say they are present in the macrophages inside the lamina propria of the GI tract, then your answer is going to be given as Whipple's disease. Having said that, the common misconception that most guys have is that in alpha-1 antitrypsin deficiency, it is not produced. No, guys, it is produced, but it is not excreted out of the hepatocytes. That is why we can see inclusions inside the hepatocytes of the misfolded alpha-1 antitrypsin protein. Now, what is the function of this protein is that it is responsible to neutralize elastase. What is elastase? That destroys the elastin component in the connective tissue of the lungs. Remember emphysema? Like, the air quality index in India is so bad that due to pollution, people could be having damage to their lungs. But what protects your and my lungs from that elastase that is released from the macrophages of our lungs due to pollution is alpha-1 antitrypsin. In this particular condition, because it is not going to be released, so therefore elastase is going to have a free run and it will cause extensive damage in the lung, resulting in pan-acinar emphysema. So every time you read alpha-1 antitrypsin deficiency, there are 2 things that would be coming. This time the question will not begin with like a 50-year-old smoker. He will say young guy with COPD findings. That's going to be like hyperinflation in the chest, or he could give an X-ray in which flattening or diaphragm could be given. And he will say that when this patient was a child, that is when he was a little baby, there was neonatal hepatitis, and this can progress also. I mean, there could be development of cirrhosis and hepatocellular carcinoma. Just like in Wilson disease, you have chronic hepatitis, but in the long run, there could be damage to the liver as well. As far as the genetics is concerned, you need to remember 2 facts, 3 in fact. One is the gene. I mean, this is ratification, SERPINA gene on chromosome 14, and the phenotype which is going to be telling us that there is a pathogenicity is PIZZ. There's a couple of other types of genotypes that you can read in pathology like PIMM, which would mean that the patient is perfectly fine. But especially when I speak regarding alpha-1 antitrypsin deficiency, what I want to bring to your attention, guys, is 2 facts. That this particular question, if it's ever asked to you, it would always be like a non-smoker, and he'll talk about a relatively younger patient presenting with findings of COPD pan-acinar with when he was a child, then there was developmental liver damage as well. Now I'll speak about some spotters which they love to ask. One of them on the slide is that bronchiectasis, and you can notice the very classical tram track appearance. Just like you guys are comfortable with tram track appearance with respect to kidney biopsy, that would be a membranoproliferative glomerulonephritis, or a tram track appearance on a CT head that are described in neurology, that's a neurocutaneous disorder. In the same spirit, what I want to bring to your attention is tram track appearance if described for a HRCT chest is going to be bronchiectasis. And the highlight this was asked in FMG exam was like, what's going to be the profile? So it's a purulent bronchoria that varies with position, because you see what you mean by bronchiectasis is destruction and dilation of large airways. So that large airways are filled with pus. Now when patient will bend forward, then the positional change in the bronchoria amount can be present, which is one of the highlights of this condition. In the second X-ray, you can notice that crazy pavement pattern. This crazy pavement pattern is seen in a condition in which you have a surfactant turnover being less. Traditionally, when you read about surfactant, it's always about hyaline membrane disease. But today, I'm not talking about surfactant deficiency, guys. I'm talking about a condition in which the turnover of the surfactant is relatively lesser. So surfactant will accumulate in the lungs. And this is going to contribute to chunky gelatinous sputum plugs being described in a question. And on the CT scan, the finding would be crazy pavement, which is seen with respect to pulmonary alveolar proteinosis. The condition PAP results in always an X-ray finding of a snowstorm appearance. But when we do a CT scan, which is the best test for parenchymal lung disease, we'll be able to see the crazy pavement pattern. The highlight is decreased surfactant turnover. And then is the concept of tree in bud appearance, which would be related to endobronchial tuberculosis. Tree in a bud would mean like if you look at this appearance, like the tree will keep on budding and will keep on increasing in size. So if I zoom into the image, you will notice the train the bud appearance, which I superimpose here, or I can just highlight it once again. That would be endobronchial tuberculosis. So TBs, I mean, there are a lot of causes, guys. There are a lot of causes responsible for the manifestations of train bud appearance, including pneumocystis jirovecii. But I specifically wanted to focus on the one that you can see at the moment, that is endobronchial tuberculosis. So these are a couple of important CT findings that you should be knowing about. And then is the traditional X-ray findings. So a quick recap, I'll just take 1 minute into it. And this is something that, you know, in respiratory system, if you say like, I have 1 minute, what should I revise in respiratory system? These are the findings. You know, eggshell calcification, two disorders where you will always read it as silicosis and sarcoidosis. Silicosis will obviously be like a male patient, and he'll be working in industry like rock blasting, sand blasting, glass industry. And then is going to be the aspect of this sarcoidosis, which is going to be a young female, and this time he will mention elevated ACE levels. And because there's a hilar lymphadenopathy, so as a result of this hilar lymphadenopathy, guys, what will happen is that there would be obstructive airway disorder, there would be difficulty in breathing. So every time you read a question, young female, shortness of breath, bilateral hilar lymphadenopathy, and ACE levels being elevated, it is sarcoidosis. And sarcoidosis, as you know from pathology, has a non-caseating granulomas that can synthesize vitamin D as well. And because the treatment of choice for this condition, as you are aware, is administration of, we give steroids, so it's a steroid responsive hypercalcemia. Then is snowstorm appearance, very classical. Even if you apply for like a non-academic JR shape, you will get, they give you an X-ray in the interview, and they say beta, like, you know, can you tell me the findings? So it's gonna be, the causes of it, that's miliary TB, silicosis, fat embolism, and pulmonary alveolar proteinosis. Then again, like I would say, standard bread and butter information that we should be remembering. And the last part that I'm saying is an FMG exam question, cannonball meds. The fourth option, and this was very interesting, aspergillus. It was so funny, students were laughing, sir, fungus thodi na X-ray mein dikhai dega. For that we need to do a CT scan. No, aspergillus fumigatus will result in a, aspergillus basically grows in pre-existing lung cavities. So to see a fungal ball, mark my words there, to see a fungal ball in a chest X-ray is not possible. We need a HRCT chest for the same. So it is choriocarcinoma, which causes cannonball meds. Then renal cell carcinoma, it has a hematogenous dissemination, and carcinoma breast. So these are a couple of details, guys, which I thought I should just mention before you. So we are sorted for the respiratory section, and yep, I can say at the end, stay humble and keep working, keep hammering, and you will do great in your careers. It is just the persistence to show up every single day that really, really matters. I'm really happy that you made it towards the end of this video. So take care. God bless you.